with a phone call from our beloved friend, the anywhere and everywhere, Dr. Rajiv Raman. Subarna, are you ready to organize a conference over there in Tamluk? And I told, why not? I talked to our Tamluk Ortho Club with full enthusiasm. Dr. Arnav, Jana, and others with full enthusiasm, why not, we will start. And this is the first ever orthopedic as well as arthroscopic meeting in Tamluk. So again, our orthocare team contacted us. They also had a full enthusiasm, especially Mr. Ritobroto, and we started our planning. And ultimately, this is the day we were waiting for. We are planning for 4 live surgeries and 3 workshops and many lectures. Our esteemed faculties are here. Our teachers, we started our orthopedic life. Those teachers are also here. Our friends are those who are now stars in all India level, sometimes in international levels. They are also here. So, this is a fantastic academic feast we are expecting from all the faculties and all the delegates also, because they are enthusiastically coming and they will be enjoying the whole program. This type of conference should continue, because we are here, we should not be continuously in practice only. This type of continuous medical education progression system we should continue, and I expect my Tamluk Ortho Club and our other members to further continue this type of program in near future, and I will request all the faculties will keep this type of warming and helping relations with us in future, so that we can continue this type of program in future like that. Thank you. We start our program. We will try to be in time. So please start.
Thank you, Subarna sir. Now I take the opportunity to invite Dr. B. Sharkar sir, the President of Tamluk Orthopedics Club. Please sir, come and inaugurate this session.
Welcome our delegates, faculties, non-medical persons, and also our trade partners to this auspicious arthroscopic gathering held at Tamluk. As the President of Tamluk Ortho Club, I genuinely appreciate your graceful presence. Tamluk is a historical place. Tamralipto port was very famous on that time. One part of Shoti, Ma Uma, among 51, is here. This is the place of Shohid Khudiram Bose, Birangana Matangini Hazra, and many others freedom fighters. We know a famous Bengali poem called Chora, Chele Ghumolo Parajurolo, Dhan Purolo, Pan Purolo, Khazna Debo Kise. This is the place of pan, very high quality pan exported from Tamluk to many other countries. We value your contribution in the field of orthopedic, and this place, many famous people came here like Huang Shang, Sri Chaitanya Mahaprabhu, today you. I appreciate your presence, and your presence taking our brands forward and together, and it reach at higher level in future. Again, I wholeheartedly welcome you all to make this program a grand successful one. Thank you. Namaskar.
Thank you, sir. Now we proceed with the program as scheduled. So we have the first workshop, which is the ACL tunnel, hands-on. So I would request the osteocare team to come and proceed with the
tunnel and tibial tunnel. Usually we do error in femoral tunnel mostly. So we have to thoroughly think about and know about the femoral tunnel placement. So marker ache?
हाँ जेल बेंच first you should position the knee. Position is also important while doing this. Is a bone model, but when you are doing a live surgery, that time knee should be flexed as much as possible, usually 120 degree, and that time you can see the condyle medial portion, and then you can proceed.
So we should think beginning with the femoral tunnel. So this is the femur and femur, tibia and knee. So obviously this is medial side, and going by the tibia this is lateral side. So I am dislocating the patella for convenience. And most of the steps are in 90 degree of flexion, except few steps like femoral tunnel drilling and other things. So coming to the femoral tunnel.
एक प्रोब ले लीजिए ना, प्रोब से मार्किंग करें.
Is it there? Yeah.
This is femoral tunnel placement, ideal placement of femoral tunnel during ACL reconstruction.
Hello. So it's a tunnel placement in ACL reconstruction. Okay, one of the commonest surgery in arthroscopy. So first we will deal with tibia tunnel, okay? Hello. So tibia tunnel, okay? So we have to mark few important points, like this is the tibial. What is this? So tibial spine. So this is lateral meniscus. This is actually faulty. This the tibial lateral meniscus comes like this. It goes like this. Okay. So this is the lateral meniscus attachment, and medial meniscus is almost like this. Okay. So where will you place your jig? Tibial ACL jig. So there are two types of jig. One is footprint jig. Footprint jig, just you have to place the jig over the center of the footprint, and you should aim the guide wire or bait pin to the center of the previous ACL footprint or remnant of footprint. So that is very simple. But what about other jig? There are other jigs also. So there are the shoulder aiming jig and tip aiming jigs. So in that case, where will you place your guide wire or bait pin? Suppose it's a shoulder aiming jig. So this is tibial tuberosity, tibial spine. This is the medial of the tibial spine, and this is lateral of the tibial spine. PCL attachment comes like this, ऐसे करके. Suppose यहाँ तक आया tibial PCL tibial attachment of PCL is like this, and suppose PCL is intact. So we have to think in terms of PCL attachment. We have to think in terms of condyle of the femur. We have to think in terms of while we will extend the knee, there should not be any impingement. So there may be impingement at PCL. You should visualize the problems if you do a tunnel placement at a wrong place. So it should not be impinging on the condyle, it should not be impinging with the PCL, and it should not be impinging with the roof of the notch. So what should we do? So this is PCL attachment, this is medial and this is lateral. So where will you aim your guide wire? It should be mediolateral में कहाँ कोথায় হবে? It should be sub 50-50 तुम्हें divide करो आगे. So this is medial, this is lateral. So somewhere this is the 50-50 point in mediolateral plane, isn't it? And after 50-50, you divide it in two parts, half-half, and you go 5 to 10% medial. Okay? So it's a 40-60 or 55-45. So you will try to be slightly more medially. 40-60, you aim 40-60 or 45-55. Okay? So one thing is clear, we will go slightly medially, suppose 40-60. Second is, where will you place in terms of anteroposterior placement? So we have few landmarks. One is posterior attachment of anterior horn of lateral meniscus. So if lateral meniscus anterior horn is intact, so this is one of the landmark. Second landmark is PCL attachment. So in terms of anteroposterior, your drill guide wire should come at the level of posterior attachment of anterior horn of lateral meniscus. It should be slight posterior to that. It should not be anterior. So tibial placement, tibial tunnel should not be anterior. You try to be on posterior side. If you do the error, do it on the posterior side, not on the anterior side. So suppose this is the posterior attachment of anterior horn of lateral meniscus. So we will go somewhere here. Okay?
So here also 40-60, sir?
No, slight anterior, slight posterior.
Slight posterior.
And in terms of PCL, so what will we do in terms of PCL? Which one PCL ache? So it should be around 10 to 12 mm anterior to the PCL attachment. Why? Otherwise, suppose your graft thickness is 8 mm or 9 mm, suppose 10 mm. So if you put this guide wire closer to the PCL, so what will happen? Later on it may cause impingement. Okay? So if you place 8 to 10 mm or 12 mm anterior to the PCL, so the radius of your tunnel will be 4 mm. So it will stay 4 mm anterior to the PCL attachment. So you will target at least 8 to 10 mm anterior to the PCL attachment. So clear? One is anteroposterior 40-60. Second is mediolateral 40-60. Anteroposterior you will guide in terms of posterior attachment of anterior horn of lateral meniscus and in terms of PCL attachment. So what will be the angle? এবার নিচে থেকে তো এখান থেকে যাচ্ছে তো এইখানে there is the third parameter that what should be the angle of your placement of the jig. 55. Usually it's 55. So এখান থেকে দিলে তামাম জিগের ইয়ে করতে হবে 55 সেট করতে হবে. And what about in this plane, the entry of the guide wire? কোথায় থেকে এন্ট্রি হবে? So it should be at least 2 cm, 2 to 3 cm medial to the tibial tuberosity, and at the same time it should be 2 to 3 cm at least. No, above the hamstring attachment. Okay? Or rather 5 cm above the hamstring, 5 mm above the hamstring attachment. So if you drill 4 mm, your hamstring will be intact. It will not injure your hamstring attachment. So hamstring attachment, in terms of hamstring attachment, in terms of tibial tuberosity, medial to the tibial tuberosity, proximal to the hamstring attachment, 40-60 of the tibial spine, mediolateral, anteroposterior in terms of lateral meniscus, posterior horn attachment and PCL. Clear? Okay. Now about femoral. Now about femoral tunnel placement. So you see, this is the posterior articular surface of the femur. So what we see regularly, we usually stay anterior to the posterior most aspect of the lateral condyle of the femur. So this is it's a behind. So you have to force your scope to see this part. Sometimes you need accessory portals. Okay. So first you have to define the posterior margin of the lateral femoral condyle, inferior and posterior. Okay, this is very important. Usually it is curved. Okay, it's not like flat, it's curved posteriorly. So whatever you are visualizing from the portal, anterior portal, it's a sort of the posterior margin of the lateral condyle. So it's a slightly curved posteriorly. So that is behind your visualization. So again, there are 3 points. One is anteroposterior, mediolateral, and the angle. Angle is also important. So where will you go? This is inferior, this is superior. So at what point you will mark your tunnel point? So that is anteroposterior. So suppose this is intercondylar ridge. Okay. This is the inferior part of the condyle, and so where will you mark? There's the first thing which is important, at least 2 mm of posterior intact bone should be there. So suppose this is the posterior margin, so 2 mm, minimum 2 mm. So itna safe rakhna hai, ita safe thakbe to. But now you think your graft diameter. If it's thicker, you will stay slight anterior. If it's thinner, suppose 7 mm, 7.5, 8 mm, then you may go more posteriorly. 2 mm. Suppose then 4 mm is your average radius of your graft, 4 to 6. 6, 7 mm anterior to your posterior most part of the condyle. Okay, and it should be behind your ridge, posterior to your ridge, just posterior to your ridge. It should not be anterior to your ridge. So this will be in terms of interior and posterior. What about up and down, superior and inferior? It's a over the top position, or it should be as low as possible, as posterior as possible. So there is no clear cut measurements. So suppose if your graft diameter is 8 mm, so you will go in such a way that there should not be blowout of the cortex. So anteroposterior, superior, inferior. So probably this will be the point. This will be the whole point. Okay, tunnel. And according to that, you should anticipate the center of the tunnel, and you should put your guide wire in the center of the tunnel. So probably there will be your guide wire. Okay. So first thing is you should visualize. You should at least see the posterior most part of the condyle. You should see the lowermost of the condyle. You should see the resident ridge. For that you have to prepare it thoroughly. You should spend some time in femoral preparation, and that is most important. Most of the errors usually happen at femoral side. So this is, and most of the failure of ACL reconstruction happens because of faulty placement of femoral tunnel. So this is most important. In most of the cases, we get away with the ACL tunnels and we do errors in the femoral tunnel. Okay, with this brief knowledge, we will do hands-on demonstration.
Some basic tips, some resident which will be there, so you have to curate it. You have to curate it, make it flat so that your guide pin does not slides. Yeah, right? You have to, sometimes it is the resident ridge is that it gives you a false impression and you place your tunnel in the wrong position. So you have to curate it, make it flat, see it properly, and newcomers, seniors can do directly by drills, but as a newcomer you should always use jig.
Yeah, and one more point, you should...
No, that one, offset, this one here.
Achha, you should not hesitate to make one accessory portal,
Yes.
anteromedial accessory portal, that will be slightly more medial.
More medial.
So that it will be directly, you will be able to do your
towards.
work directly in the lateral condyle. Suppose this is the ideal placement of your portal and you are doing with this, so what will happen? This will slip down. Every time you put it here, it will slip. So if you do like this from accessory portal, this will be exactly on your desired location.
So,
Okay? So suppose you are using this jig.
no, when you are making an accessory portal with when you are using a needle, so go more medial, entry and see your trajectory. By bending your knee, you just enter it and see your trajectory where it is going on the medial side. So if it is ideally we are just 1 centimeter below in the lateral patella, so you medial side, so you go more medial, put needle, see your trajectory and then make the entry. So from there you can pass the guide wire and do the
So under
tunnel.
visualization.
Okay, under
Once you
visualization.
confirm that your needle is going in along the exact trajectory which you actually desire, you just confirm it and then you make the portal. That is accessory andromedial portal. Okay? Okay. Suppose you are using this jig. This placement of jig is also important. Suppose if you place like this, the trajectory will be, the angle will be completely different. With the same jig. If you do like this, the angle will be completely different. If you just elevate the jig, it will be different. Isn't it? You just see it. Same place, it's in the same place, just angle. You change the angle. It's going completely in the different direction. You change angle in this way, it's going in different direction. Nothing, just you just lift your hand. It's completely going inferiorly, so it may blow out inferiorly. Just place angle of your hand, just slight, will make lot of difference there. Okay, this much. You just visualize the tip, this much. Just lift your hand and see it's going it downward and it will blow out. So this is very important. You should not allow your assistant to hold this if you are using jig. Now,
This direction when
blowout. Any blowout should be out.
So there should be
any blow 2 mm cortex should be intact.
Minimum 2 mm. 2 mm cortex should be
Minimum
there. Okay.
to prevent your blowout.
But
You should be satisfied that you are doing proper tunnel, ideal tunnel in femoral. Suppose you did it, then suppose you did it, and then how will you confirm, or I want to say, is there any seeing the appearance of the tunnel? What should be the? Yes. When you will be satisfied? Yes, I am fine. I am going. No.
not at the end
Just
of the surgery.
before
After just
You have
making
to
the
come
tunnel.
end, when you already you just made the tunnel, okay, and after the end of the operation, everything is end. After the end, yes,
You cannot reverse your surgery.
yes, you see is the tunnel is circular or it is oval. So ideally, our motto is to make a circular tunnel. What sir already said, okay? Yes, circular tunnel. That's why a different angle.
And the
What is it?
exit of your
Okay.
guide wire will also tell you the placement of your tunnel. Suppose that guide wire, once it is coming out, it is more anterior. That shows that your tunnel position is not good. If it is coming more posterior, that also.
Hi.
Sir is also chairing the session.
Yeah, please join us. So, suppose you have planned this area and you are just wondering whether this is your exact location or not. Should you go slight posterior? So, always be on the posterior side. Don't come on the anterior side. If you do any error, do it on the posterior side until it blows out your tunnel. So there should not be blowout, but if slight violation of posterior cortex happens, it doesn't matter. So try to be as posterior as possible. Okay? Would you like to add anything on this?
The femoral tunnel.
Femoral tunnel?
As long as you're using suspensory fixation, posterior blowout is not an issue.
Yeah,
is what sir
that's
said.
what I want to say. Slight blowout doesn't matter if you are using suspensory fixation. हाँ? नहीं दिख रहा है. want to add anything? You tell me about the angle of the tunnel.
So personally, I try to do it as much possible. And
Mic.
see, personally, I try to put the. Can I get the offset?
Yeah.
Offset, yeah.
Jig.
So personally, I try to put my hand as in posterior. I let the footprint guide me. So, and most of the surgeries, I generally don't look at where I'm making the tunnel. I'm only always guided by the footprint. So, yeah, I have done the surgery without the offset also. In there also, I have tried maximum to just follow the footprint. So, in my experience, I have always tried to keep it as
posterior.
as far as posterior
Posterior
as
and
possible, posterior, inferior, and I try to bring my hand as much down as possible. And I don't internally rotate completely, because in my experience, if I internally rotate completely, then invariably the tunnel length is around 32, 33. I like my tunnel to be around 37, 38. That is my standard. Generally, I'll get 36, 37 tunnel. So in order to do that, I have to put my hand as inferior as possible. So I like my button sitting lightly anterior, not on the absolute shortle point. Like in MPFL, you have that shortle point. So most of the times you will see that your button will end up near the shortle point. So I like it slightly anterior. That gives me a little cushion comfort that okay, my tunnel, even if I over ream, I'll get little space for that. So as far as the angle is concerned, this is no matter how, because our medial portal is generally not that high when we're doing ACL, and I am not used to making a far medial portal. So if you're making a far medial portal, then you can get more flexibility with your hand. So I am generally doing it from the standard anterior medial portal, so I am not getting that much flexibility generally. So I try to keep it as inferior, as I put my hand as down as possible, make the angle as high as possible, and then internally rotate for that 10 o'clock position or 9:30 position that I want.
So I am making it simple. So what I explained, you have to mind your position of hand. Okay. So it's a slight movement of your hand will make a lot of change in direction of femoral tunnel, isn't it? So what sir is trying to explain, you should go as posterior as possible, keeping in mind you should not go too posterior, which may blow out your tunnel. Slight blow out of tunnel is okay, but if it blows out completely, then that will be a problem. So you should be judgmental, you should judge it accordingly first. Second is your tunnel, the jig, if you are using the jig, so it should not be too anterior, it should not be too posterior. And what about the angle? If you elevate your hand like this, so it will go more posterior. In that case, your tunnel length will be shorter, and okay, very, very short, and it should not be less than 35. I aim always 35 or more than 35 mm. So if you do like this, suppose you are bringing your hand like this, too inferior, then what will happen? Your guide wire will come far anteriorly, and that is not acceptable. You should aim half anterior and half posterior. In the center of the, you should not be too posterior, should not be too anterior, it should be halfway between anterior and posterior. So you should be like, it's not like this, it's not like this, you should, and at the same time your knee is flexed. So you can negotiate your hand like this, and you should judge the position, and you should also see the exit of your guide wire, where it's coming out. So if it's coming out in the center or slight anterior, it's all right. It should not be too posterior. Okay, and again, it should not be too distal, otherwise it will be shorter. It should be at least above the eminence. Okay, like this. So ideal position will be like this. And don't hesitate, what I told them, don't hesitate to create an accessory anteromedial portal until unless you are very expert. Even we do accessory anteromedial portal. We actually create an accessory anteromedial portal if needed. We create transpatellar tendon portal. So there is no problem if you are creating one extra portal. The important thing is you should be perfect in your femoral tunnel placement. That is most crucial point.
I'd like to add, sir. So the best thing about creating an accessory portal is that, see, you will not be drilling. Your assistant will be drilling. So you have to be very careful, because you try to get as posterior as possible. When you introduce that 9 mm reamer, even with a flower tip reamer, when they pull it out, there is a chance of damaging the mid condyle. So with the far
কেউ
medial
করবে
condyle,
এদিকে
you avoid that.
কেউ ড্রিল করবে আসো 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 একজন সময় নেই আর সময় নেই চলে আসো চলে আসো সো ডেমনস্ট্রেশন অফ হ্যান্ডস অন কাম দিস সাইড সো ইউ প্লেস দিস ওয়ান মোর পারসন আজ চলে আসো একজন আর আসো একজন এটা
One
ধরো
question before drilling. What will be the position of, or what is the angle of the knee when you are doing a femoral turn?
Sir, more than 90 degrees.
Yes. Very good. So keep it.
It's already I have omitted the fat, soft tissue, skin everywhere, bone to bone. As much as possible.
Flex as possible.
So এটা হোল্ড করো একজন নিজে করো এইদিকে আরে বাবা এত এক্সপার্ট মানে ও পোস্টেরিয়র থেকেই করে দেবে সার্জারি you just confirm your position. So I'm not there to guide. You just whatever you have learned or whatever you have done till now, according to that, and I will see the exit point of your guidance.
And your hand will be in the downward. Okay.
এটা আর ঢোকাও লাইক দিস এটা বেশি রোটেট হয়ে যাচ্ছে লাইক দিস ওকে হ্যাঁ চলো
Sir, first of all, sir, I have to feel the posterior inferior condyle.
এটা তো ওটাতেই তো
I
করা
have
আছে
to- oh, actually, sir, I can see with the camera, na?
ওকে
And then
if you are using this jig so you have to fill this this is placing over the you are placing your jig over the posterior condyle on
yes, sir.
okay
And then, sir, I drill.
we have limited time you just drill it through this through offset
हाथ बजा के
ना हाथ मेरा हाँ इसका हाथ बचा ठीक है पोजीशन आई विल सी द एग्जिट पॉइंट
Exit points,
you just both of you just confirm the position
এটা একটু ভেতরে
it depends on this.
ঠিক আছে এই হাতটা ছেড়ে দাও এই হাতটা ছেড়ে দাও হ্যাঁ
ये होगा as posterior as possible मतलब ये है ये ठीक है ये
ना 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 उतना नहीं जाना है देखा এটা জাস্ট হোল্ড দিস চল কারণ আবার তো ইয়ে তো হবে তো এই তো ড্রিলও করতে হবে 8 mm 9 mm চলো ড্রিল তো করতে হবে আবার গাইড ওয়্যারের পর উপরে তো 8 mm বা 9 mm ড্রিল করতে হবে হচ্ছে না ধরো ধরো
हाँ this is the position हाँ ठीक as posterior as possible
হচ্ছে না চলো ফ্রি হ্যান্ড করো এখান থেকে একটা 4 mm ইয়ে ড্রিল বিট আছে ক্যানুলেটেড ড্রিল বিট দাও সো অলরেডি আমরা যেটা মার্ক করেছিলাম
हाँ this one
ঠিক আছে চলো আই ডোন্ট ইউজ দিস অফসেট জিগ আগে এটা মাইক্রো ফ্র্যাকচার অল দিয়ে ইয়ে করে নিতে হবে মার্ক করে নিতে হবে
हाथ बजा के
চলো 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 ফাস্ট 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 ইটস আ স্লাইট অ্যান্টেরিয়র চলো 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 ফাস্ট 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 you know you say that
this will be
it's a slight anterior
more towards the center.
चलो ये करो विड्रॉ करो विड्रॉ चलो आवर दो it happens this is the real scenario in operative OT so it happens don't worry you are readjusting and this is much better isn't it
Sir,
so
in between, sir, in between.
না it's always এটা তো অলমোস্ট মিডলে আছে এটা আর এটা একদম মিডলে আছে we have to think about the tunnel length also na
Yes, sir. So, is a posterior to become more small if it
smaller yes smaller চলো এক মিনিট এটা জাস্ট এটা লাগাও আবার এটাতে লাগাও ড্রিল বিটে, এটা ড্রিল বিটে ড্রিল করতে হবে না এবার। সো ইফ ইউ আর স্যাটিসফাইড উইথ ইউর
इसको और अंदर पुश कर वायर को पूरा पुश कर।
ओ कैनुलेटेड नहीं है, आर्टरी फर्स्ट है, आर्टरी फर्स्ट है, फास्ट फास्ट फास्ट। वो कैनुलेटेड नहीं है, मतलब ये ड्रिल
इसको छोटा कर
Drill is not can.
ओके ओके।
इसको पूरा अंदर तक घुसा के काम कर।
सो ये होल्ड दिस, इसको और घुसाना है। आइए बस करिए फटाफट। ये लोग टाइम कांस्टेंट दे रहा है।
इसके कैनुलेटेड ड्रिल नहीं है ना, ये पूरा आ जाएगा नहीं। पूरा ले लीजिए इसके साथ।
जाएगा नहीं, वो घुसेगा नहीं तो गाइड पर निकाल दीजिए, डायरेक्ट करिए।
ये जाएगा आने कर।
ও এটা বাড়ির ইলেকট্রিসিটির ইয়ে।
इसके साथ ही पुश करके ले।
বাস হয়ে গেছে, একটা দুটো ড্রিল তো করে দিই। হ্যাঁ বাস ছেড়ে দাও, তাহলে হয়ে গেছে, এটা হয়ে গেছে। এবার টিবিয়া দেখিয়ে দাও, টিবিয়া জিগ দাও, টিবিয়া জিগ ফার্স্ট। বাকি তো পাস করাটা গাইডটা ইয়েটা কি বলেছিলাম। ও this is footprint jig, okay, so you will place this, you will place this in the center of, you know, of the footprint,
medial lateral,
and
posterior to the anterior one of
45 दवा আছে তো दिया हुआ है ना,
and to PCL.
देखिए कितना है
8 to 10 and
वो बाबा कितना है 55 ही तो 55 ही था। चलो लगाई लगाई
এন্ট্রি তো তোমাকে এক্সপ্লেন করাই আছে তোমাকে। হ্যাঁ
লাগা
তো জাস্ট পুট দিস ইজ হ্যাঁ
এটা and anterior to PCL সেই
না
মাপটা
দিস
ঠিক করে
এই তো এটা এখানে আছে, যেখানে আমরা মার্ক করেছিলাম ওখানে নিয়েছি। আর এটা জাস্ট প্রক্সিমাল টু দ্য হ্যামস্ট্রিং অ্যাটাচমেন্ট and 2 cm to 3 cm medial to the tibial tuberosity। चलो मारो टाइट करो बस।
এই মাপটা ঠিক করে নিচ্ছি 8 to 10 cm anterior to PCL।
ওটা তো আর্থ্রোস্কোপিক্যাল।
Arthroscopy you were seeing it, na? You were seeing the PCL, just keep it anterior to the PCL.
You know, you have to work in your head that how do you want to do. If you're doing osteotomies with arthroscopy, or you are, you know, using the C-arm to look at your PCL tunnel, then you should plan it a little beforehand, that how the C-arm would come in, how the arthroscopy tower would move. So that would make the logistics easy, and it won't, you know, you won't lose operating time trying to arrange the equipments. About patient positioning, I think there are many positions to do arthroscopy surgery. The two common, the one that I use is that I hang the leg on by the side of the bed, OT table. But you can also use the TKR position. A lot of surgeons use the TKR position to do the arthroscopy. But keep in mind that for your femoral tunnel to be posterior and properly made, you need to flex the knee to about 110 to 120 degrees. So check that if your knee is flexing to that angle, especially if you are, you know, hanging the leg by the side of the bed, then you need to have enough room to flex the knee to 120 degrees. Make sure that there is adequate tourniquet padding and tourniquet pressure. Recently, I had a patient who had a, you know, a severe blister around the tourniquet area, so the padding was not done properly. These things should be avoided. And you know, also the side support. If you are using the valgus and varus stress, you will need to use the valgus and varus stress inside the operating room while operating. So you should make sure that the knee side post is, you know, helping you give the valgus stress, and there's enough room to make the knee into a figure of 4 position when you need to look at the lateral compartment. So the basic about the instrumentation, I think the first and most important thing is the scope. So you should know the basic movements of the scope, how to advance it, retract it, the rotating movements and the sweeping motions of the scope. That's fine. So you can use the light source for orientation. So whichever way the light source is, you are usually looking along that direction. So you can use it for orientation and rotation. So there are 30 degree and 70 degree scopes. I think we are primarily using the 30 degree scopes for knees, but the idea is that the 30 degree scope, as it gives a broader field of view, so it increases the field of view by about 3 times,
compared to the 70-degree scope, but you should keep in mind the blind spots. So remember that your scope is looking at an angle of 30-degree downwards, so there are some places where you cannot see or which are, around your blind spot. About the basic mechanical instruments, I think the most important is the probe. It's called the surgeon's extended finger, so you should understand how the probe works. And you always should keep in mind the dimensions of the probe, because every time you cannot use an arthroscopic ruler to measure every defect or every measurement inside the joint. So basic idea is that the tip of the probe, if you know its exact dimensions, then that will give you an idea about how large a meniscal tear is, how far, or whichever measurement you want to take inside the joint. If you know the, the tip of your probe, the length of the tip of your probe, then that will give you a very good measure. The sheath with obturator, one tip that I would say is that sometimes you use the blunt obturator to dilate the tibial tunnel. Don't do that, because it's sometimes, deforms the obturator and it doesn't go inside the sheath. So use whichever instrument is there for, its original stated purpose. Don't try to use jugaad techniques to, use things for other things. And the grasping forceps, you all know, they are to grasp things, and the punch and the basket forceps are to cut for meniscal balancing. If you want to take out a flap or something, you can use it to do that. For shaver, the ideal recommendation is that the shaver should operate at 2000 RPM, because now what we do is we normally ask the OT assistant to put the shaver at the highest speed, which is around 3000 RPM. But it's said that the higher the speed is, the closer the window of the shaver closes. So it's not very efficient for cutting. So the ideal RPM should be around 2000, but I think we are reusing our blades a lot, so maybe we should, we need to put it up a little more. If you're using a bar for whichever reason, the optimal speed is around 2000 to 4000 RPM. And so these are the basic, arthroscopic OT setup and instruments that you need. Thank you.
So can we take questions also, sir?
At the end of the session. So next speaker is Dr. Udipto Lodh. He'll speak on
So this is the standard instrument set already, which Debananda has alluded to. So we have the shavers, we have the screw-in cannulas, we have the passport cannulas, and we have the trocar system. So this is the position that I use, and the one thing that I focus on is the hyperflexion of the knee. So the primary portals are, one is the anterolateral. This is the primary viewing portal, which is placed about 1 centimeter above the joint line, next to the patellar tendon in the palpable soft spot. The anteromedial is 1 centimeter above the joint line and 1 centimeter medial to the patellar tendon, and it's also in a palpable soft spot, but more often it's done under visualization. So this is the transillumination technique which we use. We can see the point where the intensity of the light is more, and then we go in, and this is also guided by the blade. So the blade is always facing away from the patellar tendon, and the skin and the joint capsules are incised, and the care is taken not to damage the ligaments or the cartilage, and to always stay above the meniscus. So there are other portals as well. So we have the superior medial and the superolateral portal, which is generally used for the aspiration and water inflow and outflow. So the posterior medial portal and the posterolateral portals are very important nowadays, because we need to visualize the posterior horn, the PCL and the ramp lesion in the posterior middle, and also probably a zip lesion we can see through a posterolateral portal. So these are basically 1 centimeter above the joint line, and this is also done under visualization through the scope, and also a transillumination technique can be seen. So the posterior medial portal is basically 2.5 centimeter inferior and 2.5 centimeter posterior to the medial epicondyle, with the knee in 90 degree of flexion. And this also coincides with the soft spot between the medial head of the gastrocnemius, the MCL and the semimembranosus. So there are variations as well. So literature suggests that there are people, there is a study group using a radio frequency device to create a posterior medial portal. And there is a high portal philosophy as well, like they do all high portals. They go as close to the patellar, they hug the patellar tendon as close as possible. And all the philosophies are different, but they do work in different surgeon groups. The transpatellar portal, obviously, we have a 1 centimeter, it is done 1 centimeter distal to the patella, and it splits the patellar tendon. So this is never used in a bone bone graft harvest. And this allows the central viewing, probably needed to remove loose bodies which are entangled there. And far medial and far lateral portals can be created. It's used as an accessory instrument placement portal and also for loose body removals. This also allows us to get the proper angle of attack for the ligament tunnels and also for meniscus repair. So loose bodies can be very difficult to manage. There are multiple literature suggesting the portals to be created. So this is one literature which suggests that the multiple loose bodies were removed using different accessory portals in different locations. Since loose bodies have this affinity of getting stuck in the most difficult places for us, so you can be very ingenious with the tunnel placements as well, as long as you are respecting the anatomical boundaries, the neurovascular structures, while creating those tunnels. There are particular techniques of doing a meniscus ramp repair as demonstrated by Dr. Shital Gupta sir. So he has used two posterior middle portals to create this shoelace technique, one to visualize and one as the working portal for this. So if we go into the basic diagnostic arthroscopy, we enter the joint in extension, and here we can see the undersurface of the patella. Not much chondral loss can be seen, and also we can see the trochlear groove, which appears to be quite pristine as well. And so when we are happy with this, then we enter into the gutters. The medial gutters and the lateral gutters. So this is the right knee, so we could see the lateral gutter. This appeared to be normal looking plica, and we can also see there does not appear to be too much damage to the meniscocapsular junction. Again, on the medial side we enter, not much opening, and also the meniscocapsular junction seems to be open. But then we enter into the medial joint space. So while doing this, we take the knee into extension and also give a valgus stress. Then we can clearly delineate this flap tear in the posterior part of the middle meniscus. So this has to be tackled. So a bit more medial portal is created, and our shaver blade comes in through this. So we can balance this. So again, there is nothing constant about the accessory portals. It can be created at the convenience of the surgeon. And obviously the location of the tear or the location of the repair takes priority in this. So we keep the blade away from the articular surfaces. The cartilage is not damaged, and we try probing to see the displacement. So this is in white zone, so this was balanced. Then we move on to the lateral compartment. So the lateral compartment, we can take the knee in the figure of 4 position. And a good assistant can obviously open the knee joint beyond what the surgeon can do. Otherwise, we also have other accessory techniques. We can have the pie castings. We have so many other techniques as well. So here, again, the posterior meniscus, the root, horn, and the body seems to be good. A bit of balancing is done. And then we move into the notch. We can see, I'll just forward this. So then we move into the notch. Again, in this particular case, the ACL and the PCL was absolutely normal. We can see nothing much in the no chondrocyte loss. The cartilage seems to be intact. So if we suspect, or if we see a popliteus which might be a suspect, so we can go about probing the popliteus as well. So this is the brief overview. In the suprapatellar pouch, this is where the loose bodies and the plicas are seen. The patellar and trochlear chondromalacia is also noted here. In the lateral gutter and the middle gutter, we again have the osteophytes and the loose bodies. The middle compartment, we have obviously the middle meniscus tears and chondromalacia. The intercondylar notch, we have the loose bodies, and both the ACL and the PCL ligament tears can be delineated. The lateral compartment, again, the meniscus tears. The posterior middle compartment is for the loose bodies as they get stuck in the weird places, and the root tears are also visible from this. So the takeaway would be a thorough, standardized, systematic approach is critical for diagnostic arthroscopy, and the portals can be created as per requirement while respecting the neurovascular boundaries, and accurate portal vectors are needed for the meniscus. And thank you, and prayers for the victims of AI 171. For the next talk, I would invite laptop to change karo. Dr. Shib.
Discussion is graft choice for ACL and PCL reconstruction.
graft selection is a cornerstone of successful reconstruction. The ideal graft characteristics should be that recreate anatomic and biomechanical properties of native ligament and that withstand tensile strength, stiffness, and adequate strain like a native ligament. And that limits donor side morbidity, allows secure fixation and rapid incorporation also. Graft choice depends on multiple factors like what are the tissues are available, what is the patient's activity level, is he a sportsman or not, and what is the occupation of that patient, is there any associated injury, and in Google's era, obviously patient preference, and what is the most important, that is the surgeon's experience and preference also. The graft categories are broadly divided in 3 categories: autograft, allograft, and the artificial one. That is also divided under synthetic and augmented. Among the autograft, bone patellar tendon bone graft, hamstrings, quadriceps, and peroneus longus we commonly use. And allograft, Achilles and tendoachilles, Achilles and tibialis anterior and posterior are commonly used. Bone patellar tendon bone graft involves harvesting of central 1/3 of the patellar tendon with a bone plug that offers strong fixation via bone to bone healing, and it is suitable for high demand athlete and contact sports. Here the graft incorporation is very early. There is very good tensile strength. Only drawbacks is anterior knee pain, risk of patellar fracture, there is donor side morbidities, and also slightly higher incidence of patellofemoral arthritis. Regarding hamstring autograft, we use semity and gracilis. There is tendon to bone healing. Definitely, the healing is slower than the bone patellar tendon bone graft. But the advantage is, here there is less anterior knee pain, donor side morbidity is less, but there is a chance of hamstring weakness, and also sometimes we get smaller diameter of graft. Use of quadriceps tendon autograft is rising, and with or without bone block due to its size, strength, and lower morbidity. The larger diameter of graft are available, and there is lower anterior knee pain as compared to bone patellar tendon bone graft. But it is technically demanding, and there is a chance of suprapatellar pouch injury that may lead to stiffness later on. Peroneus longus graft has gained substantially popularity over time because easy to harvest, and it's a predictable length and diameter. There is less donor side morbidity, and cadaveric studies shows there is better tensile strength than hamstring and native ACL also. Good functional outcome with less thigh wasting and early rehabs in their cases. Contraindications are flat foot, lateral ankle instability, and polio. Allograft considerations usually for revisions and multi-ligament injuries. Advantage is definitely there is no donor side comorbidities and the larger grafts available, but there is risk of transmission of HIV, HBV, Clostridium itself. There is delayed graft incorporation, higher failure rate, and among synthetic graft, first generation we use protoplast, second generation dacron, and third generation leads KO. Graft selection in PCL is more tricky because PCL bears higher forces than ACL, so definitely stronger grafts are required. And single bundle versus double bundle reconstruction may influence graft choice. Bone patellar tendon or quadriceps or peroneus longus are preferred. And another another topic is single versus double bundle ACL reconstruction. Single bundle is more common, technically simpler, and double bundle anatomically mimics native ACL. No consistent superiority in outcome, especially for ACL reconstruction. But in case of PCL, there is definite advantage regarding double bundle reconstruction, but the controversies are still going on. There is a comparative studies of different types of grafts, tensile strength, knee pain, failure rate, like this and that. Most important is re-tear rate. It varies a wide range. It's about 1.8 to 33%. The systemic reviews and the registry review reports lower rates of re-tear with bone patellar tendon bone graft as compared to hamstring and quadriceps. Bone patellar tendon bone graft in athletic population has a lower failure rate than all other graft options. Data on quadriceps and peroneus longus is limited. So take home message, no single graft suits all patients. Selection is the paramount important. Consider the age of the patient, activity of the patient, is he a sportsman or not? If a sportsman, so what type of sports, what muscles are using? And skeletal maturity, and obviously previous surgeries. And overall surgeon's preference and experience also. For primary ACL reconstruction, hamstring tendons are widely used. Bone patellar tendon bone graft still remains gold standard. Emerging preference for peroneus and quadriceps grafts in complex or revision cases. Allografts useful in multi-ligament or revision cases, and future trends are biologic integrations and graft augmentation. Synthetic grafts alone have not survived up to the hype. Thank you.
I thank all the speakers for staying.
Good morning. Myself, Dr. Sandeep Kumar Pramanik. My topics today is anatomy and the remnant preserving ACL reconstruction. First of all, we should know what is remnant. This is the remnant remaining part of the torn ACL present in the knee joint. It may be a torn from the femoral side, it torn from the tibial side, or intersubstance. There is some classification of the remnant. There is a 4 type of classification of the Crane's classification. You all know this. Actually, what we usually do in case of ACL tear, a torn ACL is reconstructed with the tendon. Why is the tendon? Because the unavailability of the accurate size of the ligament in the body. So we can forced to reconstruct with the graft at this tendon. Before the one question to the audience, why remnant is so important for preserving in the ACL tear? Before giving the answer, we should know the anatomy of the ACL. This is the both side attachment, is the femoral side and tibial side. ACL attached to the posterior aspect of the femoral surface of the lateral femoral condyle of the femur. This attachment site is semicircular shape, approximately 20 to 10 millimeter. And tibial side is the lateral aspect of the tibial spine, anterolateral aspect of the tibial spine. This attachment is broader than the femoral side and oval shaped footprint, measuring about 10 into 30 millimeter. There are 2 bundles, we all know, this is the anteromedial bundle and the posterolateral bundle. AM bundle originates from the proximal and posterior part of the femoral attachment and insert on the anteromedial part of the tibial attachment. And the posterolateral bundle originates from the distal and posterior part of the femoral attachment and insert on the posterolateral part of the tibial attachment. Vascular anatomy of the ACL is the, you all know the vascular middle genicular artery is the popliteal branch. This supplies the ACL and also supply the posterior lateral meniscus and the meniscus. So it's a nerve supply, sensory nerve ending. The ACL contains nerve fibers including reference receptor, which detect the stretch, and the free nerve ending, which acts as a nociceptor and the strengthening pain. Proprioceptive function of the ACL is supplied by the nerve ending, plays a crucial role in the proprioception, which is the body's awareness of this position and movement in the space. Innervated by the nerve fiber from the tibial nerve, which also supplies the surrounding joint capsule and muscles also. So, what is the advantage of the remnant preserving ACL reconstruction? This graft and vascularage. We when to do the classical ACL reconstruction, we ligament reconstruct with the tendon, because due to the unavailability of the ligament in the body, we should force to reconstruct the ACL tendon, ACL ligament with the tendon. Why? These grafts are vascularized during the first year after surgery, with the body creating a healing response and covering the graft with new tissue and blood vessel. This process is also called the ligamentization. These preserved fibers of the ACL increase the vascularity, new blood vessels needed for the healing of the graft. Second advantage of this remnant preservation is to prevent the leakage of the synovial fluid into the bone tunnel, which impedes the healing. And third, preserved fibers of the ACL also increase the mechanical strength of the graft and may act as an internal brace to protect the graft during the ligamentization process. Remnant preservation increase the ability to nerve ending to cover the newly forming ligament, thereby increase the proprioception. Proprioception is an important factor for the successful return to the sports. This is also the advantage of the remnant preserving ACL reconstruction. So, any surgery which is the complication. So, what is the complication for the remnant preservation? This is the main complication is the cyclops lesion, which is the cyclops lesion is the anterior arthrophyrosis. These are scar tissue formation within the knee notch, which can cause impingement of the graft and leading to the extension loss. Second, the graft impingement, the remnant tissue can interfere with the graft's proper function, causing the pain and the limitation of the motion. Extension loss, which is the significant complication where the knee cannot be fully strengthened, hindering the recovery and the potential impact in the athlete performance. This is the complication. So, some articles regarding this remnant preservation. Some authors prefer the without remnant, and some authors prefer there is some articles with the remnant preservation with or without the bundle. The short video of the remnant preservation surgery.
Is viewed via AR portal. Under examination, ACL is far ruptured from its femoral footprint. A robust remnant is intact. At full knee flexion, the anatomic femoral tunnel is determined by a femoral hammer with proper offset guide via AM portal. A guide wire is drilled through a lateral femoral condyle and followed by a 4.5 mm drill bit. A femoral tunnel is finished properly with a graft size drill bit about 20 to 25 mm. Return to 9 degrees knee flexion. The tibial C-type drill guide with 50 to 55 degrees set is placed in the center of the tibial remnant. A K-wise is inserted into the center of the remnant and is held by a Kelly clamp via AM portal. The remnant is bored from the smaller size. It may start from 6, 7, 8, etc. and gradually up to their appropriate graft size. A tibial suture blue suture pass is retrieved via AM portal. The femoral wading white suture is sutured down through the tibial tunnel with a suture. A needle is pierced the remnant percutaneously. A shooter nylon sutures is retrieved by AM Porter with a Kelly clamp. The retention in suture is pseudo in retriever by AM Porter after its femoral fixation. Pulling the ankle and the graft with a wide weighting suture through the center of the remnant. The femoral ankle is retrieved and is prepared with the retention in suture through it via AM Porter, finishing pulling the ankle and the graft toward the femoral tunnel. Fixing the ankle and pulling the graft into the femoral tunnel with approximately 20 mm. Retention in the remnant by pulling the retention in suture if necessary. In the right leg, a Kelly clamp was used to enlarge the tibial tunnel and protect the graft. At a point 1.5 to 2 cm lower to the tibial
Thank you.
Thank you, sir. Next, we move on to the life surgery team. Can you add the feed to the screen? So this is life surgery 1, ACL with meniscus repair by Dr. Arnav Kormakar sir and Dr. Abhijit Chen. So to chair this session, I would invite on stage Dr. Sridhar Agarwal, Dr. Rajinder Singh Gahir and Dr. Amrisha. Arnav sir, can you hear us? The audio is not clear from the OT. Venue to OT.
Oh, अच्छा. Hello.
Hello. Arnav. Hello.
Hello.
Arnav, can you hear us?
Can you hear us?
Yes, we can hear you distinctly and clearly.
हाँ, start करते बोलो.
Yes, good morning Arnav. Start करो.
Hello.
Hello. Yes, we can hear you.
Are you audible?
You are clearly audible, Arnav.
Okay. Thank you. So good morning to all of you. Many thanks to Tamluk Orthopedic Club for giving us the opportunity and Indian Arthroscopy Society. And we have our Secretary Dr. Rajiv Raman. Special thanks to him. So the case of today is an ACL tear with a medial meniscus tear. So I'll ask the cameraman to focus on the MRI first. So we can show the MRI, then we can go to the live surgery. MRI টা দেখো।
এখানে ফোকাস করতে হবে। এই
focus on the MRI please and
ওই ক্যামেরাটা MRI তে
increase the hall sound. We can't hear. হলের সাউন্ডটা বাড়াও।
ওই ক্যামেরাটা MRI তে ফোকাস করতে হবে।
Arnav, tell us about the patient.
Show the MRI please. So this is a 21-year-old male who has a history of injury 1.5 years back, and after that he had multiple episodes of instability and pain, and especially he mentioned about locking of his knees in one episode. So probably that time. Can you see the MRI? ওইভাবে হবে না, সামনে থেকে দেখাও। এইখান থেকে আস। Just give us a moment, we are shifting the camera for the MRI. এদিকে আসো, straight করো। Yes. So zoom in. So if you see the first the coronal cuts, in the coronal cuts if you can come here, so if you can see that in the middle sections there is discontinuity of the ACL fibers. The fibers are wavy and edematous. Zoom here, যেখানে আমি দেখাচ্ছি। Zoom করো, zoom করো, zoom করো। Yes, yes, হ্যাঁ। So this is the ACL, which is discontinuous, wavy and edematous. And then if you come back, you start seeing the PCL. And once you come here, so here you can see the tear in the posterior horn of the medial meniscus. Sort of complex tear, but 1, 2, 3, 4. 4 in 4 cuts it is seen. So it's quite a big tear, horizontal tear with complex pattern. So this is it. And if you come here on the bigger sections, the same thing is that the ACL is here. যেখানে আমি দেখাচ্ছি ওখানটা ফোকাস করো, বড় করো. Yes. So ACL is discontinuous, but we can't see any bucket handle fragment in the intra-articular portion. And then if we can come here, then we can see the here in the posterior horn of the medial meniscus. And the X-ray and alignment looks fine. So our plan is to do a ACL reconstruction with a repair of the medial meniscus.
So Arnav, how is the pivot test? Can you
please show?
Yeah.
So this boy has got really flat quads that I like to show you. He's got almost flattened quadriceps, huge muscle wasting is there.
Yeah.
And you can see the anterior drawer. This is it. And Lackman, but pivot shift is not positive here. So he is otherwise stable. His tile test is also negative. Posterolateral corner is also fine.
Arnav, in the MRI, Dr. Siddharth here, in the MRI, if you could see there, the
Yes.
hyperbuckling sign of PCL was not there. So probably suggests an incomplete injury of the ACL. Maybe 20%, 10% of the ACL is remaining, and that is the cause of negative pivot. That could be one of the reasons. I was watching on the MRI, the hyperbuckling was not so much on the PCL.
Exactly. And as you know, the injury is 1.5 year pattern of ACL repair healing. The one bundle of the ACL goes and stuck with the PCL and heals with the PCL. In that cases also, you don't find grade 3 laxity, but the ACL is actually not working. So whenever the patient is walking or bearing weight, the instability comes. But in your test, you may find a lesser bit of laxity.
Yeah.
So that is what I think you are telling.
Yes. Let's start. So you'll be harvesting the graft, or you will be going with the diagnostic first?
No, first we should do the diagnostic, then we'll come for the graft.
Great.
We have planned to take the hamstring graft here. So first we'll do the diagnostic-scopy, we'll give a round and then we'll come back and do the graft harvest.
Arnav, for confirmed ACL cases, do you always do a diagnostic first, or do you straight away go and pick up the graft?
No, first I always do a diagnostic-scopy.
Okay.
And that should be the message to all, I think. Maybe some confident time you go, but we have burnt our fingers also many times that we had taken a big graft, then we have seen. So if the camera can come close. So one thing I have learned eventually is that regarding the anterolateral visualizing portal. So for ACL, planned ACL reconstruction, I tend to be very close to the patellar tendon. Can you reduce the glare? I think it's not very visible to them. Top light off kore dite paro.
I think better to shift to this camera.
Yes.
Make this camera on larger view.
So the anterolateral viewing portal will be very close, just adjacent to the patellar tendon. Because if you are planning to do work in the notch area for ACL reconstruction, then you should try to be more towards the midline. And then we will do the anteromedial portal under visualization. So I do in TKR position. I know that many people do in hanging position. So it's I feel easy and leg is supported. So I feel it's better. Easy for me. Once you enter the joint, then we'll extend the knee and we'll go to the pouch area. We'll enter our scope. এবার স্কোপের ছবিটা দিতে হবে। ওয়াটার অন, ব্যালেন্স করা হচ্ছে। So this is the suprapatellar pouch area. So quickly we'll just go through the trochlear notch, the patellar facets, looks fine, pristine. The lateral gutter we can go up to this much. So almost we can see up to the popliteus tendon. This is the lateral meniscus. Then we can come back, and then from the medial side you can see the medial gutter, and slowly then you can hang the leg in. So see the medial meniscus tear, we can see from here. So this is a, as we were suggesting, this is a quite a big tear, but the medial meniscus otherwise looks fine. Yes. So this is it. This is the, sometimes there are ramp lesions also, we need to exclude ramp lesion, but here it looks okay, though we can inspect with a needle from the posterior medial side. So this is the ACL. So now we will do the anteromedial portal. So for ACL reconstruction, we do a anteromedial portal a little bit away. So you can do 2 portals, for one for working and one for later your graft passage, but most of the times I can get away with 1 portal.
Arnav, in this case, your anterior lateral portal looks pretty high. I'm just over the, so what I have seen, that once you are doing a little bit of high portal, seeing the posterior part of the meniscus like ramp and other areas, it bit easy. So that is why over the time I have done little bit of high portals. Otherwise, you can do a standard portal, not an issue. Suction. The notch looks empty, I think.
Suction. Yes. So this much of fat pad you can remove, how much it is required for visualization. Otherwise you can keep. So the point we are discussing regarding the ACL healing, actually that is classically seen here. You can see the one bundle of the ACL is healed with the PCL. I'll show with a probe. Give me a probe. But you see there is no attachment in the femoral condyle, right?
Yeah.
So if you can see this, yes. So this is the part of the ACL which is healed with the PCL, but see there is the femoral condyle is almost empty.
So we have an empty notch sign to start with. So we have an empty notch sign to start with.
Yes. So we can keep this or we can remove this, depends on, we'll see later on. If it comes and hinders in our making a tibial tunnel, then we can remove, else we can keep it. And obviously we are remnant, will try to preserve it. Nowadays it's the concept. So I think, yeah.
So what may be the cause of negative pivot shift test in your case? Because it's a complete tear and still we are not getting pivot shift test positive in this case.
It might be with the cause. Amrita, because of this, it actually gives a false negative pivot shift, because it, with time it gets hardened with the PCL, that prevents the tibia to roll forward. So that is one of the reason.
Maybe there is some contribution from the bucket handle tear of medial meniscus.
Also bucket handle, yeah, sometimes it goes in, the patient gives one history of locking of the knee and he was unable to extend. That time it was locked, but at present if you seen in the MRI also, it has been reduced later on. And it even in now also we have seen that it has been reduced. So maybe sometimes the bucket handle it prevents the tibia to come forward. So this lateral meniscus looks fine, and we can probe it, else we can go for graft harvest. Okay.
What
so
if your pivot shift test is positive? Then also you go for diagnostic arthroscopy and then start your taking graft? If you are
not really. If you are in hurry, you have less time, then you go for directly graft harvesting. But ideal, if you say in a live surgery, we can talk about ideal scenario. So diagnostic scopy is a must before you take your graft.
Yeah, true.
So if we can focus the camera, this patient is really lean and thin. We can literally palpate his tendons, and I give a little bit of oblique incision just over the semity graft or in between the semity and gracilis.
Can we tell the cameraman to focus on the graft harvest side and change the bigger vision to the outside vision?
Yes, please outside view.
Yeah.
Enlarge the picture. Yeah, make it clear.
Perfect.
Reduce the brightness a little bit.
In the meanwhile, what is your indication for taking peroneus longus graft?
So primary ACL I usually don't take, otherwise it's an high demand athlete, sports person, or having a very bad pivot shift or generalized ligament laxity. These are the things where primary we take peroneus. Otherwise semity and hamstring, I think it is suffice for most of the cases. And for revision, definitely peroneus or quad tendon that I prefer to use. So here we can literally palpate the tendons over the edge of the tibia, posteromedial border of the tibia, and that over that area I give a little bit of oblique incision. That LV. Somebody prefers a vertical incision also. So what you do?
I prefer oblique incision. What about others? Rajendra?
Oblique incision.
We all prefer oblique incision from the moderators. Probably most of the people prefer this oblique incision only.
So, but the even after giving oblique incision, it is sometimes the neuropraxia cannot be avoided. Most of the patient complains of numbness after the operation for 6 months almost, and then it recovers by itself.
Yeah. Arnav, can you explain the measurements of locating the exact location of incision for taking this graft?
Yes.
Direct palpation directly over the tendon, sometimes it's not that much palpable. So for the juniors and for the delegates, will you please explain the measurements?
Yes. So if you can see roughly, I have given my one thumb or almost 2 to 3 centimeter. You come down and then you go 1 thumb medial. That is the location you invariably find your tendons there. And you have already, without knowing that, we have given the incision, and we'll make it little bit bigger for clear visualization. So once you cut, then you come for the subsartorial fossa. So once you feel the subsartorial fossa, you can a little bit dissect and confirm that you are in the right place. You can feel the tendons here. Yes. Okay. So then you have to give a L7 incision in the fossa over the tendon. You can give L7 incision and close it. It's always better that you close the incision later on. But I have seen many of teachers, they are not closing, and that doesn't create any difference. I don't know. But I try to close it. Sometimes it's possible because after taking the graft, sometimes the fossa is also not very clearly visible. Sometimes we get it visible. So here we'll...
One tip is here, you can just mark the cut ends of the fossa.
Yes.
With a marker, or maybe better with methylene blue. And later on at the end of the surgery, you can close it.
Yes.
And preferably it
So
should
once
be
you
placed.
cut the fascia, then you can get the tendon easily. Yes. Then you can hook the tendon and then with your right angle and then you can take it out. So this is your semity tendon. If you can see, the vinculas are there. Yes. So this is the semity tendon and with the vincula. So then we pass a loop suture over it and I can show the vincula clearly. So then you have to cut these vincules and reconfirm and palpate. So at this point, try to pull the tendon and push your other index finger around the tendon, circulating around it 360 degree to feel and palpate if any other vincules are left. Because that is the one of the reason for premature amputation of the tendon. So be careful and then I think.
Arnav, you are using open tendon stripper?
What tendon stripper we are having? Open or close?
Which
Close.
one?
So we are having close tendon stripper,
Okay.
sir.
So you don't have an option. Normally,
Yes.
which one do you prefer?
Most of the cases we use close only.
Okay.
Otherwise, if we are planning to keep the stump of the tendon in the tibia for some reason, then we use open. Otherwise, this one. For quadriceps, I like to have open tendon strippers. So we try to take as much as periosteal sleeve from the tibia and then we cut and then we remove the part. So this osteoperiosteal sleeve, if it is possible to take, then it is very good for the healing. So then you pull and then you can have. So your graft excursion should be like this easy. If it is not that easy, then you have to recheck that if any vincules are left or not.
With the osteoperiosteal sleeve harvest, generally it is difficult to suture back the sartorius fascia.
Yes.
Because while harvesting the periosteal sleeve, you end up invariably cutting the sartorius fascia to expose
Yes.
that area.
Right. So I think osteoperiosteal sleeve is difficult, but definitely we can have little bit of periosteum with
periosteal sleeve, sir.
that
Even with
helps.
that, the inferior border of semity crosses sartorius fascia at that level.
Yes. So I do in this position 30 degree of flexion. So I try to, then you have to push your tendon stripper and rotate. So it's not always that you push too hard. Slowly you should push and slowly you should rotate. Then one point of time you will feel that the resistance has given away and your tendon is there.
This is a nice trick to roll over the artery so that it does
Yes.
not slip back.
Yes. So we can take the gracilis. We'll see. I think we have good graft, but still I think we can take because this person is active young and we should have a good graft option for him. We have to dissect it first, then we have to take. So for this young chap, what should be the graft diameter that most of our panelists will agree and be comfortable with? 8 or 9?
I would go with 9 plus, 9 plus.
9, 9.5. So if it is less than that, so will you do an internal brace or something?
No. Internal brace is a big no. I personally feel that if your target is ACL reconstruction, your
Yes.
primary target is ACL, having a suboptimal graft and substituting it with anything that is less optimal than graft does defeat the purpose of surgery altogether. So you
Right,
need
right.
to have a good graft that you put in place if you are doing a ACL reconstruction. So
Exactly.
minimum to minimum, the dia is 8 and anything above 9 is very good. That is what my concept is. I sometimes do supplement a poor graft with a sleeve of quadriceps, a thin sleeve of quadriceps. I take an as
Yes.
supplement in case I don't get a good graft from hamstrings.
So, and what about your opinion about this adding some biological augmentation if the
Like-
graft diameter is less than all?
Like what?
If you can show this thing. So here you can see clearly you have taken a good amount of periosteum with, it's not visible, really white.
which biological augments are we talking about, Anand?
Yes. So this amount of periosteum you can take with the graft. So this thick white part at the end of your graft is the periosteal slip. And all the research paper has shown that it will keep this, and some of there are some papers which have shown that if you take separately some periosteal and you tie it over the ends of the graft. একটা বড় নিডল লাগবে এমপিএল ফ্রাই কাস্টিং এর জন্য
গ্রে স্পাইনোক্লেন পাওয়া যাবে
আর্টারি
স্পাইনোক্লেন
এই নিয়ে হবে তোর কিউআরপি সেটা দিলেও হবে ইয়েস
Arnav, for the delegates, give us some tricks to prevent premature amputation of the graft, and unfortunately, if it happens, then what should be done?
So, if you can see, I have draped till ankle. This is one of the tricks. So, be prepared if something untoward happens in OT. So, you have another option of getting another graft. So, your quadriceps is always there, but it's tricky to harvest quadriceps, and you need surgical mastering to do quadriceps harvesting properly. Sometimes inadvertently you might damage the muscle underneath. So peroneus is a busy good option that you should be prepared for. So always drape up to your ankle and be prepared. Second thing is that always use your fingers alongside of the tendon. Give a big incision. That a smaller incision is not always good. Give a big incision, see the tendons clearly, dissect it out, and double check with your fingers that there are no vincules left before putting your tendon stripper. And one test that I always feel that when you are pulling your tendon, it should come out very easily, at least 1/3, 1 finger breadth from without giving much effort. So these are the indications that you have made it clear. Then keep your knee 30 degree of little bit of flexion, little bit of like figure 4. So external rotate. So your medial part is get relaxed. So when you are taking the tendon, so it should not come under any stress. Then don't push with the tendon stripper too hard. If you are feeling that it's not going inside, stop, come back and reassess and check for any other vincules are left. Then rotate the artery on your left hand, and the graft should come. So rather than pushing, it's like rotating the graft and the graft is coming it. So these are the things I think if you follow, and if you are got premature amputation, then the quads is an option or peroneus is an option. So that thing you can take, but provided that you give counsel the patient previously for that.
Arnav, most of the time what I've seen is, if you face resistance and you try to push the stripper, that's when the amputation occurs.
Exactly. So never pull the stripper. That is the clear message should be given.
The message to the delegates is you should know at least 2 tendon, you should know how to take tendon graft at least at 2 points. Like you should know quadriceps with hamstring or hamstring with peroneus longus. At least you should know two tendon graft harvesting. Okay, so you may fail in one tendon harvesting, then you may have to shift to another one.
Suction.
Arnav?
Yes.
So you please carry on. We will carry our inauguration ceremony, and we will keep you on hold. Your video will be mute, but it will be running.
Okay.
You carry
no
on.
problem.
Yeah, please.
So in the middle, we will start our inauguration program. We will not take much time, within a short period of time. We have with us our very most senior surgeon in Tamluk Orthopedic Association, Dr. B.K. Addo here. We'll do the inauguration with him, and Dr. Rajiv Raman is here. We will do inauguration with him. Arnav, niye চলে এসো? Rajiv. Dr. Agarwal. I'm Dr. Subarna.
একটা ভালো দিবি না, হে আমার মাইকটা তাহলে এখন অফ করবে।
মানাদা স্যার কোথায়? Where is Dr. একসাথে আরে একসাথে আয় Sridhar. Thank you. চলে So I would like to take the opportunity to felicitate Dr. Rajiv Raman. He is, Robin is felicitating him. It is our honor. He is the secretary of Indian Arthroscopic Association as well as Indian Orthopedic Association. This is a fantastic. I feel so great. He is my friend. It is a real matter of pride, but I say more. Thank you. Dr. Agarwal, Dr. Sridhar Agarwal, he has taken this much of pain to come from long distance Chandigarh here. Thank you very much. It is a small town in West Bengal. Thank you very much. So our very senior surgeon, Dr. B.K. Addo, he is the first person here to bring this. Before that, orthopedic surgery in Tamluk was done by the general surgeons. And he is the first person to start it directly by the orthopedic surgeons. Rajiv, I can introduce. Dr. Aditya, he has come from Delhi. Yes. We like to felicitate Dr. Aditya. He has come from Delhi. Yesterday at night, 1:30 a.m. he has reached here. 1:30. Now Dr. Rajinder Gahir is very much our beloved senior. All the time he is present. So nice person. Rajinder, thank you very much. Manada, our teacher, old teacher, all the time. Shobochachi? Shobochachi kothay? Manada, thank you very much. Yesterday, Manada reached here at 6 p.m. He has seen all the cases in details and now he has put the cases. Thank you very much. But you did not come. You told me you will come along with. And Shobhashachi, Secretary, West Bengal Orthopedic Association. Shobhashachi, our team is going to Jharkhand this time. Thank you. And last but, Dr. Sunit Ajra. Thank you very much, Sunit. Where is Dr. Rajesh Kuchar? Rajesh, please come. Aste. Rajesh, please come. Ritik. Hi, please. Hi. Ritik? Ritik, my brother. Please. Hi. Amrish? Hi. We are very much happy to take all the persons here. It's really nice. Everyone was very much enthusiastic. 11, 12 persons. Yes. Rajesh. Rajesh, Yes, we'll take. Amrish, Shiv Shankar, please felicitate Amrish. They are all from Arjikot. The maximum people from Arjikot actually. We should have a clap for Arjikot. Khalpar, Khalu. Okay. আচ্ছা ওরা আমাদের ওই ব্রাদাররা লাস্টে একদম দে আর একদম ওরা পেছনে সব সময় আছে ওকে 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 অর্ণব
There is a small announcement. So there is a small announcement. So we have a IAS Tatkal membership drive. So connect with Udipto and Devayan. So you apply. If you apply today, by tomorrow evening you will get a membership number. All right. So please apply today. So it's a Tatkal membership drive for Tamluk.
I respect the chairpersons. I request the chairpersons to go back to the live session. Arnav sir is still there.
Hello. Arnav.
Yes. Dr. Arnav?
Yes.
Dr. Arnav, can you hear us?
Yes.
Yeah.
We can.
So you have put in the first stitch of the bucket handle tear?
Yes, yes. So it's not, maybe we have not tied yet, but just to reduce it, then if you can see, this is quite a big tear, almost extending up to the posterior third of the body and posterior horn. So we'll be requiring at least 2 all inside stitches in the posterior part and maybe 3 or 4 inside out or outside in stitches in the middle and up to almost anterior part. So what I have done in meanwhile that I have done a pie casting of the MCL to open up the medial space, and I have shifted my visualizing portal to the medial side, and I am working from the anterolateral portal.
So the instrumentation that is going in for the sutures is from the anterolateral portal now.
Yes. So this is what stitch I have taken. Now this stitch will be holding and reducing the meniscus. Then I will come back to the anterolateral portal again to put the all inside device in the posterior part of the meniscus. So I'll start my repair from posterior to anterior.
So you would first put an all inside device and then put the inside out sutures.
Yeah, 2 all inside in the posterior part, then inside out here, here, and maybe anteriorly 1 or 2 more.
Okay. So how many?
That is what is my planning.
All inside.
So any difference in the opinion from the panel regarding this?
I personally feel that being a mobile part of the meniscus in the center, it is a wiser decision to pass in the inside out sutures initially, and then at the end I prefer to pass in the all inside devices as the last step. I prefer to fix the inside out devices first. To decrease the mobility of the meniscus to the maximum. That is what my approach is. Rests, Dr. Rajendra?
Yes, that can be done, definitely. But I feel it sometimes difficult once you to go in the back after you fix the meniscus nicely, and we have
all inside.
We can do no problem. That also can be done.
Are good.
That's why we have done this stitch to hold the meniscus in place. We have not tied the knot. If it feels that it is quite well and perfectly holding, then we can tie it, or else we can put another stitches there. So if you can see, this much is the tear. So what will you prefer, a vertical mattress or horizontal mattress in this sort of tear?
একবার ব্যাক অ্যাডভান্স করে একটা ফায়ার হয়ে যাবে।
So what's your preference?
I think I will, regarding the length of the tier is really big, so I may prefer a horizontal mattress. Bite will be here, second bite will be here, another I will take first bite here, second bite here, or in this part I can take a vertical one, but in that most posterior part I can take an horizontal one.
So
if you see that if you are trying to take a vertical one, then the capsule is really behind this. So you need a bigger bite. So that will be difficult. So here I think horizontal mattress, then we can go for an vertical mattress, then rest of the things can be taken care with an inside out. Here.
Looks good.
First horizontal?
First, yeah. Yes. So we will take out the guide now. Now we can see, so depth we have taken 20?
18.
18. Okay. So this will be our first bite that should go within the body of the meniscus.
Back. Then first bite.
So push
Yeah.
completely until you reach completely,
Yes.
then fire. Once you are fire, then slowly come back. And while you are coming back with all these all inside devices, we have seen many failures, and budget is always an issue. Next, again I took this karo. Yeah, you should have a look of the tier, and then pierce, go completely push in, then fire again.
How far do you keep the 2 bites?
You can give yes, so almost 1 centimeter you can give a gap. Pusher. So never pull the threads in with your hand. Here it tends to come out. So always take the suture cutting device or some sort of otherwise you can push with probe if you have other portals to do that. Then pushing the thread in, then you pull slowly you tight. Here if you can see here, yes, slowly, yes, yes, slowly, yes, fine. I think that much of tightness is okay to me, so I'll now cut it. Yes, take it. So this is our first stitch, looks fine.
Yeah. Looks stable.
Yeah. So another all inside, I will see whether it is possible to reach that corner with this. I think we'll shift the portal and will come from the anterolateral side. That trajectory would be much better, being from the anteromedial side. So I'll again shift my portal. So for meniscus repair, you need to be very free shifting your portal, and you should be aware of looking the knee from the medial side. Sometimes the orientation matters. So that thing should be practiced in between. So if see, just once you have changed your portal, then your trajectory becomes very nice. So we can go for a vertical mattress here, because we don't have that much of space to keep an horizontal mattress. But I think one vertical mattress will, this much will cover up, close up the gap here. So your meniscus will be like this. Then rest of the things will tackle. Chalo. So what is the experience of the panel with all inside devices? Because I think it is very easy, but sometimes it is very unreliable also.
I feel one should always be prepared for few failures with the all inside devices. And that is where the key is.
Yes.
Once
So
in a
always
while,
be
they will fail.
prepared for inside out and outside in needles. Keep always in your meniscus repair set and keep very handy. Fire. Yes. So one fire here, then another. So see the meniscus, I am finding it very hard to push in. So because it was torn for so long period, it has become really hard. But again, it is more than 1.5 year, but it's a young adult active person. We should always try to repair this sort of meniscus, and because we are doing an ACL reconstruction, so the marrow will come in and chances of healing is good, I think. So that should be tried. And with these all inside devices, always keep a knot cutter, because sometimes you tend to cut it with your punch and other things, then it tends to come out and it causes problem. So all implementation on all steps should be followed properly, otherwise it's difficult. Because here now the knot cutter is not working properly. So that is why we are getting delayed here.
I think cutting with punch is a big no, because
Yes.
at the end the punch doesn't cut more than 5 times and then it stops cutting the meniscus. And all of us have had this experience, I suppose, sometime or the other, damaging one punch.
So next, once we cut this, then this much of the tear is left. So what do the panelists feel? They will give two stitches or 3 stitches will be required here. We can give one horizontal and maybe 2 vertical. That may be done.
Combination shall work fine.
Yes. Needle দিয়ে এটাকে পরিষ্কার করে না
For the anterior part of the tear, you can try outside in as well, Arnav.
Yeah, Sunita?
Yeah, outside in for the anterior part of the tear.
Yes, that can be also done. But see, we are looking from the anteromedial portal, that's why. If you look from the anterolateral portal, I'll show you. Can be managed. We can go for outside in, no problem.
Okay.
Ano halka? Bas. Right to? Yes. Jada. So we have used this, if you can show the camera, we have used this all inside device of OsteoCare because it's mandatory to tell about the product we are sponsoring. So there is this osteo stitch, and luckily today it actually worked nicely, because if you follow the steps properly, all inside will work for you. But sometimes it happens that it may come out, but this is very good, and we have been using of late this osteo stitch. So again we'll shift the portal and see, just to see our repair. So this much is left. So I think we can target from inside out also, and 1 stitch from outside in for the anterior part, that we can do. We have outside in needle, excuse me.
So what is your...
I need to check if they have some...
preferred suture configuration. It's a vertical mattress or the horizontal mattress is majority of the time? Vertical suture?
If the tear is very long, I'll prefer a horizontal mattress. But vertical mattress can be done, but you need more of them. So just to save time, and we can give. But horizontal mattress is I think better in first as far the stability is concerned.
Inside out niche, doctor. Okay, inside out niche.
Inside out, inside out needle. Needle and barrel. Okay.
How much you do the inferior stitches and superior stitches to prevent the sort of any inversion kind of thing? So what should be the
That
ratio?
can be prevented if you here if you can take another stitch down, then you can prevent this one.
Yes. So what should be the ratio?
To answer your question, if you use more of vertical mattress stitches, with the vertical mattress, the lifting of the inferior surface is more. So with every 2 vertical.
So here you can take another portal also, and then you can repair till we are able to do and see nicely. Then you can do with this portal and come from the another. So we'll try to gather the materials for outside in also, if you can able to show one outside in stitch also.
Even 2 vertical followed by 1 horizontal, you will not notice a lot of regression.
Yes. So one thing would be nice that if you can give 1 horizontal stitch, in between 2 horizontal, you can give 1 vertical. That would make things better.
So one thing, Anand, do you use fibrin clot or something to enhance this the healing rates? Any other augmentations?
Fibrin clot sometime when actually only meniscus repair is being done, but I have used micro drilling in only meniscus, but in ACL definitely lot of marrow will be there. So I don't think in ACL cases. So here we are planning for an horizontal vertical stitch.
The best augment for meniscus healing is when you do ACL reconstruction. So
Yes,
if you
yes.
are doing ACL reconstruction at the same setting, so probably there is no need of other added augmentation.
Yes.
So anytime you feel that you should do the femoral ACL drilling first, and then put in the all inside stitches in the posterior horn of medial meniscus, do you plan that way or like this only?
Yes, that is an also a good idea because the marrow will be already there. But again,
The hyperflexion maneuver that we need to do for the femoral tunnel drilling puts excessive stress on the posterior part of the meniscus. Do you feel
so this
anything?
is the vertical stitch we have put. So 1 horizontal, 1 vertical, and again, if you can do 1 outside in, then I think that should suffice. So we'll see if the needles are available outside in. That's it. So we can do some jugaad, or we can do 2
That's a very good question.
vertical.
Rolling.
You can use a large bore needle for outside repair.
That is what we are using. Look at the loop.
Do you have angled cannula?
Yes.
Do you have angled cannula for inside out repair?
Zone specific.
Zone specific. Zone
Yes,
specific.
yes.
So will you please show our delegates angled cannula or zone specific cannulas?
Cannula. Zone specific. So here I think we have used this one.
Camera focus.
Camera dakhao hatute. Can you show the outside picture?
So there are zone specific cannulas for inside out repair. So that makes our life much easier. And because of these cannulas, now we can repair almost all meniscus by inside out technique only. The problem with all inside is it's very costly, and most of the time it fails and it adds to the cost.
The cannula we have used, so you can see its angle.
Zoom it.
Two lumen double barrel sort of. Different angles are available to address the medial and lateral meniscus and different parts of the meniscus. and single bore cannula sort of things is also there. So this must be there in your meniscus repair
So it's a 10 degree, 20 degree and 30 degree, isn't it?
Yes, 10, 20, 30, yes.
And one is straight. So you have 4 cannulas, so you can reach every part of the meniscus.
We have a meniscus repair workshop. I think they can have a look at that, because it's in, people are finding difficult to focus on the zone specific cannula. So Arnav, you can carry on your work. We have a separate workshop on the meniscus repair as well. So we'll show the delegates the meniscus zone specific cannula during that time.
Which threads have you used? Arnav?
Yes.
Which threads have you used? What size? And
We are using Prolene, I think. Prolene. 20? 20 Prolene we are using with
For
the whiteboard needle
for the outside,
passing.
is it? This one?
Yes, out.
All the, I mean, the inside out sutures are usually the 20, I mean, non-absorbable braided ethylene sutures.
Yeah. So we need another portal. We'll create another portal, or we'll hold it just straight out. We have to hold the meniscus with a probe there. Because once you try to push in, then you will be going to displace the meniscus at the body.
So do you use these specific needles which are supplied for the all inside, or you can use the any IV needle or the TURP set needle which?
Here we are using the needles which are available, provided with the TURP set.
Okay.
So that is quite whiteboard that we use for our MCL pie casting.
Yeah. So that MCL pie crusting has affected the sharpness of the needle, I think.
Yes, yes. Yeah, this is okay. Yeah.
Here one simple trick. Many times we insert the needle first, then we try to insert the Prolene.
Yes.
But what happens with the flow of water, it's become difficult to insert the retriever Prolene. So there is a simple trick. If you load the needle with the Prolene beforehand, then it becomes easy to retrieve the Prolene.
Very nice.
I think
so.
I learned this.
We can have a loop now. So what we'll try to do, we'll try to put the another part of the needle from here, and we'll come through the loop and take out the suture. So that way it will reduce one step.
Yeah, and for the repair part, which suture you are planning? I mean, this is for the passing the loop. You are using the Prolene, and for the repair part, which suture you want to use?
20 fiber wear we are using.
Okay.
So this is not okay. I'll go a little bit there. Yes. This I'll accept. So if you can see, I'm coming out with a fiber wear. Then I'll go through it.
Arnav, are you not concerned with the bevel of the needle causing some damage to the thread?
A little bit, definitely. So now we'll go through the loop, and through the loop we can look the turn. Look the Prolene loop. So একটা না দুটো হ্যাঁ ওকে 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 এটা নয় নিডলটা করো yes this is the suture yes so Abhijit is assisting me very nicely and helping me. Without his help I cannot be able to do this. So take out the needle now. Yes. So now if you can see, loop for it. Now we can take out the Prolene out. Yes. Yes. Tano? Yes. So this is what? Do you need to put any more, or I think it should work? Sunita?
Yeah, it looks very nice, I think.
So we'll tie at the end. We'll keep the sutures now and we'll go for the ACL.
Yeah.
Table down full. Graft देखो, इकना देखो. Cameras can show the graft here. So here we are using adjustable loop in the femoral end. We'll be using, and one adjustable button in the tibia. So we're not using screws. So it will be all inside equivalent sort of ACL reconstruction, not all inside exactly.
Yeah. So any particular reason, Arnav, or just to so that these options are there, you can use it, or what's your take on this system?
So my first preference is always putting a screw in the tibia. Unless we put a screw in the tibia, we are not very much satisfied. But these options are nowadays coming out nicely, and the buttons are actually blocking the tibial tunnel, and there you can tight the graft very nicely. So slowly and gradually, I think maybe you are using this sort of system more and more. But to me, still now the gold standard would be putting a interference bias screw in the tibia and a rigid loop or adjustable loop in the femur. That is what is my most preference. But the other options are also there. You can put screws both the ends. You can put adjustable loops and make it all inside.
Yeah,
or
so more or less we don't have any consensus on what exactly should be the best fixation method. So we have good results with majority of the fixation devices we have today. But I think in my opinion, I think the weakest link in the ACL is probably tibial fixation. So you probably have the weak bone interference screw might sometimes leads to in the chronic the cycle might sometimes give away leads to grade 1 or grade 2 laxity. So these loops, adjustable loops, which usually gives you once you use that adjustable loop, and you can close that loop as well over the button, so that gives you a much more stability than the interference screw. So I think we need to investigate it much more further to have a concrete evidence that which one is superior to other.
Right, exactly. So this is the part of the ACL I was talking about. So we have dissected it nicely. You can see how it was healed over the PCL. This was the part of the remnant which was there. So it was not attached with the femoral condyle, lateral femoral condyle. It is totally empty. And see, you can go up to the back of the femoral condyle. Yeah. You can see. And if you palpate with your probe, probably this is the residence wreath we are gliding. So we need to be posterior to that resident wreath.
Yeah.
And like this area, we should aim for.
Yeah. So I think Arnav, so there are a lot of views regarding how you should start doing the femoral tunnel position. So whether you prefer the all technique or you prefer the offset jig?
So today we are going for an offset technique. Otherwise, what I usually do, we can go. I usually take with my 4.5 drill bit. Then I take a bead pin, and then I check with the bead pin whether my in other, and I come to another portal to see if I am trajectory is fine or not.
Yeah. So what is the offset? How much offset it is?
So the 7 mm offset it is.
And the graft is?
The graft is 9.
Okay.
Thickness is 9. And once we are in, then we'll flex the knee to 120 degree. And in this patient, even more, we can able to do more. So this is what I should expect here.
So, Arnav, just to give a little bit of guideline for the audience. So how far above from the inferior cartilage you tend to start?
Yes. So if you can see from this is the at least 3 to 4 millimeter from the anterior cartilage line, it should be back.
Yeah.
And another thing is that you should be behind the residence ridge if you can palpate it properly.
Yes.
And it should be really low down. So what we tend to do mistake is that we tend to be on the higher side.
Yeah.
But ACL is really lower down. If you can see from this also, ACL is lower down. And if you don't flex the knee, you will end up in doing in the higher side. So you have to flex, hyperflex at least one.
So you need to be low and deep, isn't it? As far as your starting point is concerned.
Low and posterior.
Yeah. So this, I mean, the terminology has a little bit changed. I mean, shallow and deep is what we call it, and because the posterior is actually in the inferior part. If you go by the anatomy, since the knee is in flexion, hyperflexion, the inferior part is the posterior part. That's why the anatomy has been changed, renamed like shallow and deep, and then I mean the high and low.
If we can show the camera where the pin has come out from the outside of the knee.
Yes. So what's your guideline on that? It should come through the iliotibial band. You're happy with that? Or you what is the girth, as far as the girth of the thigh is concerned, where it should exit between the anterior 2/3 and posterior 1/3 junction?
Yes. So I'll be happy if it comes on the anterior third of the iliotibial band.
Okay.
So that's what I aim for, but sometimes we have to settle down in the middle part also.
Yeah, you're lucky that you are getting lean and thin patients, so that you can come up with the anterior third. But
yes,
I think majority of us ended up being on the posterior third of the thigh.
Third or middle part of the iliotibial band.
Arnav, this femoral tunnel, what is your expectation? How far will it be from the inferior cartilage, the final tunnel?
From the inferior cartilage?
Yeah, like from the inferior part of the cartilage of femur. How far are
I
you
think
expecting?
More than 4 millimeter, it is definitely deeper.
Yeah. Okay. I think.
And another thing I always check that when you are drilling, this should almost touch the PCL. If it is there, that means you are deep. But if it is far away from your PCL, that means you are.
Arnav,
So I think
Arnav, our question is how far from the inferior cortex?
That is from the tibial side.
Yeah.
Here cortex of
femur. So deep it's clear, 2 mm. There should be minimum 2 mm of bone posteriorly.
Posteriorly 2 mm of bone should be there. That is why.
What about inferior?
Inferior also 2 to 3 mm cartilage. At least 2 mm from the inferior cartilage you should be high up.
What is your graft thickness? 9.
My graft is 9.
9. So 4.5 and 7.5. At least 7 mm from the
7. Yeah.
So how much is your length of the tunnel?
So we are stopping. We're drilling with 4.5 drill bit now, and at the second cortex. This is the second cortex resistance we could feel. So we are yet to enter 35. So maybe then we'll measure it. Once we drill it, so it is almost 40. So it will come out around 40. Yeah. Take out the pin and let's measure it. John.
So you will be using the fixed loop on the femoral side?
Adjustable loop.
Both on femoral and tibial side?
This side, yes. On the tibial side, adjustable button and with cortical fixation and fixed loop. So it is 38, 36. 36. So especially in this short stature, lean and thin patients, sometimes the talents are less. So better to go for adjustable loop. And we are planning to keep 25 mm of graft in the femur. So we'll drill with 25. 25. 20 go. We'll keep 20. 22.
As your tunnel length is 36. So
yes.
Why have you opted for adjustable loop? Any advantage?
You can tighten the graft later on, and most of the tunnel will be covered with graft. There will be no empty spaces, so later on chances of loosening is less. But we can use fixed loop. At least till you have At least 30 or 35 mm of tunnel you can use fixed loop. 20 you are entering, yes. We plan to keep 20 at least 20 mm of graft, but we'll drill 2 mm extra for later on tighten. Bas, remove. Okay, thank you. So what is the preferred for the panelist? What do you use for adjustable loop or fixed loop?
Adjustable loop definitely makes your life easy, but it comes on a cost. So it's you know, if the tunnel length is more than 30, I go with fixed loop.
See, if you've got a good tunnel and you're very precise with your calculations, you're getting a 25 millimeter hold, then a fixed loop most of the time. Adjustable, if there's any doubt and you're not sure whether you would need to tighten the graft later on, then adjustable. But
so have you encountered any case of loosening later on in where you have used an adjustable loop or something?
Arnav, it is very difficult to say that the loosening that has occurred, that 2-3 mm, has occurred at the level of your graft, your tibial fixation or your adjustable loop. It's a very big question which cannot be really answered in our practice. So I am a total adjustable loop guy, 100% for the last 5 years now. And I feel at the end of the surgery, if you tie a knot at the top of the adjustable loop and convert it to a fixed loop, it gives you advantage of both the techniques. So I am a through and through adjustable loop guy for the last 5 years. And I feel the loosening of the adjustable loop cannot be really ascertained in our clinical practice. It is only the lab conditions that can prove what it actually happens.
Yeah, also there is no added advantage of using that two adjustable loop on both the sides. So you can have adjustable on one side, that will do the job, I think.
Actually, we are thinking more about femoral fixation only. Maybe the weakest link is tibial fixation.
That is possibility. But in some cases of all inside ACL, I have seen in X-rays, when you see the loop on the femoral side is not sitting exactly on the cortex. If it is little bit of floating, and patient is having a loosening, that can give you a clue that there is some loosening on the femoral side or maybe tibial side.
No, maybe you can argue, but I think there are even bigger consequences of that. When if you end up landing above your iliotibial band, then that's a separate problem altogether, isn't it?
You have to be very careful while you are pulling the loop there, and you have to mark your calculated length. So this is our femoral tunnel. Sunita, is it okay?
Yeah, it looks perfect.
Thank you.
It's a neighbors envy owner's pride sort of. Onita.
So now planning for the TVL tunnel. So for this we can see the anterior horn of the lateral meniscus, anterior border. If you can draw a line here, you will come in the stump of the ACL. But what I do, I tend to be little bit on the flare of the medial tibial spine. I'll go a little bit posterior because it is an elbow reamer. So your pin will come at the angle of your device. So this is, so the guidelines for the audience sake is that you have to track down the anterior border of the lateral meniscus, come within the stump, and then you feel both the spine, tibial, both medial and lateral spine. Then you can be at the center or little bit of medial, just at the flare of the medial tibial spine. So you should come at this gauge, and it should be all around 7 millimeter posterior to the. So it has come little bit medial, so we can change corrector, or we can use a sequential drilling like this. So this I like to right nicely. Soft tissue, yes, go. So 7 millimeter front from the PCL and a little bit on the flare of the medial tibial spine. Slowly you should come, otherwise, yes, come. Yes, okay, perfect. So this is what I aim for. Any opinion from the panelists regarding this?
At least. Yeah, it looks good from my side, but I think only thing is it looks a little more medial. So more medial, you have chances of PCL impingement is more, I think. If you can have a look from the anteromedial port, then you can have a better idea.
4.5.
We'll do sequential. If a graft is more than 8, I try to do sequential drilling. Like initially around 4 or 5 I drill, then with the length, with the thickness of the graft that I drill. And the two advantages is that, as Sunita said, if you want to, lateralize the tunnel little bit, then you can also do, if you do sequential drilling. So that option is there. And sometimes in very young patient, hard bone, it is easy that you do sequential drilling.
Arnav, I think sequential rimming is always advisable, because if you drill by 8 or 7 directly or 9 it will there will be some thermal injury.
Yes.
And we want the tunnel to be biologically live. So if you are drilling with a larger diameter drill, probably it will harm or it will take more time to incorporate the graft.
Yes. So as Sunita told, we'll try to lateralize it little bit so that we'll be exactly at the center.
We can cross check by advancing the guide wire also.
Yes.
You have used all the 3 landmarks for the
We're
AC.
trying to keep the stump as much as possible.
You have used all the 3 landmarks for the ACL tunnel?
Yes. So slowly you should come, because if you come too fast in the joint, then the stump may not be, can't be preserved. So slowly come.
How much is the diameter?
Graft diameter is 9.
Yeah, 9.
Is correct too? Back. So you can, now we can put your paper and check that if you can come. If required, you can take out some little bit of the posterior soft tissues here, and that makes the graft passage easy. So fairly enough, we have preserved this stump of the ACL, and we are actually at the center. I can try to show it from the lateral portal also. Let that thread come out, then.
Yeah. So I think, Arnav, it's a very common to see this a bit of metal debris on the tibial side. So if you can remove those with the saver,
yes, we'll wash and we'll remove everything.
Yeah.
Yes. So let us see if you can see from the medial portal. And so this is our femoral tunnel. We have cortical bone left, and we are really deep, as far as Sunita suggested, deep and down. And this is the tibial tunnel and medial tibial spine. So maybe we are at the center, not very medially initially that we thought. We will take out the metal debris now, because it passes the grafts. Okay, go ahead. So now we'll pass the graft. So we have show the graft and the marking. Cameraman.
Camera. Hey.
You shall
Cameraman,
be using
please.
a screw. Arnav, you shall be using a screw on the tibial side.
Table देखा. अभिजीत, graft का table देखा. Sorry,
I would request the cameraman to focus on the table to show the
graft can be shown.
Can you switch the picture, the bigger and the smaller one?
Yes. Show the graft here. एखाने. So this is the graft, and this is the adjustable loop here.
Arnav, can you hear us?
Yes.
Can you tell the cameraman to show the graft here?
Yes. ক্যামেরা এই ছবিটা দেখো, এই ক্যামেরাটা শিফট করো।
Right.
Yes, হ্যাঁ, নাও। Okay. So this is our
slide zoom out.
আমার হাতটা দেখতে পাচ্ছ না তুমি? Yes. একটু কাছে আসো না, দেখাও না ভালো করে। This is the graft and this is the adjustable T button we are going to put in the tibia, cortical fixation, and this is the adjustable loop. So our aim for the graft is 20, so we'll mark 20 in the femoral side of the graft, and our 36 was our tunnel. We'll mark 36 in the loop. ভালো করে mark কর, so that we can understand when the loop is over the femoral condyle, and we'll mark 20 from the femoral end of the graft. So total graft length is 75 and diameter is 9. Okay. Antibiotic use antibiotic. Chalo. No. Abhijit, Jana. Aste, dekhe, dhore dekhe, not fast. Okay. Inside picture, please. Inside picture, show the inside picture. Yes. So see our loop is going. So yeah. No. Yeah. Slowly. So there is trick for the adjustable loop that you should not pull too much. Slowly, gradually you should pull. Arektu. Then you can feel when your button is arektu tanta. So now we have reached the mark. So we will now see flip and see whether we have flipped on the femoral side or not.
Arnav?
Yes.
We would break in for a bit and continue. And maybe once you're done with your meniscal root tying, you can show us the final picture of the knee.
Yes.
It was nice, and thank you. And we'll take a break from the OT.
Okay, sure.
Thank you, Arnav.
Thank you. Yes.
Thank you to the chairperson. So we are running a bit late, so we'll move on to the lectures as quickly as possible. Lecture is going to be Dr. Alok Kumar Maiti for ACL avulsion repair relive. And before that, this is a small screen. This is a membership drive that we are having. So as Rajiv sir mentions, this is a Tatkal drive. So what we are going to do is I'm going to just demonstrate with a very small video how to do it. We can simply use the mobile phone that we have and go to Google and search IAS membership. So basically this is the second link which comes up. So we apply for the we sign up for this. Then we go down. So we have to verify our email first. So whatever email ID we want to receive an OTP on. Okay. So this is the IAS membership drive that we are having in Tamluk. So I'm requesting all the members to have a quick look through the video. So go to Google and search IAS membership. So this is generally the second link which comes up. So we apply for we apply for the IAS membership after verifying our email IDs. So whatever email IDs we want to receive the OTP on, we put it and we press verify. So the code will come. The code will come in your email. So generally, since this is a lot of membership applications come in, the code might also be in your spam account. So go there and get the code, whatever it is, and then put in your password of your choice, and then you can easily sign up through this. So this is the password that we have created, and obviously we have to check the spam account as well for this. And then with the email ID that we have, we can put in an email ID and then simply put in the password and we can log in. So for the new members, you have to keep 3 documents in waiting. One would be your MBBS certificate, one would be your MS certificate, and one would be the medical council registration. So preferably in a PDF format. So when you go through this, then step by step there are 3 sections. You will have to upload the documents alongside your data and everything. And after that, when the data or documents are sent, the documents are processed by the IOA official who gets the link, and after the verification of the documents, the payment link will come to you on email. Based on that, you can simply pay, and immediately or day after, we can have the thing sorted out. So processing will be done as early as possible, maybe as soon as tomorrow. And these are the few contacts. You can have my number and Devananda's phone number also. So if you are having any issues, if you're getting stuck at any particular situation and not understanding, definitely you can tell us. And so thank you. And without taking much time, I would shift to the next speaker. Sir, please come. Sir.
Sorry. Hi, good morning everybody. I am Dr. Alok Kumar Maiti, going to present ACL avulsion injury. What is ACL avulsion injury? ACL avulsion injury, when the ACL ligament is avulsed of the bone along with a small fragment of the bone. It is commonly occurs on the tibial attachment site of the ACL. It is more common in children and young adult. What is the presentation of this ACL avulsion injury? In acute cases, they may present with pain, limited range of motion, knee swelling, and inability to bear the weight. In chronic cases, joints instability, recurrent effusion, restricted active and passive knee extension. ACL is primary stabilizer for resisting anterior translation of the femur on the tibia and control hyperextension of the knee, secondary stabilization of the internal and external rotation as well as varus and valgus stress. This injury mainly occurs through a valgus force applied to a flexed laterally rotated or externally rotated knee with foot over the ground, or hyperextension with medial rotation. Less commonly are hyperflexion or direct valgus force. What is the diagnostic modalities of this ACL avulsion injury? This may be X-ray, CT scan, or MRI. By X-ray, maybe we can see the avulsed fragment, especially on the AP and lateral view. And CT scan, by this CT scan, we can measure the size and is there any comminution or not. And by the MRI, we can determine the other concomitant injury. What is the classification of this ACL avulsion injury? Type 1 is undisplaced, type 2, type 3 and type 4 is displaced. And type 2 is anterior elevation of the fragment, type 3 complete separation of the fragment with involves majority of the eminence, and type 4 comminuted or rotation of the fragment. What are the treatment modalities of this ACL avulsion injury? There may be conservative, may be operative, and especially for type 1 for conservative management, and from type 2 this done by operative management. Why we need to fixed? There are 3 reasons for this fixation of this avulsed fragment. Number one is stability. For stable knee, we should need the anatomical reduction and internal fixation of the fragments. Second is restoration of the proprioception. If in untreated cases, there is malunion, and in malunionated cases, there is loss of proprioception. And third is avoid loss of extension. Any bony bump in the intercondylar eminence, there is loss of extension. So it should be fixed properly. What are the fixation options? By fixation options are, we have evolved ourselves from the KOR, by screw, by staples, and recently this is arthroscopically fixation. What is the fixation methods? By open or arthroscopically. Both can be used by fixation of this avulsion fragment, but we have shifted from the open to arthroscopically gradually. What is the surgical management? It may be open reduction internal fixation or arthroscopical pull-out suture technique. Open reduction is good for large and single avulsed fragment. Internal fixation devices like CC screw or hardware screw can be used in cannot be used in skeletally immature patient. Arthroscopy pull-out suture technique is minimally invasive, faster recovery, can be used in skeletally immature patient. Open technique is simple and very low cost instrument. Open technique, no special training is required, and there is short learning curve and easy to adapt. ACL avulsion fracture fixation by screw advantages are provide direct compression fixation across the fracture site, avoids placing of the suture piercing through the ACL, and disadvantages are fracture fragments may be too small to accommodate screw, second surgery for removal of the screw, growth disturbances in pediatric age group due to epiphyseal injury. Why arthroscopy? Less invasive. So, if there is less soft tissue handling and minimally less post-operative stiffness. And there is short video.
The patient was laid on supine position with knee.
Patient's position is supine, leg is hanging from the table, and all procedures are done in 90 of flexion. First, two portals are made initially, anterolateral and anteromedial portals, and from this anterolateral anteromedial portals, first diagnostic arthroscopy is done, and then first and most important is the saving of the debris over the fracture sites, and this is the intermeniscal ligament, and sometimes this intermeniscal ligament can be resected for the proper fixation and anatomical reduction of the fracture fragments. And then first step is the debridement of the tibial crater. We should remove the all soft tissues and debris from the tibial crater, and after the tibial crater preparation, we should prepare the fracture fragments by the sever. And after this done, the two sutures are made over the osteotendinous junction, one from the medial and one from the lateral, and first sliding knot is applied, and 3 to 4 half inches knot is applied to over the ACL and avulsed fragment, And after this preparation, we should go to the formation of the two tunnels of the tibia, one anterior lateral, one is medial. And most important features, important points is to reduction, the avulse fragment should be anatomical. There is no overhanging over the anterior, lateral or medial. And two tibial tunnels are done over the anteromedial aspect of the tibia, and two suture lassos are passed through this tibial tunnel, and from this suture lasso two fiber wires are two fibers are taken out from this tunnel, and over the tibia these fibers are tightened by pulling. And at this moment we should notice the proper anatomical reduction of the fragment. And what is post-operative care? Yes, this is very important. Keeping extension in knee for 3 weeks, slow rehab, full weight bearing at day 1, normal activity at 12 to 16 weeks. Thank you.
Thank you, sir. So we'll go back to the live surgery. Arnav sir wants to show us the final picture of the live. Can we go back to the OT, please?
Hello, Arnav.
And the next speaker is Dr. Rajendra Singh Ghai, sir.
Arnav, can you hear us? We can see that the ACL has nicely been reconstructed. You are showing the remnant which you have preserved and the meniscus repair part as well. So I think we can't hear you. So we are waiting for his voice. Hello. Yeah, so that we can see that the meniscus repair is still holding very nice after the ACL reconstruction. And yeah, I hope that you have already tied all the sutures. There is no impingement in extension as well. So your graft looks perfectly positioned on the tibia as well as on the femur. So I think this patient should have a good recovery. But unfortunately we can't hear you, Arnav. So I think we are running late. So we are signing off, and we are thanking you for the nice demonstration of ACL reconstruction as well as the meniscus repair. Thank you. From a big round of applause from the hall. So you can hear the applause, Arnav. Thank you.
Okay, so good morning. My little talk is about lateral extra-articular tenodesis. Now, we've all seen, isolated ACL reconstructions often do not fully restore the rotational stability to the knee, and that has been confirmed by various biomechanical and clinical studies. And this persistent pivot shift and rotational instability causes various problems. There's a lower rate of return to sport, greater re-rupture rates of the graft, and poor patient-reported outcome measures, and potentially earlier progression of the degenerative knee disease. So what we know so far is that ACL tears are often aggravated by concomitant injuries of the anterolateral complex. So it is this anterolateral complex which increases the rotational instability of the knee. And if left untreated, these injuries could compromise the outcomes of ACLR. We do a very good ACL, but the patient continues to complain of instability. So that's where, you look back and you think, whether you've missed an anterolateral complex injury or not. So the risk of re-tears, subsequent meniscal injuries, and patient dissatisfaction remains. So various biomechanical and clinical evidence shows that if you supplement an ACL reconstruction with a lateral procedure, for most of these anterolateral complex injuries, that reduces the pivot shift and the rotational instability. And this recent meta-analysis shows reduced re-rupture rate by almost 3 times compared to isolated ACL reconstruction. So where does this anterolateral complex comes from? 1879, even before the X-rays were, Paul II described this avulsion fracture. we've all seen this sort of fracture on the X-rays, and it's anterolateral proximal tibia, and he described the presence of a fibrous band at the location of this fracture. And then the interest in anterolateral complex sort of was renewed in 2012 when Vincent published this paper, an anatomical description of the anterolateral ligament. So this arises from the lateral epicondyle of the distal femur and is attached to the proximal tibia in between the fibular collateral ligament and the Gerdy's tubercle. So this is a ligamentous structure which comes under tension during internal rotation at 30 degrees. So most of the patients with anterolateral who have had an ACL reconstruction would complain of instability, especially when they're bending the knee, coming or going up and down the stairs. So lateral extraarticular tenodesis are all these surgical procedures which are performed along with the ACL reconstruction to enhance the knee stability, particularly in patients who are at a high risk for rotational instability. And several techniques have been described, but the consensus about the patients who need this procedure is mainly patients who are young, patients aged under 30, who have got a concomitant medial meniscal tear or a generalized ligamentous laxity, and of course athletes in pivot heavy sports, athletes who have got a very high impact sports and exercises, and in some or even most cases of revision ACL. And various techniques, the original technique which was initially described was by Lemaire, and then there were various modifications of Lemaire, and then the Bony procedure, either the Ellison or modifications of Ellison, and then a combined procedure, especially in children where you need to do an ACL reconstruction without doing two tunnels. So that's the Macintosh. I'll come to them. So the Lemaire is the original procedure described in the 80s. And essentially, Lemaire took a strip of iliotibial band, made two holes near the attachment of the anterolateral ligament, and used a nylon sort of a core, nylon braided suture. And he stitched that with the iliotibial band and fixed it with anchors at both the sides. So that was the original paper, written in French, in the French literature for a long time, not evident in the English literature. And then after this paper came the modifications of Lemaire, and there are basically two modifications. First is by Crystal and Jana, and he took a little smaller strip of the iliotibial band, made a hole in the femoral, sort of near the point of attachment, the Krakow point where the ligament is attached, and essentially he sort of passed this iliotibial band under the fibular collateral ligament and fixed it with a screw. So this is the commonest procedure which we do, and this is what is commonly described in the literature. And then, this transverse tunnel functioned very well in restoring the biomechanics of the knee. And the second procedure, this involves only soft tissue, so no involvement of bony tunnel, and this is preferred in children where you don't want to disrupt the epiphysis. So strip of iliotibial band passed under the fibular collateral ligament, and then it's sort of turned around in a U and then reattached back to itself. So no bony tunnel, no interference screws. And this procedure was easily reproducible, required a shorter surgical time. There was no risk of damaging the distal femoral epiphysis. So this was also very common in the literature. And then the Ellison is a bony procedure. It's like the distal realignment we do for recurrent dislocations of patella. So the distal part of the attachment of anterolateral ligament is taken up with a little flake of bone, and then it's sort of passed under the fibular collateral ligament and is reattached slightly anteriorly, and that stabilizes the anterior lateral ligament. Macintosh described a lateral substitution with over-the-top technique, and this is where you have an ACL deficient knee, and he took a long strip of iliotibial band, and this was sort of braided in by a whip stitch, and then he passed this into the femoral tunnel, back into the inside of the knee, comes out to the tibial tunnel. So essentially the same loop goes around, reconstructs the anterolateral ligament, reconstructs the ACL, and then he fixes on the tibial side with either anchor or over-the-top sutures. So this is what it looks like. So the most described risks and complications of the lateral procedure is overconstraint of the lateral compartment. Your overzealous tightening of the lateral ligament will cause a lateral constraint and early degeneration of the lateral cartilage. Then there are tunnel convergence issues with when you're having an ACL femoral tunnel and you have another tunnel to fix the femoral part of the lateral ligament. And then the graft failure risk if the graft is not prepared properly. So the conclusion is proximal bony and soft tissue fixation techniques have lower residual anterior and anterolateral instability compared to distal bony fixation. So distal bony fixation are not as popularly used as the proximal procedures. And the lateral procedure improves rotational stability, it reduces the graft failure rate, it improves the return to sport rate, and it's beneficial in specific cases. Of course, you have to be very perfect in your execution of the whole surgery, and it requires proper indication. Thank you.
Thank you, Rajinder sir. So Subarna Mishra sir is in the OT right now. So I invite upon stage Dr. Subrottim Giri sir for quadriceps harvest, his technique relive.
On করে দিয়েছো?
Good afternoon. Quadriceps tendon harvest, my technique. Dr. Supratim Giri. Next. Cruciate ligament injury is the most common ligament injury in the knees, and reconstruction of the cruciates has shown promising and reproducible results. Reconstruction of the anterocruciate ligament
Retractors
was
লাগবে
first
এটি?
described.
Retractors? Open surgery কিন্তু এটা, সেজন্য retractor সব লাগবে।
Reconstruction of the anterocruciate ligament was first described in the 1917 by the Hay groups using the iliotibial band autograft. But the ideal graft for the reconstruction of the cruciates is still a matter of the debate. And quadriceps tendon graft is a...
BP কত আছে BP? BP কত আছে? 107 300 হ্যাঁ।
Quadriceps tendon graft is a versatile graft for the anterior and posterior cruciate ligament reconstruction. And the advantage of the quadriceps tendon graft is the superior quality of the graft, and there is a reduced risk of the neurovascular injury and no flexion weakness, and there is no or minimal anterior knee pain, and there is a customization of the graft size, and there is a reduced incidence of the arthrophyrosis and better patellar mobility. And what is the disadvantage of the quadriceps tendon graft? If the thickness of the quadriceps tendon at the 3 cm proximal to the upper pole of the patella in the mid sagittal section in the MRI is less than 7 mm, quadriceps tendon graft is not preferred because there is a less strength in this graft, and the risk of the penetrating suprapatellar pouch complicating the subsequent arthroscopy, especially the knee swelling and full thickness graft is harvested. And the procedure is to be avoided in the patient in whom the bone patellar tendon bone graft has been harvested previously. And there is a few surgical techniques. Surgery is done under the spinal anesthesia unless it is contraindicated, otherwise general anesthesia is preferred. And pneumatic tourniquet is applied as high as possible in the upper thigh, and during the inflation, knee is kept to be fully flexed to obtain the maximum quadriceps length. The leg is put in the hanging position with the knee flexed at the 90 degree, and we harvest the superficial quadriceps graft from the lateral part of the quadriceps tendon. A 2 to 2.5 centimeter vertical graft, a skin marking is made and starting from the upper pole of the patella.
is the junction at the junction of the middle and the lateral third of the patella, and extending upwards. Skin incision is made with the number 10 surgical blade. Subcutaneous fat is dissected and paratendon is exposed. Paratendon is incised with the number 1 surgical blade and is dissected and retracted with the Langenbach retractor both sides until the quadriceps tendon is exposed. And 2 vertical incisions are made over the quadriceps tendon with the number 11 surgical blade, one at the midline and another at the 6 to 8 millimeter lateral to the midline. The thickness of the graft to be harvested is determined with the 6 millimeter probe or tip of the 6-inch right angle artery forceps, which is also 6 millimeter. And right angle artery forceps is passed through the graft is determined depth. End of the graft is looped with a suture and the distal end of the graft is detached sharply from the upper pole of the patella. The free distal end of this is secured with the whip stitch and non-absorbable suture, and the 2 to 3 centimeter of the superficial tendon is elevated. We dissect the superficial tendon to the deep layer of the quadriceps tendon. A closed tendon stripper is introduced and pushed gently while extending the knee to up to the 30 degree of flexion to relax the quadriceps tendon, and repair of the paratendon with the absorbable suture. The advantage of our technique, minimally invasive technique, and second thing is the simple, do not require any specialized instrument, and early rehabilitation is to be given. Disadvantage of our technique, as we use an ordinary closed tendon stripper, reasonably force is to be applied by the surgeon to harvest the graft. And although we have not come across it, theoretically it is the risk of the quadriceps contracture, and occasionally there is a hematoma formation at the musculotendinous junction of the quadriceps. Now we will play the video. Video to play. Play the video. This operation has been done
to put
by
a
Rajiv
skin
sir.
incision, 2.5 to 3 centimeter of skin incision over the superior pole of the patella. Once you cut the skin and subcutaneous tissue, now go for a sharp dissection with 11 number blade for a paratendon. Try to dissect it proximally with your sharp scissor so that you don't have any fibrosis even after closure of the paratendon. The 8-inch right angle artery forceps is used to measure the 8 millimeter horizontal thickness of the graft. You can see here we are measuring it over the scale, and normally you can put this 8-inch right angle artery forceps to measure the 8 millimeter thickness of the graft. The first incision is over the midline. You can see we are putting our first incision over the midline, and your second incision is 8 millimeter lateral to the first one, and that is your horizontal thickness of the graft. The vertical thickness of the graft is decided with the tip of 6-inch right angle artery forceps, and normally the thickness is 6 to 7 millimeter. You can see the superficial part of the quadriceps is harvested, and you can see the horizontal thickness of this graft is 8 millimeter. Now the distal end of the graft is sharply detached from the proximal port of the patella. You can dissect it with a 11 number blade, and always be careful that you are not violating the suprapatellar pouch, or you are not violating the deep layer of the quadriceps. It is very important to preserve the quadriceps function in due course of rehabilitation in these patients. The distal end of the graft is detached, and normally you put 5 to 6 whip stitch from distal to proximal over the harvested tendon. You can see here, and that is taken to with a non-absorbable suture, either a 2 number or 5 number non-absorbable suture. Now try to dissect 2 to 3 centimeters superficial proximally from distal to proximally the superficial quadriceps. Again, be careful that you are superficial, harvesting the superficial part, you are not violating the deep part. You can check and recheck the deep part of the quadriceps tendon is intact. You can see the deep part of the quadriceps tendon is intact, only the superficial of the part of the quadriceps tendon is being harvested. Once the superficial, you have taken 3 or 4 centimeter of the superficial part of the distal end, you can use your 8 millimeter closed tendon stripper to harvest the quadriceps, superficial quadriceps graft. One important technique at this step, try to extend the knee in 30 degrees of flexion so that you are relaxing the quadriceps, and with the less force you can harvest the superficial quadriceps tendon. Here you can see we are harvesting a superficial quadriceps tendon by extending the knee in 30 degrees of flexion so that whole of the quadriceps muscle is relaxed. Normally you can take out 30 to 34 centimeter of the superficial quadriceps graft through this technique. You can see a long superficial graft quadriceps graft has been harvested. Here the length is around 34 centimeter, which is good enough for reconstruction of your either ACL or PCL or whatever ligament you want to reconstruct. Again, if you go back to the wound, we can see here that the deep part of the quadriceps to put a skin incision, 2.5 to 3 centimeter of skin incision over the superior pole of the patella. Once you
Thank you. It's actually one of the methods which has been cited multiple times. So the next speaker is Dr. Shobhoshachi Shatra sir, who is going to talk on meniscus root repair.
Good morning, everybody. My talk is on meniscus root repair. So meniscus root is the very important structure in the knee, in knee joint injury with ACL or PCL injury. So this is almost a silent epidemic in India and almost in abroad also. The importance of meniscal root tears has been demonstrated by many mechanical and clinical outcome studies. Meniscal root tear is avulsion of the attachment of the root of the meniscus or a complete radial tear within 1 centimeter of the anterior or posterior tibial attachments of the menisci. See, here is the anterior root, posterior root of the medial meniscus, and these are the anterior root and posterior root of the lateral meniscus. The meniscal root tear, if untreated, it leads to meniscal extrusion, increased contact pressures. There is a higher risk for chondral damage, accelerated osteoarthritis, and sometimes subchondral insufficiency fractures. The injuries tend to occur in deep squatting or flexion position. There is often a rotatory component, particularly in lateral posterior root tears. A high proportion of meniscal root tears, particularly lateral meniscal root tears, have an associated ACL injury. Medial meniscus root tears are often seen in older females and obese individuals. So, you must identify the tears of the meniscus or root tears. These are some structures, the MRI pictures to identify the meniscus. This is the normal meniscus. This is like the ghost sign in a sign of meniscal root tear. This is subchondral insufficiency syndrome. There is edematous in appearance. The magnetic resonance imaging is the gold standard to identify the meniscal root tear. The hallmark radiological signs of posterior root tears is ghost sign or lack of radiological evidence of meniscus. The radial tears adjacent to the meniscal root observed as linear high signal intensity perpendicular to the meniscus. The vertical linear defects at the meniscal root, also known as the truncation signs. These are all the MRI features. Now coming to treatment of the root tears. Historically it was believed that radial tears do not heal. So in that cases meniscectomy was the treatment of choice previously. Non-anatomic meniscal root repair is often equivalent to the meniscectomy. So you should done anatomic meniscal root repair. The consensus now in cases of root tears which should be potentially repairable, both chronic and acute tears can be repaired. Better results are with early repair. The degenerative root repair, there is poor outcomes as solitary procedure. In those cases, the HTO may be done if required, the alignment. The goals of repair, anatomically, you should reduce the repair. There should not be any gapping. The torn edges should be in contact with another torn edge, and there must be compression between the torn edges after the repair. The vertical orientation, the compression to circumferential fibers, evenly compress the inferior part, the middle part and the superior aspects of the tear, avoiding entrapment to the surrounding structures. So this picture showing the compression at the tear site. These are the various techniques of the meniscus root repair. Now coming to classification described by Laprade, the type 1 tears are partial and stable root tears. The type 2, these are most common, complete radial tears near the root attachment, subdivided into type A, B, C. A is less than 3 millimeter, B 3 to 6 millimeter, and C is 6 to 9 millimeter from the center of the attachment. Now type 3, these are also called disaster tears associated with bucket handle tear with a complete root tear. The type 4 tears are oblique tears propagated into the root attachment, and type 5, these are bony avulsions. Bony avulsions. See, these are the pictures. This is the oblique tear type 4, this is the bony avulsion. This is type 5. There is a study of meniscal root repair by Dr. Sital Gupta. He added some extended classification of the root tear, type 6, 7, 8. The type 6 is the root tear plus horizontal cleavage tear of the meniscus. Type 7 is retracted root along with a capsular tear, and type 8 in which there is meniscus tear along with meniscus substance loss extending up to the root. So for root repair, 2 tunnel transtibial repair of radial meniscus tears produces comparable results to inside out repair of vertical meniscus tears. And transtibial single tunnel on inside technique also is used nowadays for complete radial meniscus tear. So there is a video. This is the you see there is a radial tear of type 4 variety. So here the picture shows the first reduction of the tear. You should do the reduction. If reduction is possible, then you will go from the repair of the tear, and there must be compression between the tear surfaces. So here the reduction done, and after that the repair is done, all inside repair technique. The side to side repair. See, the reduction is done. And after the passing of the sutures, you must compress between the tears fragments, that is both parts. The torn edges should be compressed with each other. in the superior part, in the middle part, and also in the inferior part. Augmentation, is it needed in isolated meniscus repair? The augmentation may be done with microfracture, fibrin clot, whole blood, or through tibial tunnels. This augmentation is needed for the healing of the tear. Now, the take-home message, the small tears or tears in the white zone can be balanced. The large tears extending up to the capsule to be repaired. Proper portal vectors to be employed. Appropriate visualization is necessary to allow accurate tear identification and classification. Rasping of the torn edges should be used to prepare the tear site for the repair. Premature weight bearing postoperatively may lead to failure with displacement and damage to the repair site. The weight bearing is allowed usually after about 6 weeks. Thank you.
Thank you, Shobhashati sir. Now we move on to the second live surgery. MPFL reconstruction by Manavendra Basu Mollik sir. So can we have the audio feed as well? And to chair the session, I would request Dr. Aditya sir, J. Aditya Jham sir, Ritik Ganguly sir, and Sunit Hajra sir on the stage.
Scale koi. Scale patis na?
Mana sir? Mana sir? Sir, chairpersons Ritik Ganguly sir, Sunit Hajra sir, আর J. Aditya Jham sir.
ফোর স্ট্যান্ড কর। শুনতে পাচ্ছিস আমাকে?
হ্যাঁ শোনা যাচ্ছে মানাদা।
ওকে।
বলো কি করেছো?
ঠিক আছে।
What you have done?
কিছু করিনি, we are just waiting for you. In the meanwhile, we just prepared the grafts and we'll start with the MPFL.
So
for MPFL, our preferred graft is semitendinosus, and our preferred technique is an adductor sling, implantless technique with a suture with fixation, and it's a double standard reconstruction with the reconstruction of MQTFL and the MPFL.
So can you tell about the brief of the cases? So what is the case? How much dislocation?
This patient had a injury 1 year back. Since then, she has been significantly unstable. So she complains of a painful buckling like this frequently. So when we examined her, we found that the patellofemoral joint is grossly unstable in extension, not so unstable in flexion. There is a significant apprehension, and the apprehension is not of dislocation, but the apprehension is of pain. So I think during this episode of injury 1 year back, she had an osteochondral defect in the patellar facet, which is giving her that pain. So now we have a patellofemoral instability with osteochondral defect. The third thing that we found is that she is significantly Latchman positive. So grade 3 Latchman positive, grade 3 pivot shift, or maybe grade 2 pivot shift, and associated with that, she is hyperlax. So she has got Baton score 9. So now we think that we need to fix her torn ligaments. So we need to do fixation of the MPFL, MQTFL. We need to do a fixation of the ACL, and the MRI shows there might be an injury of the posterior part of the medial meniscus, which we need to fix up. So our choice of graft is semitendinosus for MPFL, MQTFL, and peroneus longus for ACL. So we'll not go through the ACL so much because Arnav has already done a demonstration of that. We'll mostly go through the MPFL part of it. So this is the technique which was originally published.
What is your sequence if there is a ACL along with MPFL? So first you do the interarticular procedure, then come out and do the MPFL, or first the MPFL, then the ACL. So
we were doing like this up to recently. I think 6 months back we were doing the intraarticular part and then the extraarticular part, and then we learned that it might be actually be easier doing the extraarticular dissection first before there is too much of fluid in the area, which makes the area slightly soggy. And since then we have started doing the extraarticular part first. If if we need an intra-articular visualization for helping decision making, we do a AR arthroscopy. We don't put fluid, but that's only for visualization, not for a procedure per se. Because you can't put a second portal. Once you put a second portal, all the air leaks out.
Okay.
Okay. So do we proceed from here? So can we put the lights? Oy light off ache naki?
Light. Camera.
So we have looked at her reports. I would have loved to show you the MRI. So she doesn't have a trochlear dysplasia per se. We have seen at her X-ray, she doesn't have a patella alta. We haven't looked at her TTTG, but she has got slightly valgus. Clinically TTTG doesn't look so off. Okay, so our landmarks are, this is the proximal tibia, this is the distal femur. Am I easily visible or not? This is the medial epicondyle. And this is my adductor tubercle. So medial tibial epicondyle is relatively well palpable. Adductor tubercle is relatively well palpable unless you are looking at a very thick, flabby individual. But usually the medial epicondyle is palpable here. The adductor tubercle almost 1.5 centimeters behind that. And this is my patella as it sits now. The MRI also shows the significant amount of patellar tilt is there. So this is my quads tendon. And this is a two incision technique. So the first incision is over my adductor tubercle, 2 centimeters above to 2 centimeters below. So it is like a 3 or 4 centimeters. We will take the 4 centimeters one because this is a slightly bulky lady and probably for demonstration would be easier. And the second is over the medial 1/3 of the patella. So this again extends from the insertion of the quadriceps tendon to 1 centimeter below and 1 or 2 centimeters above. This is a relatively mobile window. With the flexion extension of the knee, this window actually moves. Okay. Please tell me if I need to explain anything.
And you are planning with only MPFL or MPFL with some sort of lateral release or kind of thing?
No. A lateral release, I think, is indicated only in cases of habitual dislocations or frequent dislocators in which the lateral structures are tight. Normally, with the intermittent or recurrent dislocation, even if it happens maybe once in 2 months, 3 months, the lateral structures are not tight. Once the lateral structures become tight, it will always pull the patella laterally.
Yes.
So it's a case of more of a habitual subluxation than dislocation. Okay. So we go with the skin incision. Video ta dekha jacche ki? Can it come up closer? Okay. So once you cut the fat, you get to the deep fascia. Once you cut the deep fascia,
closer picture.
Yeah. Sorry.
It will be better.
আর একটু কাছে এইখানটা নিয়ে আসতে হবে, এটা উপর থেকে দেখাতে হবে, নাহলে দেখতে পারবেন।
এইখানটা ভেতরে ফোকাস করো।
Not visible.
Are you okay?
Okay.
দেখা যাচ্ছে না? দেখা যাচ্ছে না?
অতটা ক্লিয়ারলি নয়।
ওকে।
এদিকে নিয়ে ক্যামেরাটা।
এটা একদম এই কাছে না নিয়ে এলে ওটা তুমি দেখাতে পারবে না। ওকে। So even if you once you remove the fat, even before you cut the deep fascia, you can actually start palpating the adductor magnus insertion into the adductor tubercle. Feel cut. নিজে feel কর। It's very prominent. It's very prominent. একদম thick. A very thick structure. Okay, visible, not so visible, almost visible. I think we are doing good.
Yes.
Yeah, that's good. Yeah, this is better.
Visible.
देखे. Okay. Much better. Eta much better. Yeah. এটাকে একটু ফোকাস করে, I think এসে যাবে. Okay, maybe if you pull this one, আরেকটা retractor দে, ছোট, oh yeah. And if you use maybe 2 retractors, they'll be able to see better. Okay. Can you see it now?
Yes.
Is it better?
Better.
Okay, yeah. So once we reach the deep fascia underneath the fat, you can palpate the adductor magnus insertion. You make an incision on the deep fascia, and there's a fat. You do a blunt dissection, and the adductor magnus can be felt. So both of you try. Okay, it's this side. It's this side. Huh? Okay. Yeah. It's on this side. Okay, now don't pull the adductor tendon. Okay, so once you can feel it, you can use a 90-degree artery to loop around and take a
Not visible.
loop around.
Yes.
Visible, not so visible. Okay, if you can't see it, you'll have to take my word for it, or maybe Devan's word for it. Yes, we have taken hold of the adductor here. Shoot up. Okay, go. So this is my loop around my adductor tendon insertion. Okay, so can you see or not? Yeah, maybe you can. So this is a very strong insertion. You can actually lift off the limb with it. Okay, you can completely lift the limb off the table. This is such an insertion. So with this loop, we have already graft prepared for this, and so this is my, দেখা যাচ্ছে না? Okay. Okay. হ্যাঁ এসছে এটা এসে গেছে, এটাকে জুম করতে হবে.
So what are the advantages of not making a femoral tunnel for the femoral insertion?
Femoral tunnels are always a problem.
And why?
So there are specific groups of people in whom you don't want to make a femoral tunnel, like the pediatric group, and this is the group which most commonly presents with the patellofemoral instability.
And
so this is the rare case of adult onset patellofemoral instability. Is a more commonly you get a femoral pediatric group or adolescent group, and you don't want to touch the bone in those cases, at least not close to the physis. There's a major advantage. So this was originally described for pediatric age groups. Can you? I think you can see it much better now. I to zoom korte paro.
So how do you actually know about the isometricity? So
this is a non-isometric graft. This is a non-isometric graft, and the isometricity of MPFL is seriously debated. So it's no. So now we use this loop to pass this graft underneath my adductor magnus tendon insertion. So this is my medial fixation artery. Okay, it's a non-isometric graft. So we are done with this part. Now we'll take the second incision down, which is on the patella. Okay. So it will take slightly bigger because there's plenty of fat here, and maybe that will ease of demonstration. So we cut the fat, that's layer 1. Okay, so once you cut the fat, layer 2 becomes visible. Retractor. Okay, so we are still looking for okay, so now we can see the layer 2. And we'll cut the layer 2, which is, take another retractor, I think, yeah, better, and maybe, and better, yeah, this is better. Okay, so now we cut the layer 2 right on the middle aspect of my okay. So once we have cut the layer 2,
so you are exposing the equator, right? The
yeah, equator and the insertion of the quad tendon. So am I visible? Not visible.
Light off.
Am I visible? Yeah, too much of glare maybe. Light off for the, yeah, better, much better. So we don't need too much of light. Keep it here. Keep it here. Yeah. Layer 1 error. Don't need to retract layer 2. Okay. So we develop this plane, and once we have developed this plane, we take a long artery. Okay. And dilate this plane. Okay, creating a passage. Okay. And then we create the connection between this plane here and this plane here. And then we deliver the graft into the second incision. So, good. So that my grafts are here. Now we have two bands. One which we are going to use to reconstruct my MQTFL, and the other for the MPFL. So for the MQTFL, we will use a suture weave technique. Okay. A-planar retractor track. Layer 2. Okay. Yeah, good. Scissor. So just at the junction of mosquito, just at the junction of it will act as a retractor. Just at the junction of the capsule, the superior medial pole of the patella, we create the first passage, and this is done with the mosquito. Okay, with the mosquito you can pick up the superficial layer of the quadriceps, and then you dilate this by pushing your mosquito. Then je kono ekta de eta khule de mop lagbe na to.
So sometimes during dissection it is seen that layer 3 is breached. Sometimes it is breached. Okay, some point of time.
If we have fluid in the joint, yes, breaching a EA is a problem, because it will cause fluid to leak out and make your surgery more difficult. But in this case, even if it is breached accidentally over a small area, I don't think it's too much of a problem. Okay. To dilate okay, now. Okay, let's hope we can do it this time. No. Yeah. Okay.
Sir, I would like to point out that we always taper the ends of the graft to make this part of the surgery easier.
Yeah. True. I agree. So there's the first pass through quadriceps.
Signal off. মানাদা শোনা যাচ্ছে কিচ্ছু না
So,
এই তো
so usually we'll take two or three passes. This would probably would have been enough. Graft passage. Because graft length is never a problem here. If you take the semity, there's enough graft there.
so how do you appreciate the tension of the repair?
Yeah, that is under arthroscopic view.
Okay, so from outside whether you are doing more tightening or less tightening, so it
Yeah,
is
that's under arthroscopic vision. So proper tensioning is done under arthroscopic vision only.
and this is before the
Can I
patellar
retract that?
fixation, right?
No, this is after we have repaired the MQTFL part.
Okay.
So at the junction, I don't know whether you can see or not. Can you see or not?
Yes,
See?
yes.
Can see, huh? Can see? Not
Yes,
see?
yes.
Okay,
We can
okay. So at the points of passage through the quadriceps, we repair the graft at these points. Okay? So there are 3 points of passage, we repair it at these 3 points. So that completes my MQTFL patellar quads fixation. We have not yet fixed the medial part. That is going to happen under direct visualization after we have decided on the tension. Okay.
Sir, is there a reason why we are not using any anchors for the fixation of the MPFL?
Two things again, because this was a technique which was designed for children where you don't want to put anchors. It's only recently that this has been adopted for elderly or adult population. So, when MPFL started, there were a couple of techniques which developed, tunnel technique, anchor technique. So, a lot of complication has happened with those fixation processes per se. So this is something we have adopted from the pediatric technique and it has worked well, and now there is literature support for this. So now with this technique we don't need anchors, we don't need tunnels, we don't need one headache is less, tunnel related headache, anchor related headache. The price is less, you don't need a C-arm, makes it a relatively faster technique. ক্যালপেলটা নেই, এদের ফাইবার ওয়্যার তো কাঁচিকে নষ্ট করে দেবে। ওদের কাঁচি নয় বলে ওরা কিছু বলছে না, কাঁচিকে নষ্ট করে দেবে। ওকে, এদিকটা একটু রিট্রাক্টেড, এইখানে ইয়া এইখানে থ্রু দ্য ফার্স্ট পাস, এটাকে একটু ধরে থাক বাঁ হাতে, ইয়া ব্লেড নিয়ে নে। ওকে, এক মিনিট। Cut. Okay. So now we this is the fixation of the quad tendon part. Now we'll do a fix. এটা ছেড়ে দে, একটু রিল্যাক্স কর। হ্যাঁ, এটা টেনে দে, ওকে একটা দে দিবানের হাতে।
So by this time we can take any question from the floor. So
Yeah,
any confusion, any
দিবান এই
controversy.
লেয়ার নিচে, লেয়ার 2 এর নিচে।
You can join.
Okay. So let me know if you can see it or not, because this is a slightly constricted space, so visualization might be a problem. একটু টিল্ট হয়ে গেছে ছবিটা আই থিঙ্ক একটু নিচে দিয়ে কর বাবু
মাঝখানে
আচ্ছা নিচে দিয়ে কর এদিকে এদিকে আমার ইয়া গুড হ্যাঁ
ঠিক আছে
ওকে ক্যান ইউ সি নাও zoom so this is my proximal this is my equator of the patella am I clear or not so this is my fixation points and this is my patella equator of the patella let me know if you can see it well okay here again we start from going through the capsule which is layer 3 the first bite comes in through the superficial layer of layer 3 এটা ধরে নে একটু না তুই রিট্রাক্টর ধর নাহলে ওরা কেউ দেখতে পাবেন একটা স্যান্ডিকে দে তো এইটা স্যান্ডিকে দে yeah maybe this one sandy
so what is your mode of fixation in the patella
again suture weave technique through the periosteum
okay
so this you will need an awl for this এটা একটা awl লাগবে
yes so sesamoid bone doesn't have any periosteum so
no this is not a periosteum this is a soft tissue expansion of the quads this is not a classic periosteum this is a sesamoid bone so whatever is covering it is essentially the soft extension of the quads tendon this is not a true periosteum we call it osteoperiosteal flap but this is not a true periosteum এবার ওদিকে জ্যাকটা ছেড়ে দে এদিকে চলে একটু এদিকে চলে
so any reason why you don't use a tunnel on the one tunnel could have been done on the particularly the patellar part
absolutely can be done I have no reservation against tunnels arki per se though there have been complication related to tunnels that's a different issue but I personally don't have reservation against tunnels there have been complication related to ACL tunnels as well so that doesn't mean we'll not do ACL tunnels
so what is the long term results with this what is the long term result you have because since this is an entirely soft tissue based fixation so
I have had follow-ups of 5 years they are doing very well except for one patient which was a pediatric patient artery lagbe which is a pediatric patient in which we did this with the forewarning that you will probably need a revision because she had a trochlear dysplasia she is marfanoid she has genu valgus probably increased TTTG but because we couldn't do bony procedures at that age when she came to us I think when she was 12 so that patient has failed in the sense that she was having a subluxation dislocation in extension and now she has a subluxation dislocation in flexion so probably we undertreated her we should have done a quads plasty or maybe a lateral release at that point of time which we didn't do
no if you take the end point as a failure that which requires a new surgery then
no
okay
but no I completely agree the end point is recurrent instability
yeah but if you take the take in account the patellar tilt and everything on based on follow up MRIs does this stretches out a little more than the tunnel sort of technique or it's probably do as good as tunnel setup technique but probably not stretches out too significantly that the recurrence occurs so
okay so I think the without going into a debate whether this is a better or a tunnel is better one reservation against this is because this is a completely soft tissue repair the rehab is much slower so we can't really rehab them as fast as we could do for a more solid fixation or a implant related fixation or a tunnel related fixation or a anchor related fixation so that limitation is definitely there no doubt about it we don't move this limb for 2 weeks and then when we start to move then we also restrict it so no movement beyond 6 weeks no movement beyond 90 degree up to 6 weeks so rehab is definitely slower
Manada, have you seen any?
So I can't say this is better or worse than that, but yes, it's got its own advantages and maybe some disadvantages as well.
Manada, the tendon sling is around the adductor tendon. Have you seen any problems with tightening of the adductor tendon? Patients complaining of pain around that area.
No, we haven't seen that. In fact, as the patient starts to flex the knee, this graft becomes tighter and tighter. Okay.
Okay.
So, and Debayan has seen a case in which I think he was mentioning it today. He saw it. এক মিনিট ওটাকে একটু কাছে আনতে বাবু পুরো খুঁটিটাকে একটু টান পড়ছে এখানে আর একটু কাছে নিয়ে আর একটু কাছে নিয়ে আর একটু কাছে নিয়ে ওকে দুটোকেই খুলে দে একসাথে গুড আর এই যে ফুটোগুলো আছে এটাকে বার করে দে নো পাম্প ওকে খুলে দে দুটোকেই আর দুটো দিয়ে ফুটো ফুটো করে দে দ্যাটস ইট ওকে হোয়াইট ব্যালেন্স করা আছে ওকে so Debayan had seen a case demonstrated in Isakos in which there was a avulsion of the adductor tubercle. So I don't know what led to that, but
so at the time of doing the surgery, okay.
Sorry.
At the time of doing the surgery, there was avulsion.
No, not at the faculty who was speaking on this.
Okay, okay.
They showed a case of avulsed adductor tubercle. So I have not faced, but yes, that thing can happen. Sorry,
so how do you diagnose that? It's a bony avulsion or soft? I mean,
Divine ball. So what was it, bony avulsion or what? এক মিনিট হিরো ও হিরো একটুকে এটাকে একটু আমাদের দিকে করতে রে এই স্ক্রিনটা একটু আমাদের দিকে ঘোরা ইয়া গো হেড দেবান So it was a bony avulsion. So it was picked up on X-ray.
Okay. Yeah, but that's one new complication which probably you need to look into your patient as well. Maybe,
yeah.
Not
absolutely.
the bony avulsion, maybe the soft tissue. I mean, tear of that adductor tendon as well. Attrition may be there with the each flexion and extension.
Okay. So ACL is definitely gone.
Yeah.
Medial meniscus, I think, is gone. Sandy edike ataka. Right, left hand under the heel. Left hand under the heel. Right hand on forefoot. Yeah. Okay, good. Just lift করে রাখ একটু external rotation করে রাখ. Yeah. Okay. দাঁড়াও এখনো ফুটো করা হয়নি. Needle. So there is no leak from here. That means we haven't done any damage to the layer 3.
Yeah. Can we have a suprapatellar pouch view so that we can see that?
Yeah, the tightening is done. Yeah. The tightening is done through the suprapatellar pouch view, the transquads view. So I think there's a meniscus tear there.
Yeah.
Going from this one, maybe 4 o'clock to 1 o'clock or 12 o'clock. So the large meniscus tear. ACL tear. One sec.
What's your take on these two dual pathology in these patients?
I think she had a laxity of the patellofemoral joint. She's got a tear here also on the lateral side. We'll see whether it's a partial or not. She's got a drive-through sign, which is in commensurate with her Baton score. Posterior roots looks okay, not too bad. I think she had this patellofemoral instability to start off with, but this time she tore her ACL and her meniscus.
Yeah, probably the recent injury is probably the
ACL meniscus. Yeah. But yesterday when we examined her, the patella was completely jumping out of the lateral femoral condyle.
Okay.
And if you look at the MRI, so there's a tear going right up to that ramp, periphery, whatever you call it. So we will not do the.
We would like to have a look at the patellar articular cartilage as well. So and the
that we'll see. So we will just look at the femur. Femur doesn't have any cartilage defect to start off with. Typically you should be expecting a cartilage defect at the lower pole of the patella, medial facet, and femur, lateral, can't see anything. Can't see, no, nothing in the femur as yet. Okay, femur looks okay. Okay, dhar, babu, dhar. Okay, now let's look at the patella. So, patella. Can't see the patella at all.
Manav, there is a question from Bhojanda. So, at what degree of flexion you usually tighten the graft?
At what degree?
Yeah.
I do it in 0 degree. But the position I check by arthroscopy, what is the correct tension.
Okay.
So, patella, needle. Okay. Here in the joint. Okay. Patella. Can't see too much.
Yeah, looks fine, I think.
Looks fine. I don't know why she was so painful in the patellofemoral movement. There's significant patella, small lesion there, small one. There's significant patellar tilt, and when we try to, okay, needle. Okay. So we'll create the transtendinous portal through the upper pole. This one looks okay, or maybe slightly higher here. Okay, cut off.
This is for the patellofemoral joint inspection, is it?
Yeah, and deciding on the tension.
Okay.
You can't decide the tension without looking through this portal. Okay.
So you have already fixed both the strands, na?
No, we have fixed one of the strands. We have suture weaved the other, but not fixed it.
Okay.
And because it's a loop,
you can adjust actually.
Yeah, I can adjust. Santerica.
So, is it a routine in your MPFL reconstruction by this technique?
What?
Is this a routine?
Which one?
Doing an arthroscopy to see the tension?
Absolutely. The fixation is under arthroscopic view.
Okay.
And I have not found any other reliable technique to find what is the correct tension. Anyway, I think we'll manage. I can manage. Yeah, good. Okay. So now we are in the superior portal. The patella looks relatively high.
Yeah, that's what I'm saying. I mean, the
yeah, it looks high. देखिए एक मिनट. Okay, shiver connected হয়েছে. Foot piece আছে.
And is it sitting on the trochlear groove?
Fine. Oh,
Yeah,
hands.
that
এটা কি? আচ্ছা. আর এটা sucker. Okay. Foot. Oh, fuck.
So, Manada, if you know, can you tell us the age of the patient?
35.
35.
Okay. Right. Dhar two. Okay, 1 second.
Manavda, regarding adductor tubercle avulsion fracture as a complication, so what I think probably it might be due to over tightened or contracted lateral structures, which was not addressed.
I think that was what we were discussing. Probably the lateral structures were too tight and they were not released in the first place. Yeah, that was probably not addressed. And maybe it was not a case of recurrent dislocation. It might have been a case of habitual dislocation. So habitual dislocation is a different ball game completely. It has so many other bony issues. Okay. Now this is my patella. So what we want to do is not to subluxate it, in fact. So we'll probably do it in situ fixation in this position, just to add a restraint. But normally what we will do is we will push the patella. So usually the patella will be lying here. In this case we can push it out So usually we will push the patella medially to bring and make it sit on the central one with some amount of laxity, and then we have fixed the proximal part of this band. Can you see? Do you have an outside picture? Yes, you have. So we have already done the MQTFL part, but because it's a loop, as I pull on the distal limb, it actually tightens both the rear. Do you have a look? Yeah. So do you understand the principle?
Yeah, we do.
So because the distal part is suture weaved but not tightened, as I pull on the distal limb, it tightens this MPFL part and the MQTFL part, and it is fixed proximally. So at that point of fixation, we will make the repairs. Does that sound good?
Yeah, of course.
Good. This looks like maybe a bit of trochlear dysplasia also.
Yeah. So that's the main issue. I think diagnosing these based on MRI is really tough job. I mean, both. The Alta and the trochlear dysplasia.
Yeah, I agree. I think this patient has an Alta and maybe. Yeah. But anyway, she's lived with that for 35 years. I don't think we really need to address it now.
Yeah.
So maybe if we can add a restraint and do an ACL and a meniscus repair, that's going to tighten up her knee enough.
Yeah.
Okay. So we are done with the MPFL.
Yes.
Okay. You can continue with the lectures. We can come back and show you once we have done the ACL part. Okay.
Okay.
So now at this point of tension, we will just repair the MPFL part of this reconstruction.
Okay. Thank you. Thank you for the nice demonstration. It's really
a huge round of applause for the chairperson and Mana sir.
Thank you.
And we had 2 pending lectures in the previous session. So Arnav sir is here. So would you be comfortable doing the ACL with internal brace now?
Okay.
Okay. Basically, it is like augmenting your ACL reconstruction, right? So let us see what are the indications, like why we should think about putting an internal brace. So if your patient is high demand, high strength suture tape, it is sort of seat belt to protect the graft till it heals. Sometimes in newer day we are seeing a lot of ACL which are coming at a very early stage, and you may try to repair those cases. So when you are also thinking to repair the ACL, especially femoral footprint avulsion, or in an adolescent or pediatric patients, when you are planning for repair or incomplete tear, single banded tear, then you can use it as an add-on therapy. How it works basically, it's a high strength suture tape that adds to the graft stabilization. It allows you to do early mobilization, so you can avoid stiffness. It reduces the mechanical overload during healing and may promote better biological integration. So again, in whom we should consider high demand patients like athletes, intensive jobs, acute proximal ACL tears, direct repair. In that case, you can add a brace, no graft. So till that is healed, your brace will protect the graft. Mid substance tear, sometimes we can use it as an augmentation. When you feel that your graft is inadequate, you don't have any other option. Some partial tear, it provides added stability and fast requirement of return to sports. So benefits already been discussed. So the basic procedure is that you put a suture tape, it is placed during the repair or reconstruction. You secure it to the graft, you can stitch it to the graft or your suspensory fixation ligament. In this case also you will see the image that it is alongside of the graft, and you can create a ribbon separate structure along with the graft. So different manners are there that you can use this internal brace. I'll show a video. So here you see the, in case of a revision ACL reconstruction, we have used that is the whole femoral tunnel from the previous surgery, and this is the new femoral tunnel has been done, and with the graft was, it was a female patient and graft material was not that adequate, so we added a brace with it. So we created a ribbon like structure and then we
sutured it with the ACL graft. So in that manner you can use a internal brace. Then you have to fix it separately. You can fix it. So this is another technique of using an internal brace. Suppose once you prepare the graft, after you prepare the graft on the both side, you can use the tape and put it inside your suspensory device or the button like a U. So that has been done. So you take it from one hole and then take out from the other, creating a loop in the suspensory device fixation. Then you can put it inside the ACL graft just like a, so put your artery inside and take one strand from there and another strand from the opposite side like this. So then like your normal, after your femoral socket is drilled, you then you measure and then you pass the graft. This is an all inside sort of technique shown here. So you take your graft in from the tibia, and this is the internal brace or the suture tip. Then you can fix the ACL. As this is an all inside technique has been done, so here we are two suspensory fixation adjustable loop are done. So this is the loop and this is the tape. Then you can put the tape inside or you can fix it separately also. So there is two concepts. Most of the surgeon prefer to fix the tape separately. So you fix the ACL first, then you can fix the tape on a pillar or post. Here there have been shown that they have fixed on the same button. So this is another way of using an internal brace. So ACL reconstruction with internal brace is a viable option for selected patients, though the actual benefit is debatable whether it helps or not. Sometimes some group of surgeons says that it does not have any role to play. It supports early recovery and return to activity. It gives you confidence to allow early motion to this sort of patients, and it is obviously one of the important part in acute ACL repairs when you are trying to repair the ACL. Thank you.
The next speaker is Dr. Abhijit Chen. He will be talking about his decision-making process in meniscus repair.
Good afternoon, everyone. So my topic is decision making in meniscus tear. So there are different kind of meniscus tear there. So first one is longitudinal tear, which if extends may turn into bucket handle tear. Second one is radial tear, which eventually progress into your parrot beak type of tear. And third one is horizontal tear, which if progresses then turn into flap tear. So the question is, the dilemma is which one to repair and which one to excise. So basically we have three treatment options for the meniscus. One is excise, one is repair, and the third one is leave alone. The traumatic tear, there are basically two options. One is meniscal repair, another is meniscectomy. But for the degenerative tear, we have two options. One is meniscectomy, another is leave alone. So for the degenerative tear, the repair is big no. So what are the surgical consideration we have to take during our surgery or before planning? So number one is patient age. So if the patient is young, less than 30 years of age, then our threshold for resection will be very high. We should try our best for the repair. If the age is more than 50, then the limited meniscectomy may be the option. So remember the term limited meniscectomy. This is not the total meniscectomy. We should try to keep as much meniscal tissue as possible to preserve. And third one is if the age bracket is between the 30 to 50, then it depends upon the surgeon's choice and also the patient's preference. Why patient preference? Because you should give option to the patient, because if I repair the meniscus, there is chance of failure. So if the patient doesn't want to go for second surgery, if it fails, then you can go for meniscectomy. So other surgical considerations should be chronicity of injury. So previously there was a dictum that less than 6 weeks of injury we should go for repair, beyond 6 weeks then excision. But the main thing is the quality of meniscal tissue. The biology should be proper. If the biology is good, then we can go for meniscus repair even up to 6 months. Even today morning we have seen the patient has meniscus tear more than 1.5 years, but we have repaired the meniscus. So we need to take care of the biology properly. So tear location, medial meniscus tear or lateral meniscus tear. So both the meniscus have their own significance. The medial meniscus has got its add to the anterior stability, and the lateral meniscus acts as a shock absorber and also gives rotational stability. But the lateral meniscus is very crucial. So tear length, if the tear length is very much big, then the resection may be the consideration. And the concomitant ACL injury. So it has been seen that if the meniscus is repaired along with your ACL reconstruction, then the success rate is very high. Around 90% success rate is there. But if the meniscus repair is done in a unstable knee, then there is chance of 30 to 40% success. And also the activity level of the patient to be taken care of. So regarding the meniscus repair, we need to see the vascularity. So we know that genicular artery is the main artery source of blood supply to the meniscus. So at birth the meniscus is 50% vascularized, but in the adults 10 to 25% part of the meniscus is vascularized. So meniscus is a avascular structure more of. So making so this the avascularity makes the healing very difficult, and we are, depending upon the vascularity, we can divide the meniscus into 3 zones. The central portion is your white zone, then the red-white zone, and the peripheral portion is red-red zone. So which meniscus need to be left alone? So we can leave the meniscus if it is stable, longitudinal tear less than 10 mm, and there is minimal displacement less than 3 to 5 mm. Degenerative tear with concomitant osteoarthritis, less than 3 mm radial tear, and stable partial tears. These are the tears we can leave them alone. We need to don't need to do anything for them. So this is a study which shows that around 97.8% of the lateral and 94.4% of the medial meniscus, if they are untreated, depending upon this protocol, then they do not need repeat surgery. So you can see the picture. So this is a incomplete posterior horn tear of the lateral meniscus. So this kind of tear can be left alone. So this is a partial tear of the undersurface of the meniscus. So I would like to emphasize on this video because I have put this video intentionally. So while probing this kind of meniscus tear, we should not probe like this. Here probing is done through the undersurface. So if you probe like this, then you can convert this partial tear into a complete tear. So you should probe on the other surface where the tear is not there. So the vertical tears to the posterior part of the popliteus tendon, if it is small, then incomplete tear and small radial or flap tears can be left in situ at the time of ACL reconstruction. So what are the indications for meniscectomy? So radial tear, small flap tear, radial tear if it is also small one, then the horizontal tear and the complex tear, and if the tear is in the white zone, then meniscectomy may be the option. So what regarding the horizontal tear and the cyst? So we should preserve the meniscus. We should resect the unstable layer of the horizontal tear. We should suture these two layers if possible, and before suturing we should empty the meniscal cyst. And if we don't suture these two leaves, then there is chance of recurrence of the meniscus cyst. So who are the ideal candidate for repair? So if the tear is more than 1 centimeter and the length is less than 4 centimeter, the tear is in the red zone, vertical tears, age less than 40, and there is no mechanical malalignment, and acute tears less than 6 years, and concurrent ACL reconstruction is done, then there is definite indication for repair of this kind of tear. So this is basically a longitudinal tear in the posterior segment of the medial meniscus. So this kind of tear should be repaired if possible. So depending upon the different factors, there are different repair techniques depending upon the location of the lesion, the type of lesion, and the stability of the repair, and available instruments, cost of implants, and surgeon's preference. So depending on all these, we should decide which type of repair we should do. So there are different techniques of meniscus repair. In today's morning life surgery, we have seen all the three kinds of repair: the inside out, all inside, and outside in techniques. So ideal repair technique should give adequate stability. It should be suitable for most of the tear types, and should be fast, and should be simple and one hand technique. So these are the different kind of repair techniques. I won't go in details because we have already seen different kind of repair techniques. This is outside in. Mostly this is done for the anterior horn and part of the body which is anteriorly placed. And this is the video of outside in repair. As the time is short, so I won't go for the full video, because we have already seen today. No? So the third one is inside out repair technique. This technique also we have seen today. So with the zone specific cannula, we insert the needle and we can repair the meniscus in inside out fashion. So this technique is very much helpful for the body part of the repair. And all inside technique which is which has become very popular nowadays, these are very helpful for the posterior horn tear. So this is the video of the this is the video of your all inside technique. So I think due to shortage of time, we should skip the video. Yeah. So these are the indication for the meniscus repair. If the tear is longitudinal tear on the posterior horn, bucket handle tear, and for the medial meniscus, longitudinal tear of the posterior horn, and bucket handle tear, and the ramp lesions. These are the tears we should go for meniscus repair. Thank you.
So we also have a dedicated meniscus workshop which will come later. So Abhijit is always there for the grilling. And next we move on to the next station. We have PCL reconstruction relife. So for that we have one of our national faculties from Delhi, Dr. Jay Aditya Jhamsa.
So hello everyone. I would like to thank everyone for calling me here and giving me this opportunity. Generally for my PCL reconstruction I am using either a peroneus graft. Can you make this isko on kar denge? So I'm using either a peroneus longus graft or a semi-T. I'm generally not taking the quadriceps again because I feel quadriceps weakness will cause a delay in rehabilitation. So this patient, we had done a root repair already, and now we're looking at the posterior medial corner of the knee. So I am using either, most of the times with a single posterior medial portal I can get away, but because this patient was well built, nearly 6 feet tall, and we had sufficient space in the posterior medial corner, so that's why here in this particular patient we made 2 portals. Otherwise, generally with just 1 portal I get away with doing the work, but actually we should be doing transseptal. And I have experienced that even though it takes a little bit of time to create the posterior lateral portal, but it makes the job a lot easier. That initial 15 minutes of patients can actually decrease the surgical time. So in this, we have placed the 2 cannulas. Very rarely do I get a knee this big, where I can put 2 cannulas in the posterior medial portal. So this is one thing that I wanted to highlight. I have made a lower anterolateral portal, because most of the time I am using suspensory fixation for my femoral tunnel. And the normal portal, anterolateral portal, I am making very high because I want to have a proper posterior visualization. So this portal, like I can see, can point out the anterolateral bundle of the PCL, the remnant of the anterolateral bundle. So a low anterolateral portal is a preferred choice for inside-out femoral tunnel drilling in the PCL that I have used here. So this is a microfracture owl that I create just before putting the beath pin. It makes my job a little easier. And after this we do a standard 4 mm and 9 mm in this case drilling we did. So after that we'll pass the sutures. So this is the femoral tunnel preparation basically. So again, from the, you can see this gives me a very nice high tunnel by using the low portal that I'm trying here. So again, most of the time I use either a adjustable loop or a fixed loop. If I'm using an adjustable loop, like Dr. Sridhar said, I make it a point to put a sliding knot at the end to convert it into a fixed loop, because I personally am not very confident whether it will slide down or not later, especially in PCL, because no matter what we do, grade 1 sag in post-operatively at 6 months is always an issue. And even though patient is not very symptomatic, but at least as a surgeon, I think it really troubles us. So this is my standard. We have a drilled till up to 30 mm because we want to use a adjustable loop here. A fixed loop we are using here, so around 28 mm we drilled. Move it forward, I think. So now we have repositioned our scope into the posterior portal. So this is the most critical part of the surgery, and I think we all can agree this is where all our hearts stop. Whether using a cautery or using a shaver, I had a experience with the cautery one, so after that I started using the shaver. But I have heard that shaver is worse. Most of my friends tell me better to use a cautery, but I generally put the suction off and then I do it. So this is the septum. That I think that clearing the septum is the most important part of this surgery. If we don't clear the septum, we cannot visualize the lower end of the PCL attachment, and we will end up making the tunnel too high. So as everyone has said here, and I also believe in preserving the remnant in the PCL surgery. So this is, we are just clearing the septum. So just behind that is where the vessel will be. So we have to be as careful as possible when we are doing this particular step, and I generally go below the PCL attachment, where a lot of times people have asked me, when do you feel you have gone sufficiently below? It is when I start to see the muscle. If I see the muscle, that means I won't go any further, because I know I have come very close to the vessel now and I don't want to take that risk. So I keep clearing this area until I see I have cleared the entire septum and I can see the muscle visible from below. So that is where I stop and try to make the tunnel. So this we can see the PCL, the attachment of the PCL. So this is as low as I go, generally 15 millimeters, or where the attachment of the PCL, the distal most part of the attachment of the PCL, generally I have never gone beyond the muscle. Once this comes, I stop. So this we drill the initial part and then hammer the last part. So generally I use this jig only to protect the bead pin from coming out. And or sometimes I use the Weisinger rod also to retract the posterior capsule, because in this case we have two portals, so we can easily do that. The jig was from the anterior medial portal. We can place the Weisinger rod to push the capsule behind, so protect the vessel. So this is either a PCL protector. In this case I couldn't find anything, so I just grabbed the grasper and held the bead pin. That's also one more way you can prevent the bead pin from coming further. Otherwise, either a PCL protector or a curette. This is the stage where we are drilling the tunnel of the tibial tunnel. So because I am not doing all inside PCL, I am using either a single screw to fix it on the tibia or with a suture disc. So generally we have to ream the entire length with the desired reamer, either a 9 or whatever the graft size is. So this we have passed the suture from the femoral end, we have placed it behind. Now we'll go again from the posterior medial portal and retrieve it through the tibial tunnel, and then we'll just pass the graft. So while passing the graft, one thing is there to protect the killer curve. Generally I have seen the graft either getting damaged from the tibial surface, or I have had a case where I had the threads got cut out with the killer curve. So I generally use a Weisinger rod or a trocar to just push it back to allow for easy passage of the graft. So in this case we used a fixed loop. So a fixed loop is a little harder on the drilling time, but once you are done with that, I think it's easier to do, and post-operatively we feel safer that it will not slip down. So this is what we are using, either trocar or a Weisinger rod, just to allow the easy passage of the graft through the killer curve. So this is our final picture after we have fixed it into the tibia. So we can see the good tension here, and this is with passing from the femoral tunnel. And we'll flip the button and then we'll just fix it on the tibia. So this is the after fixation on the tibia. I'm sufficiently happy with the tension, and we can see the ACL is not lax anymore, so I am happy. But still I feel no matter what we do, I think after 1 year grade 1 SAG, I have always seen in my patients, even after the best of my efforts, I have started adding suture disc also for this in tibia. So this from the posterior medial portal, we can see the graft that is passed. So this, I think, if we have good access to the knee, sometimes I am making this tunnel in figure of 4 instead of putting a bolster under the knee, because I feel figure of 4 also gives me a more secure location and it decreases one assistant for me. So I think this is the end of the surgery. Any questions?
Rare injury and having high morbidity if not treated in time and with the perfect precision. So already theory part I won't go. There are some debate on open versus arthroscopic technique. So for me, open is when it's a large fragment, and if the fracture is older ones, like in this case, this was 6 weeks old, patient came after 6 weeks. So in such cases, you should not attempt for arthroscopic fixation. Otherwise, you may land up with more complications. So that is the indication of open surgery. Arthroscopic fixation, I prefer in comminuted fractures. If it's a big chunk, I go open. The advantage being it deals with the other concomitant injuries, and you can just get away with one single surgery dealing with all the injuries. But the literature is suggesting no difference between open and arthroscopic in long term. So my PCL avulsion, I usually do double tunnel, and if the fracture is fresh and it's a comminuted, I may go by one tunnel also. So after the initial evacuation of hematoma and other was, this is the telltale sign of PCL injury with the floppy ACL sign. So now we need to go to the posterior compartment. That is the most important part, because most of the times we deal with ACL and we tend to stay in the anterior compartment only. Here we need to go to the posterior compartment, and for that we need to go transseptal. So this is a transseptal dissection, and care should be taken not to injure ACL or PCL fiber, just dissection of the fat tissue. And slowly you advance your scope into the posterior compartment. You should be very gentle not to do any injuries of the structures. So again, the next step is you have to make a high posteromedial portal under direct visualization. In this case, you are viewing from anterolateral and just making portal in high posteromedial. After this, we need to have a good dissection posterior to the PCL avulsion fragment. Otherwise, you won't be able to see the fragment. So you need to do very slow and very careful dissection of posterior soft tissues posterior to the avulsed fragment. It should be very slow process and it should be very careful. Otherwise, there are chances of vital structures damage. And in cases when the fracture is old, we do not recommend arthroscopic fixation, at least by the beginners, just because of apprehension of damaging posterior structures, neurovascular bundle. So the next is creation of low posteromedial portal under direct visualization. So we need two posteromedial portal, one is high posteromedial and the second one is low posteromedial. And because we are going to deal with low posteromedial, we will use it as instrumentation and working portal, so better to put a cannula in the low posteromedial portal. After that, once you have cleared all the tissues around it and you are clearly able to see the PCL fracture fragments, now it's a PCL jig, tibial jig. So this jig is used to assess the reducibility of the fracture fragment. And you have to clear the soft tissue as much as 20 to 25 mm down to the joint line. Once you have cleared all the tissue up to the desired level, the bony fragment should be lifted and it should be debrided carefully, like as in ACL avulsion fractures. There should not be any interposition of soft tissue between the bone and the crater. Crater must be debrided well, especially in slightly older avulsion fractures. And then the provisional reduction using tibial PCL jig. Now it comes what technique you will follow. Up to this is a common. If you are planning to go by one tunnel and one suture, then you will drill only one tunnel and one suture will be passed through the ligamento osseous junction of the PCL. But in this case, it was two tunnel as it's marked on this side, left side. It was two tunnel was drilled from the anteromedial, and these guide wires should exit inferomedial one and inferolateral second one. Inferomedial to the fracture fragment and inferolateral to the fracture fragment. So you are drilling this from the anteromedial part, keeping a good amount of bony bridge between the two guide wires. Because subsequently we will not use any implant at the tibial side, anterior side. So care must be taken not to injure any vessels, and it should be always slow and protected guide wire passage and drilling subsequently. So you must always guard your guide wire in the while passage this, and during drilling also it should be done under visualization, and you should always guard your drill bit. Pump should not be used in these cases because that may extravasate in the calf region and may ultimately lead to compartment syndrome. So now the drilling of inferolateral and inferomedial, drilling over the inferolateral and inferomedial guide wires by 4.5 mm cannulated drill bit to create the bony tunnels. Once your tunnel part is over, then comes passage of suture. So this is a suture bridge technique. In suture bridge technique, what we do, we pass one suture from the anterolateral portal, because in this case we are viewing from the high posteromedial portal, and our anterolateral, anteromedial and low posteromedial portal is free. So just pass the suture one tail from the lateral aspect and round it around the PCL osteo ligamentous junction and make a suture bridge. So only one suture, just making up suture bridge, and then we will pull that suture. So this is the tying of suture to make a strong suture bridge, and then we will pass the suture to retrieve this anteromedially in through two separate bony tunnels. And then it will be tied over the anteromedial part of the tibia. So after that, you should verify the perfect reduction of the bony fragment, and it should be stable throughout the range of movement. And post-operatively, this should be sitting over the crater only. And this was my case, and this is the follow-up study after 3 months. Thank you so much. It has a long learning curve. If you feel that two sutures are difficult to take, and then in that case you can use this endo button anteriorly and tie the rope over it. Thank you. No, intraoperatively, and if you think in terms of stability of the reduction and the strength of fixation, two tunnels are definitely better. But long-term results are almost same. Even in the open versus arthroscopic, one tunnel, two tunnel, long-term results are same. That is the beauty of orthopedics. Ultimately it heals. The only thing is you have to go rehab it slightly slowly. Thank you.
Sir, sometimes in postoperative x-rays we see that the bony fragment has not reduced properly. So what happens to this patient?
Even if it's not reduced perfectly, if your tension of the ligament is okay, PCL is okay, it probably won't make any difference. It should not be too high to the crater. normally the PCL avulsions are seen if it's 7 to 10 mm displaced superiorly. So if you perfectly reduce it, and it will come at the level when you will reduce it, bring it 10 mm down to the previous position. So even if it remains slightly superior or not seated properly in the crater, it won't make much difference.
Okay. Thank you, sir.
Okay.
So if there are no more questions, we have actually Mana sir wanting to show us the meniscus repair in the live surgery. So can we move on to the live feed, please? And thank you, Amrish sir.
Articular location, it's extracapsular, and the conservative treatment is a mainstay in the most of the cases. So if you see this anatomy, then you can see the medial side injury. So posteromedial structure is basically from posterior to the MCL to the PCL.
Is this iris OT?
So if you see the three-layer structure, the layer 1 is sartorius fascia, the layer 2 is a superficial MCL, the POL and semimembranosus, and layer 3 is a deep MCL with the capsule. So if you can see this, you will appreciate there are the insertion is not a small point, it is a large area in both the superficial MCL and POL. And it is not the single point. The superficial MCL is anterior part. In the femoral insertion, it is anterior, and the POL, the femoral insertion is posterior. And the same in the tibial insertion also. The POL tibial insertion is just below the capsule, and the superficial MCL, it is generally 12.5 centimeter from the joint line. And if you can see this, the deep MCL, this is a meniscofemoral and meniscotibial ligament. So generally we see the tear for the superficial MCL, because the deep MCL tear is difficult when there is a total capsulomeniscal separation. In that case, the posteromedial dislocation sort of scenario, KT3 3M type of injury. In that case, we can see the deep MCL is torn. Otherwise, the superficial MCL is a common ligament to get torn. Now, how to diagnose it clinically? This is very important, because we know that the valgus stress in full extension in 30-degree flexion is important. But apart from that, the anteromedial drawer test, the rotatory instability, the anteromedial rotatory instability test is very important. When there is you give the anterior drawer with the external rotation of the foot, and you can see the anteromedial tibial subluxation. And in that case, you can appreciate the posteromedial structure is torn. And the anteromedial rotatory instability test from full extension, you are going to flexion, and you can see the anteromedial tibial part is going to subluxate. And valgus stress in full extension, always if it is a full extension, it is opening more than 10 mm opening. We all know that is a injury of the posterior structure. Either is a POL injury along with the MCL injury, or some PCL injuries may be there. So grade 3 medial sided injury, as described by Rob Laprat, have been reported to have concomitant cruciate ligament injury as many as 78%. So this is a stress X-ray. This is also very important to diagnose, because in most of the cases in the clinical test, the MRI, we are very confused whether it is a superficial MCL injury or it is a superficial MCL with POL injury. So in that case, we can give the valgus stress, and we see the stress, the side-to-side opening. If it is more than 3.2 mm opening, it is the superficial MCL is torn. But if it is more than 9.8 sort of thing, explosive opening, then along with the superficial MCL, the complete posteromedial capsule and complete posteromedial corner injury is there. Sorry. So the current reconstruction technique for isolated, it may be the isolated superficial MCL reconstruction, is a reconstruction of the superficial MCL along with POL with a single femoral tunnel. And the anatomical reconstruction of the superficial MCL and POL with the two separate tunnel. So there's a 4 tunnel, 2 in the femur and 2 in the tibia. This is the last technique is by Rob Laprat, and it is generally considered as a gold standard. So this is by the single tunnel, single femoral, single tibial tunnel, but it may give the reconstruction of the superficial MCL, but it doesn't give any sort of stability for the POL. The single femoral tunnel you can do, and there is a reconstruction of the superficial MCL and POL with a single femoral insertion, and there's a 2 limb graft, one from the superficial MCL and another from the POL. The anatomic PMC reconstruction use the 2 separate graft, provide the advantage of creating the native anterior, distal and proximal attachment site as well as individual tensioning, because the superficial MCL tension at the 30 degree of knee flexion. The tibial fixation should be done at the 30 degree. But for the POL, the knee should be absolutely 0 degree when you fix the tibial site. So the differential tensioning is very important to give a good stability on the posteromedial side. But it has different disadvantages, like it's a require extensive exposure, the multiple tunnel. If you are dealing with the multi-ligament scenario, then there is a chance of tibial femoral tunnel collision. If you are dealing with the PCL reconstruction as well, then in the medial side there may be too many tunnels in the medial femoral condyle. And there is it requires more hardware, which may lead to the stress shielding. So whenever you are doing the superficial MCL reconstruction, the femoral point you can see on the C arm also. So there is a 2 lines, one from the posterior cortical line and another from the Blumenstadt line. So there is a junction, and you just go below and anterior to it. So it will be the site for the superficial MCL. And the tibial site is, as I discussed, is a 12.5 centimeter. And before drilling, you can see the isometricity by pulling a ethibond or suture, and to see how much it is stable in extension and 30 degree of flexion. This is a Laprat technique of doing the PMC reconstruction in the 4 tunnels, 2 in the femur and 2 in the tibia, and with the reconstruction of the superficial MCL and POL. Now this is a very important, the recent technique by Dr. Amit Joshi. It has showed there is a weave technique. This is a very very friendly technique, because there are if you are dealing with the too much tunnel and the hardware, then there is a problem. So in this technique we can take the semity with the open stripper, and you can weave through the MCL part and tie that part, and you can put a femoral tunnel and fix one loop with the tunnel and come again and fix at the posterior part of the tibia, and it gives the POL. So modified Kim's technique is also a technique which gives a very minimum amount of implant. You can fix the superficial MCL and POL with the only one screw or one tunnel. And this is basically non-anatomic reconstruction, and if you are dealing with this multi-ligament scenario, then you can do it this. Now, if this is the case of this is a KD3 type of injury, where there is a complete tear of the medial side of the knee, and along with the PCL, you can do the posteromedial corner reconstruction. And what is the take home for that? The conservative treatment is a mainstay, but in scenario of grade 3 PMC injury, anatomic reconstruction is a treatment of choice. And valgus opening in the full extension and massive opening in stress excess are very important diagnostic tool. In multi-ligament cases, the modified Kim's or weave technique can give the good result, where there is a very difficult to use the technique by Dr. Laprat. And Laprat technique should be done in isolated cases of complete posteromedial corner injury. Thank you.
Any questions for Ritik sir? If not, then we are going to take the next lecture by Dr. Rajesh Kushwa sir. So it's a PLC reconstruction. Meanwhile, we are having the HTO, it's almost ready, so we'll be moving to the HTO immediately after. And the chairpersons for that session will be Dr. Arnav Kormakar sir and Dr. Amrish Jha sir.
Thank you, Dityo, for giving me the opportunity for explaining the posterolateral corner injury. Posterolateral corner injury was once considered as dark side of the knee because of poor understanding of its structure, biomechanics and treatment. But current understanding and has improved the knowledge of PLC. Posterolateral corner injuries are often associated with ACL and PCL injuries. Only 28% of PLC injuries occurs in isolation, and failure to treat PLC injuries can compromise our cruciate ligament repairs. So, diagnosis can require a high index of suspicion, needs proper physical examination, stress radiographs and MRI evaluations help in aiding the diagnosis. The non-operative outcomes in grade 3 PLC injuries are poor, and therefore surgical reconstruction is indicated. Some major static stabilizers of PLC are lateral collateral ligament, popliteus tendon and popliteofemoral ligament. I am skipping on the anatomical portions. The secondary stabilizers of the PLC are lateral gastrocnemius tendon, fabulofibular ligament, biceps femoris and iliotibial band. So, primary main function of PLC structures is, it is the primary restraint to various forces of the knee and prevents posterolateral tibial rotation. In cruciate deficient knee, it acts as a secondary stabilizer. Lateral collateral ligaments is also a primary restraint to varus stress. Even after the ligament is cut, often PLC structure serves as secondary varus stabilizers. It also for tibial internal rotation, popliteal tendon act as a minor primary stabilizer. ACL is the main stabilizer in the low flexion angle, and cutting popliteus tendon increase internal rotational laxity. Anteroposterior translation, PLC contributes minimally, especially in full extension or ACL or PCL deficient knees. So, it is mechanism of injury is due to direct blow to anteromedial aspect of the knee joint, due to hyperextension injuries, in contact or non-contact varus stress injuries. It is often associated with ACL or PCL tears, and every cruciate ligament injury should be assessed for PLC involvement. So, evaluation can be done by clinical examination, mainly varus stress test, dial test and reverse pivot shift test, and external rotation recurvation test is done clinically to confirm the PLC injuries. Modified Houston classified PLC injuries into 3 grades. Grade 1 is less than 0 to 5 mm of varus stress opening, and grade 2 is more than 6 to 10 mm of opening on varus stress, and grade 3 is more than 10 mm opening. So, a stress radiograph help in aiding the diagnosis of PLC injuries. MRI is required for confirming the PLC lesions. So, treatment rationales. In grade 1 and grade 2 injuries, it can be managed conservatively, but in grade 3 injuries, due to poor functional outcome and persistent instability and increased stresses on ACL and PCL graft, PLC repair is mandatory. So, primary repairs are considered for complete FCL or popliteus tendon avulsions must be performed within 2 to 3 weeks. Studies shows high failure rates. Treatment rationales, there are various reconstruction options preferred over repair, gradually for grade 3 or combined injuries. For chronic injuries more than 6 weeks, lower limb alignment must be assessed. because malalignment corrections must be needed before or during reconstruction to prevent graft overloading and reconstruction failure. The preferred technique is anatomical reconstruction by Laprade, which corrects all the three static stabilizer of PLC. Extra-articular tenodesis, Larson's technique, modified Larson's, and Laprade are the posterolateral repair techniques. So this is the single bundle reconstruction as was described by Larson. This is the modified Larson, in which the two bundle has been attached on the medial lateral femoral condyle, anterior crossing over each other and attaching onto the lateral condyle. This is the short video of Laprade anatomical reconstruction. Yeah, the graft has been harvested. So lateral incision is given, and through in between the Gudis tubercle and the fibular head, extension into the proximal femoral side, deep dissection is done. Peroneal nerve has been isolated and separated. Then from a drill guide is passed from the lateral aspect of the anterior aspect of the fibular head to the posteriorly, and through the zig a guide to prevent the posterolateral compartment structures. The second drill is made through the fibular head. So the third guide wire is passing from the anterior aspect of the tibia into the posterior surface. This is a drill going to the lateral condyle of femur through the adductor tubercle to the medial side of the femoral condyle, and both the guide wires are parallel to each other. Oops. Thank you.
To the IASONE feet to check if the HTO team is ready.
The diagnostic scopy.
Okay.
So we could find the bare medial compartment bone on bone disease. The cartilage on the femoral side was totally eburnated, and so was the tibial. Medial meniscus was frayed and degenerated. No obvious root tear, but otherwise it's purely frayed. We removed two loose bodies. One was the annual osteophyte and two loose bodies from the medial meniscus region. Probably calcified parts of the meniscus. The lateral compartment looks very good. Cartilage is healthy, and the meniscus is also good. I'll show the diagnostic in some time.
Okay.
And so far as the dissection, forceps, the given incision in the middle of the tibial tuberosity and the posterior middle border of the tibia, right 1 centimeter below the joint line till around 7 to 8 centimeters below the joint line, right angle. After dissecting to the bone, this is the T-shape, inverted T-shaped flap. Can you see this?
Yes, yes.
This is the inverted T-shaped flap of the pes incinerinus.
Okay.
That we have removed. Upper border of pes we gave a horizontal incision, then oblique incision, and then erase this flap of the pes incinerinus.
Okay.
This is the MCL, superficial MCL, that we have erased from the posterior middle border of the tibia, this one.
Okay.
Can you see it separately? This is the pes flap, and this is the superficial MCL.
Okay.
Can you see these two things separately?
Yes, we can, very nicely.
So now the the MCL is raised, superficial MCL, and the pes is out of the way. So we have our proximal tibia nice, bare and clear. So now we take the periosteum, go right along the posterior surface of the tibia, erasing the periosteum along the bone, so that all the deep and the important structures are separated, the artery and the other things are separated. We go right till the fibula. Siyam, please.
What is the age of your patient, Dr. Siddharth?
45 years.
55.
45.
45. Oh. Can the cameraman just show once the X-ray or the scanogram?
Okay, they have not given the brief history. The MPTA was 81 degrees.
Okay.
The LDFA was around 90 degrees, if I remember correctly. The deformity that we calculated was around 9 degrees of the varus that we want to correct. And that amounted to around 10 mm of the opening planned on the medial tibial cortex.
Okay.
My target is to open up the osteotomy and bring the mechanical axis in the line of lateral tibial spine. I am slightly less inclined towards going to the Fujisawa point. I am more happy at 55%, 45% in order to avoid changing the joint line obliquity too much. So my target is around 10 mm correction on the medial aspect and aiming for the lateral tibial spine, that is 45-55% line. So you can see the scanogram here?
Yes, we can.
So
how was the ligaments, ACL, PCL, everything?
ACL and PCL are good. The MCL we have raised and the LCL also felt good. This is the previous osteotomy we had 2.5 months back.
Okay.
कोई dynamic ना?
Anji? This is the previous osteotomy 2.5 months back, and this is the. There was an image that I shared with the.
Yes.
So we lose होगा तो much.
There was an image that I shared, that calculation image. Can you please display that?
So
calculation image. We made some calculations of the axis.
Yes.
I'll just share the image with you.
Yeah, that's okay. Fine.
That, we can tell. Basically, our target is 9 degree, 10 mm correction.
Okay.
So now we'll proceed with the osteotomy thing. So I'm clearing the soft tissue. Looking on the C-arm. Yeah, please show.
So what is the position of your knee? Flexion?
So it is, the bolster is below the distal femur. So that knee is in around 10 to 15 degrees of flexion. And that takes care of the posterior tibial slope. So I have a very single line view of the tibial articular surface. I don't have a double line view. So that is my position. And this is periosteum which has gone right till the image. Till the fibular neck, so I'm more or less clear till the area I want to go ahead with. I start my osteotomy by putting in parallel KYs starting at the posterior medial border. Okay, calculation open है? Yeah. Camera में है calculation?
Camera.
इस पे.
Sir, what is your indication for double level osteotomy?
Sir, when the correction, when the LDFA is also affected along with the MPTA. In this case, the correction, दूसरा image दिखाना दो था ना? दूसरा करो, छोटा करो इसको, दूसरा करो slide, उधर, एक ही है चलो ये है ना दूसरा, follow इसको, ये देखो. This one, this is the, उधर कहाँ? This is the mechanical axis from the head of femur to the ankle. We had drawn, and the MPTA came out to be 81.1 and the LDFA was 88 degrees. दूसरा वाला image दिखाओ. दूसरा image दिखाओ. The correction angle that we planned was 8.8 degrees, approximately 9 degrees, and the wedge, this is coming to be 9.2. I planned a 10 mm wedge. That is what I'm aiming. If you see, इसे enlarge करो, करो, इसको बड़ा करो और बड़ा करो, आगे करो. I am planning this wedge osteotomy starting around 3.5 centimeters below the joint line at the superior border of the gracilis, that is the pes and sinus, and going till the tip of fibula. And the final axis that I want is in the line of lateral tibial spine. This is slightly less, so that is why I increase the opening planned.
Sir, what is the app you are using?
Yes, sir?
What is the name of the app you are using?
Sir, this was from the Bone Ninja. We got the calculations on Bone Ninja. So we start with the around 3.5 centimeters below the joint line at the superior border of the raised pes. We put our osteotomy level. Now, right angle. So this is our mark that we had made with a cautery. Can you appreciate this mark?
Yeah. Yes.
Yes. So we plan our posterior wire from here. I am aiming towards the tip of fibula.
So Dr. Sridhar, do you do this in the KL grade 3 or grade 4 as well? So do you have any reservation for doing it in KL grade 4?
Sir, I don't prefer in KL grade 4, maximum grade 2, grade 3. Image?
And for that you do a routine weight bearing AP X-ray as well, isn't it?
3 weeks partial weight bearing, 6 weeks full weight bearing.
No, so, weight bearing X-ray I pre-op to judge for the KL grading.
X-rays?
Yeah.
It's the full weight bearing X-rays that we take and for the planning. So this is right directed towards the tip of fibula.
So how do you decide on your starting point of the K-wire?
Around 3.5 centimeters below the joint line, what my landmark is superior border of gracilis. When I'm erasing the pes, I mark the superior border of gracilis. That's what my starting point is.
Yeah, but this looks a little down, isn't it? In the C-arm?
3.5 joint line needle.
So what about?
We'll just mark the joint line with the needle. Joint line. We mark the joint line with the needle previously. नहीं बस ठीक है. This is the joint line.
Hello.
And scale. बेटा खींच के रखना sir, please खींच के रखना. This is a scale that we can take. You see, it is approximately 3.5 or maybe 3.8 centimeters.
Sometimes
the range
after osteotomy, it is
5
seen
to
that
4 centimeters. The range that we take. Next wire.
After osteotomy, it is seen that the proximal screw is at the osteotomy side. So the thing
is at the
proximal screw at the osteotomy side. So
okay.
So do you place the plate and mark it before doing osteotomy?
No, I don't mark it. I do it at the time of plate placement only, and didn't have this problem yet. Second wire, I'm planning to go in.
Okay.
Right, parallel to the, please now. Slightly more. This wire has to be parallel. Dekho? Yeah. Parallel and in line with the first wire. So we can see only a single wire that shows that both the wires are parallel.
So you are aiming at tip of fibula?
Yeah, I'm aiming tip of fibula. Or another landmark you can use is 1 centimeter below the lateral joint line, 1.2 centimeters.
Yes, yes.
Okay, the osteotomy we are planning is a biplanar one. So the division of plane will be done at the junction of posterior 2/3 and anterior 1/3 at the level of patellar tendon. That is the point where I plan to make my osteotomy oblique at an angle of around 120 degrees. It's a radiolucent retractor, the most important instrument in the whole of the case. So the point where we had cleared the periosteum posteriorly. So we put it along the bone, right in the level of the right in the line of the planned osteotomy. Dekha na bhai? So you can't see the retractor. The periosteum dobara do. I want to clear that line. I'm not happy. One has to be very sure about the clearance of the soft tissue in the popliteal fossa, in this region, before you start your cuttings. Yep. It feels good. Now I have put in my radiolucent retractor in line with my planned osteotomy. Show. Yep. Hold it. We mark the obliquity that we plan right now. And then we plan here approximately. Now we start the osteotomy. It's a stop and go technique. We can use a precision saw if it's available.
What is your opinion about hinge wear?
Please tell again.
Hinge wear. Do you recommend to use
Hinge
a hinge wear? Or
before I start opening, I'll put the hinge wire.
okay.
Wire this. क्या हुआ? सलाइन सिरिंज में लो यार, ऐसे नहीं होगा. सिरिंज में लो, इसमें नहीं होगा, इसे बंद करो. सिरिंज. रिलैक्स है, दिखाओ. तो हाँ, तो वी आर. बेटा ये ना रोटेटेड है, सुनो. दिस इज द एंगल, ओके? इसको यहाँ रखो. नाउ वी डू इट, ओके? So my target is mainly to cut the. My target is to cut the posterior cortex mainly. Show.
Camera, yes, we are not able to see.
Show.
Cameraman need to replace the camera because we can't see.
Show. Slightly more. Show. I think we are almost done.
So we can't see the CM picture. So one camera show the CM picture, one camera show the operative area.
Okay. One, can you see the image?
Yes, now we can.
Show the image. Fine. Yep. So we have almost reached the lateral cortex, around 1.5 centimeters left.
Yeah.
And I'm happy with this. So now we do the छोटा bleed है? Okay, छोटा वो दो spike. Now we do the oblique limb of the osteotomy. Like we isolate the patellar tendon, put a small spike under the patellar tendon to protect it. बेटा करना ही पड़ेगा थोड़ा सा retract ना. थोड़ा सा यहाँ भी करेंगे. Yes, now we are good. So this is the patellar tendon, if you can identify. And
so you have already completed your horizontal cut.
Yeah, I am almost done with my horizontal cut.
So,
maybe
so what is the extent, anterior extent of this horizontal cut?
So that anterior to 1/3 and posterior 2/3 of the shin. And at the level of anterior 1/3, now I'll make the cut oblique, going 120 degree upwards. ये छोटा ब्लेड नहीं होगा. हो गया चलो. एक हिंज वायर दो लोड करके एक और. We'll put a hinge wire that is between the Gerdy's tubercle and the fibular head, just at the border of the lateral joint surface. This is the fibular head and this is the Gerdy's tubercle. So we'll put a wire here. Show.
So do you direct your wire anteriorly or posteriorly?
This is in the level middle of fibula head and the Gerdy's tubercle.
Yeah, this is the entry point, but direction should be anterior or posterior?
Direction should be in line with the direction between the two. Show. Right at the border. To start here. Show. Yeah. Show. Yes. And in the line of the parallel to the tibial cortex. Show. Show now. Yes, we are good. Show. I'm happy with the hinge wire. So are we good with the hinge wire?
Yes, fine.
एक बार 100 दोबारा दिखाना बेटा. Let me check the anterior extent of the osteotomy. Somebody was not very comfortable with the head. It is going comfortably. We have done with the anterior extent also. Now we'll gradually open the osteotomy with the help of stacked osteotomes. All are there?
Yes, yes, we are watching.
Just waiting for lunch.
Lunch is already on, but we are watching to your.
Okay, so I'm missing
Very
the
nicely.
lunch. So, we can remove this one. Yep, show. So this needs to go further. Show. Slightly. एक और. Whatever Jana. The two wide ones go inside one after the other.
Okay.
The wire goes out. Wire निकालो ना. Wire नहीं निकाला. मैं wire निकाल देता है यार.
So what is your threshold for putting bone grafts or some fillers?
Sir, 10 to 12 mm. नहीं खोलना, बिल्कुल नहीं खोलना. 10 to 12 mm. We sometimes put a wedge beta TCP. 13 mm or more. I put a autologous bone graft. Show. बिल्कुल जोर नहीं देना बलजिंदर. खुल जाएगा. Show. When you are hammering the osteotomes, you have to make sure that you go right till the point.
Yeah.
The level you have made your osteotomy. थोड़ा सा यहाँ से ना कम हो गया. एक मिनट. अब दिखाओ. Show. हाँ. Show. Yes, we are good. Slightly opening more with the third osteotome in between. Any questions? Anybody? If you see the radiolucent lever stays in throughout.
Yes.
Anything now? Show. I think we have achieved a good opening. We don't need to go in more. So I'll remove the osteotomes. वो देना यार जो distractor है. Screwdriver इसका. This is a distractor. Again, trick is all these instruments need to go till the site where the osteotomy till the time you have the site where you have put in your osteotomes and done the osteotomy. Show. If you open them before, you can. There is a high probability of having a type 2 or type 3 hinge.
Yeah.
Injury. So you have to reach till the point you intend to. Show. Yes. Jana jara screwdriver. So we slightly open it up and distract our osteotomy. So because 6 degree opened already, angle वो rotate हो गया image. Yes. Show. 8 degree opened up, and this is a 9 degree opened up. I'm happy with the opening now. So we are opened completely till 10 degree, the one we intended to. Now I'll close this lamina spreader. Get this out of the lamina spreader. The lamina spreader goes at the posteriormost edge. The minor spreader tends to fall off in between. So you have to be careful that it doesn't fall off.
Yeah.
It's
so,
opening
sir,
up.
you are placing your distractor at the posteriormost border. So
Yes.
So how do you control your overcorrecting the posterior slope? Because the opening will be more on the posterior side.
Sir, if it is a uniform cut of osteotomy, the opening will be uniform. The posterior border gives you an equal pressure on the anterior side and the posterior side if you start at this border. So that is why I start opening from here. This is a measurement of the scale. The easiest way to do it is cut a plastic scale for the length you desire. Cut it at 10 mm and trying to see the opening. It's not yet open till 10 mm. So it's around 8 mm we have opened. So I'll open it up a bit more. One more thing, we all talk about osteotomy opening less on the anterior aspect and more on the posterior aspect. Do we all agree about it?
Yes.
And that changes the slope and everything. We all say that. There's a once food for thought. Tibia is a trapezoidal bone. All of us agree?
Absolutely.
So the anterior border of tibia, this one, is way more medial than the posterior border.
Yes.
So something that opens up like this will be opening less in the midline than it opens on the lateral, the medialmost border. So apparently you will always see a less opening here and more opening here, even though the actual angle is the same. So probably we are not having a differential opening. It is our perception that is different about the openings. So I'm good at 9.9 plus opening. Just show me on the छोड़ना है निकाल दो हाँ दिखाना हाँ sorry अब दिखाना. So this is the opening we have achieved. I feel that we could have gone slightly more in, maybe 5 mm more. Anyways, the hinge looks intact. Now we check for the alignment, the rod. पूरी लंबी करके दो बेटा. चूड़ी वाली थी यार. कल तो देखी थी चूड़ी वाली थी. नहीं है. एक और दो. बेटा अब सीएम दिखानी है आपने. हिप जॉइंट पे दिखानी है. एंकल पे दिखानी है और घुटने पे दिखानी है. ठीक है. So this is a alignment rod, a metallic rod. I don't use the cautery wire. I use the alignment rod proper. So first we see the hip joint. Hip पे आओ बेटा. पकड़ना पड़ेगा बस यहाँ से आपको. अभिषेक शो फैक्टर बढ़ाना और दिखाना. फैक्टर बढ़ा के दिखाना ब्रदर. अंदर करो मेरी तरफ. सर की तरफ. डॉक्टर अभिषेक की तरफ. हाँ या शो नाउ. थोड़ा ऊपर चलो सिर की तरफ. शो नाउ. फैक्टर बढ़ा के. नॉट सेंट्रल सर थोड़ा सा करो. सेंटर ऑफ द हेड नॉट देयर. और थोड़ा सा कर लो सर. आई थिंक वी आर गुड. शो बेटा. यप ऑलमोस्ट सेंटर ऑफ द हेड. नाउ वी कैन कम टू द एंकल. शो करना एक बार दोबारा. मिल गया. या वी आर गुड. एंकल जॉइंट बेटा. फैक्टर कम कर देना और एंकल पे आना है. चलो 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 कुछ मत हिलाओ. बस बस अपनी तरफ लेके जाओ इमेज. बस फैक्टर कम करो और इमेज दिखाओ. हिलाओ मत जल्दी. शो अंदर करो. शो. Yep, we are good at the ankle. Looks good. Can you see the image?
Yes, we can.
थोड़ा सा ऊपर करो.
Now we need to see at the knee.
अपनी तरफ करो. आप करो. फोटो खींचो. यहाँ पे टिकाओ इसको. सुनिए यहाँ रखो तब हिलेगा नहीं. दिखाओ. अब दिखाओ. अब दिखो, ये नाउ नी पे आ जाओ, घुटने पे आ जाओ बेटा, मुझे लग रहा है हिल, बस 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 दिखाओ, गो मोर अप. I feel that we have moved everything again. Looks to be well corrected here. एक second. Show now. थोड़ा सा ऊपर चलो. Show now. We have moved the rod all around. Show again. अब दिखाओ. अब दोबारा हिप पे और एंकल पे दिखाना है, दोबारा से हिप और एंकल दोबारा दिखाना है. अब सब कुछ कोई मत हिलाना यार. दिखाओ. वही पे बेटा और ऊपर जाएगा. लाइट खींचो ना, ऊपर लाइट फंस रहा है. थोड़ा सा अंदर करो. बस दिखाओ, दिखाओ बेटा. यस, एंकल पे आ जाओ. तो
by 2 weeks. How would you deal with that kind of syllabus?
सर खोलो, निकालो, वॉश करो और फिक्सेटर लगाओ. That osteotomy can also be done with the help of fixator, and I think that way you can achieve both the things, both fixing the osteotomy as well as taking care of the infection. That is thing I think I would do if at all I get infected osteotomy, because my simple concept is with a plate inside, you cannot take care of the infection. The infection sticks to non-living. Whatever antibiotic you give travels through blood. Blood does not go to the metal. So unless you get your metal outside, your artificial things outside, your infection is not going to heal. Go ahead, remove the plate and treat it like a normal fracture.
So you would not attempt any retain the implant, do some antibiotic beads?
Oh, no, first point is just wash it, debride it. Right. That's what I said. Na, first thing, whenever you are suspecting it's not healing, there is some element of infection, go ahead, wash it, debride it, put some antibiotic cement or something, 26, antibiotic cement or something like that. And still if it does not settle, the first debridement phase, then you should seriously consider removing things. Rather than just keep on, like what you do in fracture, you always give one attempt of simple debridement if the infection is not very severe. If that fails, then you go ahead and remove the implant. That is what my approach is. I essentially treat osteotomy as a fracture just created by us rather than the nature. For me, osteotomy is a controlled fracture done by us. The only question, thing that always remains in my mind is what happens to this gap? When does it heal? Seniors, any opinion about it? Because in many months, even few years down the lane, I always see this gap persisting. So when do you see this gap actually getting obliterated? What is your opinion of the house on this, seniors? Anybody? The panel?
It's always a different finding in different cases. In some cases it's get healed, in some cases it's not getting healed.
Yeah, it always keeps on, glaring from there. And you're always worried whether it's healed or not. But so far I feel something holds on, God holds on and doesn't give way. So far it hasn't. And I just hope God keeps on holding it like that. But
most of the time in smokers and drinkers, it will not get healed. Even
Yes,
it will
sir?
be a less opening, but it will not get healed.
So this is the last screw in the distal, 36, last screw in the distal fragment we are putting, and with this I will be completing with the osteotomy, and then we'll proceed for the arthroscopy and the meniscectomy part. I think Dr. Abhishek will take care of that. Dr. Abhishek is with me from Kolkata, and okay, Dr. Hazra. Doctor?
Sir, can we take a lecture in middle, sir?
Yeah, sure, sir. We are done with the osteotomy. If you want, we can go off. The scopy part we'll do by ourselves. If you want to ask anything, final picture of the osteotomy, remove karo yaar, remove.
Maybe sir, can we see the hip knee axis once more?
Yes sir.
Can we see the hip knee axis once more with the rod?
Yeah, sure. एक बार ही निकाल दो, फिर दिखाते हैं. लो भी rod दो दोबारा से alignment rod. Alignment rod दो. नहीं मिस हो गया और ये गिर गया. अरे गिर गया. लाओ रॉड दो यार, रॉड लगाओ. सारा ही गिर गया यार नीचे. Some of the knots came out of the C-arm and it was falling on me. Good, it was the leg gone and not the knot of the deep knot. Lovely. Show. Hip. I would suggest you to always use these rods rather than using the cautery lead. और अब जाओ बेटा. देखो सर. और बाहर करो सर. Yes. दिखाओ.
So the next speaker is Dr. Kevin Vadodaria. His talk is on rehab protocol after PCL plus PLC. So we'll have the lecture immediately after sir shows us the axis.
जरा सा किया मैंने इसके बाद. नहीं दिखाओ. एंट्रल है, थोड़ा सा इधर कर लेते हैं. दिखाओ. ठीक है, नीचे आओ. एंकल पे. अब एंकल पे शुड बी इन द सेंटर. शो. Ankle is tilted. लो अब दिखाओ. Show. Now show. कर रहे हो यार एंकल पे तुम. अब दिखाओ. Yes, now. फिर से चलो हिप पे. हिप और फिर नी. फाइनल. अब हिलाना मत कुछ भी. हिप. और ऊपर चलो बेटा हिप पे. ठीक है, दिखाओ. चलो नी पे आ जाओ. चलो. दिखाओ नी पे. शो नाउ. अब इसमें ज़्यादा वैल्यू आ रहा है. अब शो करो. नहीं ज़्यादा हो गया टिल्ट, कम करो. फिर दोबारा. Essentially it looks like going out through the lateral compartment only. Maybe 2 or 3 degrees here or there. This is an exercise we can keep on continuing. I think we have essentially crossed the midline. That is what the target was. Anything else?
No, sir. Can we have a huge round of applause for sir and the entire HTO team?
Thank you.
So, thank you, sir. Thank you.
Thank you, organizing team and the OT staff, Dr. Abhishek and Dr. Hazra, for being an excellent assistant. Thank you, everybody.
So we move on to the next lecture by Dr. Kevin Vadodaria.
Thank you, Tamluk Ortho Club and IAS for giving me this opportunity to speak on post-PCL reconstruction and PLC reconstruction rehabilitation. Looking it simple, but it's very complex topic. Why it is complex, I'm telling you that till date there is no consensus on the rehabilitation. In the different books, there are the different terminology and the slightly change in protocol. Even in between the 2 edition of the book, you will see there is a differentiation in the rehabilitation protocol.
So
the general guideline for the PCL is like no open chain hamstring work. This line is important because we have to understand the action of the quadriceps and the hamstring, because the antagonist and the agonist will works in the ACL and the PCL differently. Typically it takes 12 weeks for graft to bone healing time, and caution against the posterior tibial translation should be, we have to focus on gravity and the muscle action. And typically, no CPM, continuous passive motion exercise for the PCL rehabilitation. And PCL with posterolateral corner or the LCL repair, again it will follow the different post-op rehabilitation because of the two surgery and there are multiple graft protection. There are resistance for resistance hip exercise should be there, and it should be in the protocol of the PCL like abduction and adduction resistance, because there are the muscle connecting the two joints will also participate in the rehabilitation. The supervised physical therapy generally take place for 3 to 5 months post-operatively, and it is simultaneously supplemented with the home-based physiotherapy protocol. So this article shows the PCL graft healing times have been reported to be almost the doubles the time of the ACL graft healing. So in the progression of the activities of the daily living, the patients may begin with the following activities like bathing and showering after 1 week post-op, and typically patient can return to driving 6 to 8 weeks and typically begin sleeping without brace the 8 weeks. These are the progression of the activities of daily living. And full weight bearing without assisted device 8 weeks post-op with surgeon's clearance based on the structural integrity of repair. And the exception is PCL with the PLC or LCL repair or reconstruction. So it is divided in the different phase, the rehabilitation protocol. So it's up to 6 weeks is the first phase, and it's not a rise, it's a price here because we have to protect our graft and our reconstruction. So things should be in mind like protect, rest, ice, compress, elevate, and avoid hyperextension. It's very important in the PCL up to the 12 weeks, and prevent posterior tibial translation up to the 12 weeks. So any activities which create the posterior shear force on your reconstructed PCL, it should be avoided throughout the rehabilitation protocol. And the isolated hamstring exercise should be avoided for 4 months because hamstring will give the stress on the PCL by pulling the tibia backward. So non-weight bearing or the toe touch weight bearing is the surgeon's choice, and that 2 up to 6 weeks. So our goal of the exercise for the PCL is like graft protection, reduce edema. It start on the day 1 post-op. Address the gait mechanics and the patient education. The another thing to focus is there should be patellar mobilization, prone passive ROM. It will work well in the PCL and it should be there. There is no active flexion kind of the knee or exercise. And the quadriceps activation is very important because it is the antagonist of the PCL. It's pulling the tibia anteriorly. So static quadriceps, straight leg exercise, and the gastrocnemius stretching, hip abduction and adduction, again it is important. And the upper body and the core strength as appropriate, which starts slowly. So hyperextension position, this kind of position should be avoided where your knees will get hyperextension. Knee flexion. So active flexion not allowed, as I already told you, it will create the shear force on the PCL and the tibia, and the no hamstring curls. Passive flexion is allowed, and that too by the physiotherapist. Now the next is the range of motion that should be in the brace, and the prone passive ROM. It's good for PCL rehabilitation from 0 to 90 for the first 2 weeks. It's your target movement and then progress to full ROM as tolerated. Immobilizer brace for 3 days in extension until patient can transition into the jack PCL brace. Jack PCL brace is the, you can see in the picture also, throughout the flexion it will give the posterior support and it will lift the tibia anteriorly. It's a jack brace. Some people are using, some people are not using, and the PCL jack brace to be worn at all time including the rehabilitation, and also during sleeping for minimum 24 weeks. So these are the different commercial devices or this brace available. You can see all are in the different design, but definitely with the hinge for controlled motion and posterior support over the calf. The indigenous PCL brace is what we are using. If we are not in access to the jack PCL brace, we can use the static brace, and you have to remove your brace 3 to 4 times a day for your passive range of motion exercise. And you can also use the dynamic brace with the hinge, but your hinge should be enough hard or strong to resist the movement. These are the PCL jack brace. You can see there is the posterior lift support over the calf. It will continuously giving the pressure over the tibia to lift the tibia upward, and it will protect your graft and not giving the excessive stress over your PCL reconstruction. So these are the features of the jack brace. Is the constant translation force irrespective of the flexion angle. Spring force can be easily increased or decreased. There is some setting to reduce or increase your that pressure, and the spring tension can be switched on and off. And the limitation in 15-degree increment in extension and the flexion, and the extension limitation 0, 15, 30 and 45, and the flexion limitation 60, 75, 90 and ahead. The range of motion possible from 0 to 120. Temporary immobilization is possible here. So another thing important in the rehabilitation is the mechanotransduction. In an injured knee, anatomic remodeling occurs through a process called mechanotransduction, where cells sense and respond to mechanical loads. Hence, wearing a PCL brace may be more beneficial than wearing an immobilizer following an injury. Slowly stressing the ligament over the time as it is healing and should allow it to regain strength at a safe rate. So now coming to the second phase, which should be 6 to 12 weeks. Again the precaution and protection is there. And after 6 to 12 weeks of the injury, continuous avoidance of the hyperextension and the isolated hamstring activation. Prevent posterior tibial translation, weight bearing, and progression to weight bearing as tolerated. So full range of motion, supine and prone, and that should be after 6 weeks. It will be start, and caution to not be over aggressive with the flexion, creating stress on the repair. And particularly after the 60-degree flexion, the PCL will get so much stress. So PCL jack brace to be worn at all the time, and winning of the crutches will start from this phase. This is the active assisted ROM start. This is, you can see with the normal leg, you can lift up your opposite leg. They are the therapeutic exercise: squat progression, double leg press, hamstring bridge on ball, and the stationary bike, and the light kicking in the pool. It's a therapeutic exercise, part of PCL rehabilitation. These are the recommended cycle in sitting and the standing bicycle. The sitting to start and then to forward to the standing. This kind of kneel down and the full bridge position is not good for post PCL reconstruction. And in phase 3, again the jack PCL brace for all heavy activities, full weight bearing in jack PCL brace, full passive ROM, and avoid isolated hamstring exercise. This is very important. Till phase 3, your isolated hamstring exercise should be avoided. Again therapeutic exercise, leg press and progression to the single leg, first double leg then single leg. This is the single leg bridge after 12 weeks. The leg balance squat is the phase 4. Again precautions are there, and the goal is to continue to build the strength. Now muscle strengthening exercise will start, and the single leg endurance for all lower extremity musculature. So continuous open kinetic chain and the closed kinetic chain strengthening exercise, and the endurance work with the progressive weight. Initiate initial sport specific drills near the end of this phase. Now patient start going back to the routine, his activity and the sports life, and the clinical examination and or a PCL stress radiograph to objectively verify healing of PCL after week 24. So in phase 5 is 25 to 36 weeks. Again, patient can be weaned out of the jack brace starting at 24 weeks. They are ready. Therapeutic exercise, absorption activities, and continuous muscle strengthening and the endurance exercise, and open kinetic chain for quadriceps and the hamstring. So return to competitive sports usually 6 to 9 months. These are the criteria you have to follow, like week 1, 2, 3, 4, the walking and the jogging. 4 minutes, then reduce the 1 minute and giving to the jogging session. Return to sports after surgical treatment of the posterior cruciate ligament. This literature in the Germany 2016. If you follow the standard, there is no standard rehab protocol, but still if you follow the controlled PCL rehabilitation, then your return to sports rate should be 87.0%, and the combined PCL injury with PLC or lateral collateral, then 17.6% is unable to return to sports, and in the isolated PCL, even after following the standard rehab protocol, 4.8% people are unable to return to the sports. So when to resume sports, this is the standard criteria all over the world, is the Hope test. We all know about the Hope test. More than 85% limb symmetry should be there in the test. So Daniel found one-legged hop test for a distance, and the Barber described the 4 hop tests: single, timed hop, triple hop and crossover hop. The single-legged hop for time and the crossover hop have been reported to the most sensitive and the best indicator of function. You can see so many video of the hop test, so you can understand it's the single leg stance jumping activity on the particular distance with the time. So quality assessment is the 8-inch step down. The lack of apprehension should be there. So isokinetic test, again more than 85% limb symmetry to the normal unaffected leg. So this picture I have not going into detail, taken from the noise knee surgery and the rehabilitation. You can print this and you can give it to your physiotherapist also, and you can mark your particular point according to weeks and give it to give this chart to the patient and the physiotherapist. So now in a PLC, posterolateral corner reconstruction rehabilitation, almost same like PCL, but not going into detail. The standard is you have to control the pain because it is the open surgery. Hemarthrosis, effusion should be controlled. Non-weight bearing, more than the PCL, here around the 8 weeks, 6 weeks will be there. It should be the patient specific protocol. There is nothing like standard protocol. Depend on your how many grafts you have used, the quality of the graft, patient occupation, your rehabilitation protocol will change, and the world is moving towards now is the patient specific protocol. So hinge ROM knee brace from the day one. So protected knee motion, passive knee, passive range of motion again up to 6 weeks. Avoid undue overloading of the joint, because you have reconstructed on the lateral side, so your anterior posterior excessive movement and the internal tibial rotation should be prevented. Prevent the stretching and the lateral opening, so it's a varus loading of the joint. Avoid hyperextension, and the quadriceps contraction and the muscle strengthening should be there, and from the day one it should be start. This is again the same chart, but for the PLC reconstruction. You can follow this according to weeks and the month. It's up to the brace, range of motion, weight bearing, patellar mobilization, stretching and the different strengthening exercise in the different weeks and the different phases. And till up to the conditioning exercise will start for return to sports and back to normal life. So thank you.
Patellar dislocation accounts for 3% of all knee injury, most common in female adolescent. Recurrence rates for first dislocation 70%, with dysplasia 60%, after second dislocation 50%, and patellar dislocation mainly occur laterally, medial typically iatrogenic. Classification of the patellar dislocation: acute, recurrent and habitual. Acute single episode after significant trauma, and it always occur laterally mainly. For recurrent, repeated occasional dislocation occurs at interval of weeks or month, and in habitual dislocation, patellar dislocates every time when knee is flexed, and patella cannot be held in position throughout full range of motion. Now for patellofemoral joint stabilizer, static stabilizer are shape of the patella, shape of femoral sulcus, patellar tendon, capsule, reticulum, ligaments, and middle patellofemoral ligament. And dynamic stabilizer are quadriceps muscles and vastus medialis obliques. The MPFL is condensation of the medial reticulum. This is vertically oriented extra capsular structure found in layer 2 of 3 layer, primary medial restraining structure for lateral displacement, and it contributes up to 80% for the medial restraining forces to the patella. In cases of full patellar dislocation, the MPFL has limited ability to lengthen. The capacity of the MPFL to heal is also limited. MPFL attachment, femoral attachment, 5 to 10 mm proximal and 2 to 5 mm posterior to the medial epicondyle. In the saddle between medial epicondyle and adductor tubercle, approximately 2 mm anterior and 4 mm distal to the adductor tubercle. The width of the MPFL at the femoral insertion site is 10 mm. Patellar attachment site at the junction of the proximal and medial third of the patella, typically at the location where the P perimeter of the patella becomes more vertical. Mean width of the insertion is 28 mm and it's wider than femoral attachment site. Goals of the surgical treatment for MPFL to re-establish the natural check recurrent against lateral patellar motion and to re-establish normal limits of the passive lateral patellar motion. MPFL repair or reconstruction. In acute repair, if we done MPFL reconstruction, result will be mixed, up to 20% failure rate. And lateral repair or implication is chronically lax tissue, high failure rate, not recommended. Reconstruction most successful. Indication for isolated MPFL reconstruction, recurrent patellar dislocation, acute patellar dislocation, very rare. When there is osteocondylar injury at the time of the dislocation, failure to improve with non-operative care, continued gross instability, injury to MPFL and VMO mechanism, or high-level athletes that suffered a non-traumatic dislocation. Indication for isolated MPFL reconstruction, failure of conservative therapy for at least 3 months in association with mechanical instability. First, we have to rule out the functional instability, ligamentum laxity, muscular weakness, poor body mechanism. Rule out psychological factors in association with anterior knee pain, as the presence of this tend to lead to poor outcome from surgery. Ideal candidate for MPFL reconstruction when the Q angle is less than 25 degree, no cartilage injury, trochlear morphology normal or type A dysplasia, and tibial tuberosity, trochlear sulcus angle 0 to 5 degree valgus, or TT distance less than 20 mm. No patella alta, patella tilt less than 20. Other indication for MPFL reconstruction as adjunct to trochleoplasty, distal realignment, or varus femoral osteotomy. Contraindication for MPFL reconstruction when there is isolated patellofemoral pain, excessive lateral patellofemoral tilt, or translation on imaging. MPFL is not meant to pull the patella into position. Its role is to stabilize a located patella against excessive lateral force. Contraindication for MPFL reconstruction when there is presence of J tracking alone in the absence of other objective clinical sign and symptoms. An isolated MPFL reconstruction is unlikely to eliminate patellar J tracking. Permanently dislocated patella, habitual dislocation of patella, and when there is MPFL laxity is a result and not a cause of such an extreme alteration of the extension mechanism. When there is significant patellar malalignment with an increased Q angle, severe trochlear dysplasia, or significant patellofemoral degenerative changes, grade 3 to grade 4. Surgical steps, first we have to examine the patient under anesthesia. First we do diagnostic arthroscopy by superolateral portal. Then we will harvest the graft and prepare the graft. First we will do incision on medial side of the patella. First incision, second incision on femoral fixation side. First we fix the patella side, then we will pass the graft from incision 1 to 2, and then we will fix the graft femoral side after checking the appropriate tension. Graft source may be gracilis, semitendinous as medial patellar tendon, adductor tendon, quadriceps tendon, allografts, or artificial tendon. And one end of the graft may be left attached. MPFL tendon graft reconstruction technique, alternative technique for MPFL tendon graft reconstruction: tunnel graft into medial patella, suture anchor and loop fixation at medial patella, loop graft around adductor tendon insertion, patella tunnel fixation, adductor tendon graft and suture graft under and through VMO and also into quadriceps tendon. This is the quadriceps tendon graft and this is the adductor tendon graft. First we have to make a drill transversely, or we can also make a drill longitudinal. These are the different technique for making drill. First we will pass the graft extracapsularly from incision 1 to 2. Fixation side at femur by screw, suture or bone plug staple. These are the point where we will fix the graft on femur. This is the shortest point. First we have to place the pin at shortest point and drill the bit pin to lateral side. Drill 4 mm tunnel through and dilate according to graft size and length. Pass suture on bit pin to lateral side. Pull the graft ends in tunnel and put the needle wire for screw insertion before whole graft goes in. Otherwise finding the tunnel to put screw will be difficult. Put appropriate size screw flush to the cortex. Appropriate tensioning, the ideal tension at the time of the fixation of the graft is not so exactly specified everywhere. The ligament function as a check ring in early flexion and is therefore under the greatest tension in this range of knee flexion. It is logical to fix the graft within the knee at 30 to 40 degrees flexion. And the patella should not be pulled medially by the reconstructed ligament, but lateral translation beyond the lateral margin of the trochlear should be prevented. The tension of the graft can be adjusted to achieve this balance prior to fixation. By cycling of the knee through flexion and extension prior to fixation may help reduce subsequent creep in the construct. Excessive tension in flexion can lead to painful reconstruction, restriction of the knee flexion and articular cartilage overload in the middle patellofemoral compartment. Patella should enter trochlea from slightly lateral in extension and become centered by 15 to 20 degrees knee flexion, and it should be verified arthroscopically, and it never come more medially. Here are the pre and post of arthroscopy findings. For skeletally immature patient, modify the femoral side fixation. Don't create bone tunnels or dissect the periosteum in the region of the distal femoral fascial plate. Adductor magnus tendon transfer. Alternative procedure: adductor magnus tendon transfer, adductor sling technique, medial collateral ligament sling technique, and combined MPFL and MPTL reconstruction. This is the adductor sling technique. Here the implantless tunnel free MPFL reconstruction. After fixation, after post-op, most of the published studies have described a period of restricted range of motion using a knee immobilizer or a hinge brace for from 2 to 6 weeks. The range of the motion is limited to 0 to 60 degrees. Weight bearing status also varies considerably, ranging from minimal to full weight bearing. Bony fixation, when we do bony fixation, full range of motion and full weight bearing are allowed within the limits of comfort. For soft tissue fixation, some limitation of range of motion and reduced weight bearing may be appropriate. Rehabilitation, closed kinetic chain quadriceps strengthening be introduced from between 3 to 6 weeks. Control open kinetic strengthening from 3 months. And return to non-contact sport with resumption of contact sports in 4 to 6 months, depending on individual strength, agility and confidence. Complication after MPFL reconstruction, pain, stiffness, prominence of fixation of hardwires, patellar fracture and recurrent lateral patellar dislocation. After if the graft contaminated, if there is any infection, hematoma formation of graft site morbidity. Thank you.
So our next lecture is on MPFL reconstruction, different techniques by Dr. Deep Chakravarti.
Good afternoon, everyone. It seems like there's a lot of dilution in the crowd, and last lecture is always a last lecture, not the interesting one. Anyway, Dr. Dey has done a lot of work for me. I just need to speak only 10 seconds about it. He has almost covered all the topics. Good evening, sir. So I've been told to say some words about how do you reconstruct MPFL and different techniques about it. So as Dr. Dey has already covered part of the anatomy, what you actually need to remember is MPFL has two different anatomical landmarks where it inserts. In the patella it's little wider, and in the femur side it's little smaller. So all this anatomy has always been cleared. So after you get a patient of patellar dislocation, and you have understood the chapter where it says how to go about treating a dislocated patella, and you have mastered it, and you are also confused which surgery to be done. And if you have finally selected कि MPFL is the surgery the patient requires, then how to go about it. So for a successful surgical treatment, we have to establish that the MPFL is in order correct, and it is the medial check-in. So diagnostic arthroscopy is always to be done first to check if at all our MPFL structures are okay or not. So in the figure you can see how a reconstructed MPFL will reduce the lift off of the patella. So these things have already been covered. A quick short note about what's the shortle point. I've always been confused. I always go through Google to find out the exact location. But what we need to remember is Servian et al. Expanded the 5 mm circle to 7 mm circle, because most of the times we would be using gracilis or semity, and double bundle would eventually be that large. So graft source has already been discussed. Most of us are actually in a dilemma of whether to use gracilis or whether to use semity. So let's get this thought cleared out. So graft choice of isolated MPFL reconstruction, there was a study by Filipino in 2020 where they compared, and they have precisely told semity is the best graft for choice, not because of the initial strength, because it prevents further revision. So there are, if you go about in the book, you will see a lot of pictures going haywire, going from A point north to south, and you will just feel like which surgery to be done, which is the best way. But none of them are actually anatomical, and they have also good complications. The only way to do a good anatomical repair is something like this. So this is a company-made video. I'll just show how they go about it. So initially a medial incision on the medial side of the patella. So they drill 2 holes for 2 anchor placements, and then they quickly shuttle. See, as you're going about it, this is anchor, and they just the free end of the graft of say gracilis or semity is inserted into the superior in the middle part of the patella, and then they are shuttled between the layer 2 and 3, and they are inserted in the femoral anatomical location called the shortal point with another tenodesis or a screw of your choice. So this is not a very uncommon video. If seen, you can always find it online. There is another technique using the same principles. What we actually are trying to establish is like we are trying to get 2 secured fixation in the patella, which not only reinforces the MPFL but also the MQ2FL. MQ2FL is very important for the medial check rein, and if this is the method of fixation you are using, so a superior anchor and a middle anchor will ensure that. Sooner you just pass the graft. In this case, we are actually using the looped part in the patella, and the free part goes into all the way to the femur. So another basket wave technique described by Cordani. So this is actually done mostly for pediatric cases where the incisions remain the same, but what he uses is a specialized kind of device, a weave, which he goes through the quadriceps expansion and sutures it back to the patella. This is a friend of mine, Mr. Alex. He, in his Ortho One fellowship days, he actually published this very beautiful thing they have gone about, and they are doing implantless surgeries for MPFL. What they eventually do is like they pass ethibond through and through the patella and use it to grasp the graft, and then again fix it in the femur with either screws or just very low cost implants. So very effective in remote areas. For skeletally immature patient, it has always been challenging because where to put the graft, how to put the graft, there are high risk of failures. So Magnus, so they are not going by any static fixation, they are going by dynamic fixation where they are looping the graft in and around adductor magnus and use it as a sling. So what is eventually does is like as the body grows and there is high chances that the graft would not fail. So getting the right trajectory in the femur in a skeletally immature is very important. So we have to remember the insertion in femur is below the basically what do you call this, the fascial plate. The right way to tension the graft is at the end of the surgery. Always be in 45 degrees of flexion and don't do much varus valgus, just fix it in neutral rotation and go through a decent way of cycling. Lateral release is also a conceptual idea, but many a times you don't need it, but depending on the chronicity of the injury, lateral release must also be added. So these are another pictorial representation of how to go about doing a MPFL in different techniques. But none of them are anatomical. If you want to do anatomical, I think the screw methods are the best ones. So this is an ongoing publication where they are trying to understand the dynamic versus static medial MPFL reconstruction technique and for recurrent patellar dislocation. It's a randomized clinical protocol. It started in 2022 and they are trying to find out which way is better. What they're trying to establish is like when they are using gracilis as a sling, gracilis as a muscle acts as a medial checkpoint, and the strengthening of gracilis will always keep the patella centered and never let it dislocate laterally. So this is just 2 quick cases from my side. So this is another 13-year-old girl which came to us with a MPFL injury. She was unable to squat and all. You can see there is so easily I can track the patella all the way laterally. There is good lift off. Then again with exactly after the surgery there is good limitation of movement on the left hand side, and we are able to safeguard her. So this is very important while taking the C-arm pictures. A good lateral view is always necessary, otherwise you might miss the actual anatomical point. So this is the girl around after 4 weeks. She is able to do full knee flexion. She is able to squat also. So people improve. These are very satisfying surgeries. Coming to a different case, this you will see patient is actually, this is a maltracking patella which dislocates in terminal flexion around 90 degrees. You can see there is a good jerk of patella. So these are little kind of complex cases. So we had to go to tibial tuberosity advancement, medialization as well as proximalization, quadriceps snip, and plus lateral release. So you will see in this video, after all the effort we have done, we are still not able to get the lateral retinaculum back to the patella. These are very challenging cases. We cannot do much about it. So fix it as much as possible and just let it be. But you will see it's gliding really well, and at the end of the surgery, the patella is tracking well. And I'll just show you a video of how the patient is doing. So this is around six months follow-up. So patient is able to extend and the patella is gliding exactly at the natural joint. So that would be it from my side. Thank you for your patient hearing.
Now we have the live surgery. Hello, hello. Irish OT.
এই না নট তুই আরেকটা বুঝিতে আছে ওখানে তুমি নয়
স্যার শুনতে পাচ্ছেন?
হ্যাঁ শুনতে পাচ্ছি। ক্যান ইউ হিয়ার মি?
Yes sir.
Yeah, so
sir, I would like to invite Dr. Rajesh Kushwa and Dr. Atul Srivastava to moderate the live surgery session.
No, I don't want difficult moderator. I want simple moderator. Hello, Rajesh. Can you hear me?
Hello.
Yes, Rajesh, can you hear me?
Yes, yes, clear.
Okay, so no difficult question, please. ठीक है?
अरे दादा तुम्ही सब पारो.
So we are there to ask you tough questions, Sunita. Don't worry.
अरे बाप रे,
बना गया. Just finished my meeting. To see your live surgery.
थोड़ा और देर तक मीटिंग करने से अच्छा रहता है. Yeah. So I thought I won't show these sort of stages because this is a long surgery. So I was planning to pick up the graft first. So my planning is, this is the case of PCL with PLC. Very frank, the PCL was PCL avulsion, but since this was a 2-year-old case, so we decided preoperatively that we will be doing the PCL reconstruction as well as PLC reconstruction. Can you hear me?
Yes, yes.
Okay, so that was the plan, PCL and PLC reconstruction. For the PCL, we are planning to use tendon stripper. We are planning to use the peroneus longus, and for the PLC, we are planning to use semi-T graft. Okay, so we are just about to pick up the peroneus longus graft, and then we will pick up the semi-T graft, and then we will start doing the PCL reconstruction. So for the PCL, we have a very nice tibial endo button adjustable loop, which is very nice thing, where you can have the advantage of doing the conventional PCL drilling, but you can use it as an all inside sort of device. So I think, in my opinion, the tibial fixation area is the most problematic area for the PCL fixation. And a large endo button gives you the most robust fixation. That's why I am planning to do this tibial endo button fixation. And for the PLC, I am going to use the semi-T graft. Blade down. Okay. So since we have pre-decided what we are going to do, we will pick up both the grafts and then we will start doing the PCL reconstruction first. After that, at the end, PLC reconstruction by Laprade method. So if you have the enthusiasm to stick by that time, then you are most welcome. Otherwise, you can enjoy your beer as well. It's quite an evening now. So this case was, the planning was done by the Manada. So we think that, and there is no better person to plan than Manada here. He came early and did the planning, and we are just executing. Blade.
Sunita, can you tell the
Yes.
cameraman to focus?
Yeah. No, these are not very expert cameramen, so I do not want to move. I have positioned them for the PLC, which is most important thing. So I do not want to move the camera right now. I think the graft harvesting has been shown by many videos and everything. So we do not want to show you the graft harvest. Just bear with me a few more moments. We will go the intra-articular part, and then you can see the PCL reconstruction intra-articular part. We are just picking up the semi-T graft, so we do not want to show you this one, because we do not want to move the camera too much, because they are not very experienced people to move the camera as quickly as possible. We have seen this in Calcutta. Is it fine with you? Because we have seen picking up the hamstring graft many a time, so we are skipping this live demonstration of hamstring graft pickup. Okay.
Okay.
So I think within few moments we will go intra-articular, then probably we can see the transmission. We thought that we will be picking at the graft before the transmission, but I think you guys finished quite early. Tendon stripper.
Tendon stripper.
Jana, दा stripper दा गोप टप लगा फटाफट लगा. Yeah, so you got to clean कर दे आगे तक pull up. Yeah. So these are really big surgeries, so it usually takes some time to prepare as well. So we know that. So it about graft. दुटो की graft को prepare कर रखा. Camera ये कुछ है. एकदम end button दी कर वो सही से prepare कर वो. जानो तो. हाँ. ऊपर अरे माल साला. चलो ब्लेड डाल दो. Yeah. तो glare करो, glare करो. See,
yeah.
Can you see this?
Yes.
Yeah, so it's
a
very frank. You can see the posterior external is huge.
Yes.
This much, about 90 degrees. It's a complete PLC with PCL. Okay. So high posterolateral portal and TRP set लगाना चाहिए. दाव कोप तो पैसा नहीं लाइट केबल लगाना चाहिए लगी चाहिए लाइट केबल लगाओगे क्या बात है गच piece একটা.
So what is your sequence of operation?
ये सब आवाज आसने ठीक करो ना. So what was the question?
So what is your sequence? First you will do what will you do?
Yeah, first I will do the PCL reconstruction, and then since this is an adjustable loop, not the interference screw, so we will keep a graft. We'll tighten the graft, but we had the option of tightening it further if any problem occurs. Okay, so in case of screw fixation, the screwing PCL graft fixation is usually done at the time of PLC reconstruction as well. So here what we'll do is it's an adjustable loop on the tibial side. So we'll tighten the complete the PCL and then go for the PLC, and after the reconstruction of the PLC, if there is any laxity in the PCL, we will tighten it once again. Does that sounds well?
Yes.
Light was. TRP set the jol da. किधर है? लाइट नहीं है. आसे नहीं. हाँ छेड़ दा. वो दो बार आरे बटे वो छेड़ दा. चलो. TRP set कर दे. निकाल. दा. हाँ. So. ওটা ওই ফিডটা অন করে দাও, আর্থ্রোস্কোপিক ভিউটা অন করে দাও, ওটা দাও। ওটা ওটা নাড়িয়ে না, ওটা নাড়িয়ে থাক, ওটা দেখাবার কিছু নেই, খালি আর্থ্রোস্কোপিটা এখন, ওটা যেরকম ছিল সেরকমই থাক। ওকে, দাঁড়া পেঁয়াজি করে না, ছাত্ররা টি বাটন নিতে বলিনি, ওপেন দেওয়ার যেটা বলেছিলাম লাস্টে আসবে সারা ওপেন টি বাটনটা নেবে, ওটা ওপেনটা খালি লুপ যেটা আছে, ঠিক আছে? আমাকে দেখাবে লুপটা নিয়ে। আরে ওখানে ফুটো করো হয়নি, এখন আসছে না জল। অপবিত্রকে দিয়ে কাজ হবে? পবিত্রকেই লাগবে। এটা লাগি না, চলো। Can you see this interarticular view? So diagnostic, I think you have seen quite a long time. Now we'll straight away move into the interarticular part. Flex it. 90 degree flex karo. Yes. Yeah. So how do we do the white balance? Yeah. Yes. সাকশনটা লাগিয়ে দিয়েছে, এই সাকশন আনো আছে, সাকশন অন নেই। আর ফিক্সড লুপটা নিই না, যেটা 5-10 ডিগ্রি অ্যাডজাস্ট করা যায়। 20টা না, হ্যাঁ 20টা। ওই ব্লেড খারাপ আছে গো, ব্লেড নতুন আছে, ঘুরে যাচ্ছে। Contraction, हाँ, नहीं हाँ। So this is the ACL. Can you see the lax ACL? This one is the ACL. This is PCL, torn PCL, huh? Suction आना देखो। জলটা আর চলছে গো। The ACL looks quite lax, which is expected in these sort of situations. হেভি কাজে রাখে। Yeah, so I think we have a really robust saver, 5.5 saver. This is the intercruciate region. This is the PCL fibers which are intact few. and this is probably the bony fragments, which is completely, turned. Okay, so I will just dissect on this intercruciate zone first. This is how it looks. We usually do the septal portal, both posteromedial and posterolateral. This is the medial side. So I can see it. See, this is the posteromedial corner. Yeah. This is posterior part. This is the septa, which is still intact, I think. We have not dissected. So we'll move on this side and then go to the posteromedial corner here. We'll make a posteromedial portal. Give me a needle. জল কোথায় পড়ছে? ঠিক আছে। এত বড় লাগানো পাঁচটি বাংলা নিডল দিলে। So I'm quite happy with this. Yeah, looks nice. Need blade. Birkona there? Birkona? Yeah. कैनुला दे दिए थे दिए था That's it. So we'll dissect the. So now we'll come to that interseptal area. So this is the posterior capsule and this is the near the PCL. So we'll need to dissect this part. You guys can hear me or
yes,
have
yes.
left the hall?
Home message. So
we are a little low down as well. That's might be reason.
Yeah. That is the main reason.
Yeah, now it's coming.
Yeah. Good. You are in.
Yeah.
2.5 kilo ka haath.
Yeah. I trust on that only.
So 2.5 kilo ka haath.
So this is the posteromedial part. This is the posterolateral part, and this is the area of interest. This is the crater actually where our PCL avulsion took place. This is the crater. Okay. So we'll take the PCL jig first now. This is the crater. So we'll give. I'm going to put this to. Okay. Okay. So this is the entire fibrosis field. So there is no point in cleaning because we are going to make a tunnel. This is the the sample drop-off area. This is the attachment of the capsule. Can you give me a probe? Probe. So this is the capsule we have dissected. This is the posterior part where the popliteus muscle starts. This is the lower border. This is the probe is so small. I need a long probe. This is the sample drop-off area. This is the posterior border, and this is the entire crater. Okay. This is the crater. So we'll try to exit somewhere here. Give me the PCL link. No, এটা বড় কত এটা যাবে না এটা যা ওকে okay okay I will drill it here चलो ऐड करो Chalo. Be careful, huh? Don't drill too much. Chalo. करो हाँ स्टॉप बेर कर खोलो কত আছে ওটা 9 9 করো বন্ধ করা আছে So I think this exit is okay, almost on the lower border of sample drop up, so I think I'm happy. So it should be around 15 millimeter down. হাত আছে তো চিন্তা করছো কেন जी सूत्र रेडी करो একটা ये তো হুক আছে কি বলে স্কুপ আছে স্কুপ রিট্রিভার স্কুপ ধরার জন্য এইটা দিয়ে আচ্ছা ঠিক আছে চলো হ্যাঁ ওটা হলে মিডিয়াল ডিপ দিয়ে যেতাম চলে গেছে this is a sort of protection sleeve go ahead Stop. Take out. Retriever दिया सुतला. उधर দেখতে পাচ্ছি না बेर करना yeah. 4.5 yeah so I think tibial side we are reasonably done okay. So now we'll move on to the femoral side I do still now I am doing the single bundle only I know the Robert Laprat has influenced many people and they have shifted to double bundle. Let me check. I think yeah, this is where I want to go. Our yeah, this suture should go from here. Yeah, intercruciate zone. So I want my graft to come from the intercruciate zone because it's a majority of the anterolateral bundle reconstruction, not here. Well, yeah, so not from the medial femoral condyle and tibia. It should be between the PCL and the ACL here. So that's the only thing I want to give me. Suture retriever dharo. Dharo eta dharo. Loose कर था बस I just wanted to ensure that from where I have taken my graft 8 to 10 रखो तो gent yeah so my graft yeah I think it has gone from here or here it has not gone from here I want to retrieve it. It has gone from here, so I want to retrieve it from there. Yeah, Kolota. It has. I mean, my suture has come from the medial condyle and the PCLs, but I want the suture to come from retriever. Retriever. So I am parking my So I'm parking my retriever in the intercruciate area, then I'm taking my scope to the posterolateral corner and beat suture retriever picture down. আর আছে আর নেই না বিট পিনটা দাও না বিট পিনটা দাও জল শেষ হয়েছে না না ঠিক আছে yeah so you can see this suture here probe the probe ta I can't see my retriever. Where is it? Oh. Yeah. Yes. I think. Hold it. Probe down. Probe it. Okay. Yeah. ওটা কেন ওদিকে চলে যাচ্ছে এটা মিডিয়ালি আনতেই অসুবিধা হচ্ছে আমার রিট্রিভার না হলে হবে না গ্রাস পাচ্ছে হ্যাঁ দাও ওটা গ্রাস পাচ্ছে ভালো জিনিস তো দাঁড়াও না ঠিক আছে ঠিক আছে Yeah, looks fine now. Yeah, now it's in through the intercruciate zone. Now we'll drill the femoral tunnel. I think we'll do another. I think. Let me shift it. Yeah. So this is my reference. This is the trochlear point, and this is the medial arch point. Okay, so this is the zone where the anterolateral bundle attaches. From here to here is the posteromedial bundle. So we'll be mainly doing the anterolateral bundle. So we'll be drilling from here. Yeah, I think. Yes. I think my anteromedial is a little more close to patellar tendon. We'll do an accessory anterolateral portal so that I can target in a better manner. Artery. Artery. Yeah. So I have enlarged it sufficiently, and then we'll retrieve both the sutures through this. Okay. So this is the one suture, femoral one. I have grabbed it. Grab the tibial side as well. Open it. নিচেটা ধরে রাখবে, উপরটা ছেড়ে দেবে। নিচেটা ধরে রাখবে, উপরটা ছেড়ে দেবে। ঠিক আছে? ওদিকে femoral side ধরে, হ্যাঁ ঠিক আছে। ঠিক আছে? Yeah. There was some entanglement was there, so since I am retrieving both the sutures now, I think I am preventing that entanglement. This is very essential. Okay. Now, this is the femoral side, this is the tibial side. First, I will pass the femoral side.
Sir, yeah. Don't you think for PCL, the tibial aperture fixation is better, screw fixation is better than the suspensory fixation?
Yeah, there is no doubt that I think otherwise. Otherwise, I wouldn't have been using this. I do not think that is correct. But there is no doubt that what you are thinking is majority of the people believe like that only. ঠিক আছে? Abhijit? But I really think that it's since the tibial side usually starts quite low down. So the cortical bone is there.
Yes, the fixation of the graft is far distant from the aperture.
Yeah, you want bungee and bungee effect, no? You want to talk about? Yes. The bungee effect is usually not the good quality sutures. I think bungee effect is not that issue. The more of an issue is that the tibial side, the fixation strength of interference screw is far less because the graft is always shorter.
Yes.
Graft is always shorter. So when you put the interference screw, it sometimes pushes the graft, and the graft is actually So no, I think I have flipped it. I'm pulling it down. It's not coming in. So now I'm happy. Now we will pass.
Dr. Sunit, how much is the total length of graft?
Yeah, the total. I didn't measure it. I think it's around 9 centimeter.
9 centimeter.
Yeah.
So you plan to give 2 centimeters in femur?
Yeah.
4 intra-articular and 3 in tibia.
Yeah. Exactly. No, what we have done is we have shortened the graft.
Sir, while passing the graft intra-articularly, especially I feel difficulty in this step. After fixing on the femoral side, I find difficulty in placing the graft intra-articularly for the tibial fixation.
Okay.
Specifically the step you are doing right now.
Yeah, so I think for that, if you follow this step, pass both the graft intra-articularly from the intra-articular side, then that will be good, I think. Okay. Okay, so I usually do not see intra-articular part how it goes. Okay, I just pull it completely without following intra-articular part. But today I will try to see it how it is going. Just a minute. Yes. Now pull it. Pull it completely. Yes. So I think the graft has come in. Can you see this? Yeah. I think it's a remnant preservation issue. Yeah. Turn. ধরো একটু Hmm. Oh shit. It has shortened? Or what? Yeah, I think it has shortened, I think. Yeah, no issue. I think the loop has shortened, so we need to put the T button over these sutures. Ah. Yeah. Yeah, I think.
Sunit sir, Deep
Yes.
here.
Yeah,
Sir,
yeah.
This remnant preserving PCL that we are doing, sir,
Yeah.
are you finding this graft becomes too thick at the femoral side and causes impingement? I felt it sometimes.
Yeah, but you didn't tell me beforehand. Once I passed it after that, I would have listened to you. No. So I think this is the norm. I think this is the ACL, Titan ACL. This is the remnant preservation graft. Usually this is probably because of that bony fragment. It's a little overstuffing is getting filled. This one is the bony fragment. I think I'll try to take it out. Fix it. So I think this is the Titan ACL. You can see. This is the ACL, and this is the graft. And this one is somewhere where the bone is actually. And 2 years old, I think this bone is really difficult to dissect. And because of this bone which is getting inside the interarticular part, it is creating overstepping. Should have dissected it completely beforehand. Yeah. I think I am. Yeah. It is this bone which is creating the problem. I think I did manage to increase the space a little bit. This bone is out. Majority of it. We can see only on the postoperative X-ray that how much of bone we will be able to take it out. This one is still a little bit left. I will try to push it posteriorly and thereby increasing the notch area. Yeah. So now I think we have enough space. Yeah, I think now it looks good. See? Yeah, now it looks good. Some space. Yeah. So we'll accept this and we'll tighten this at the end. Okay? This one. Yeah. Yeah. We'll keep it there and we'll tighten. See, an adjustable loop, I would have tightened the adjustable loop and started doing the PLC. But now what I will do, I have kept it like this, and after just at the time of tightening, I'll start tightening the PCL pass first. Okay? That's it. Light jalida. The intraarticular part is over. And then I think you can use the advantage of that adjustable loop as well. At the end, if I cannot tighten it completely, then I will tighten it on the femoral side a little bit as well. Okay, now comes the laprade. Yeah, hold it like this. Yeah. Okay, this is the fibular head, and this is your lateral epicondyle. And this is your Grady tubercle. So incision will go like this. Blade.
Sir, can we have the extra-articular view on the larger screen?
Yeah, yeah. Now you focus this one, make it large. Royal stack वाला बना दे इसको. हाँ, do the straight. इटा का बड़ा कर दो. So can you see this interarticular part now? This is the Grady tubercle. This is the fibular head. Okay?
Yes,
and in between, my incision will start like this. Okay? So I'll include this one here. Yeah.
Sir, top light টা একটু কমিয়ে দিতে বলতো. Glare হচ্ছে.
Glare হচ্ছে. Forceps দাও না. Forceps, please. Glare টা একটু top light টা কমিয়ে দাও তো. Okay? Now does it look like cadaveric dissection?
একটু বাড়ি দিতে পারেন স্যার, একটু ডার্ক।
না না ঠিক আছে, it's fine, I'm comfortable.
Okay, okay.
After arthroscopy, it feels very clear. So always I do my
Blade.
intraarticular first, then extraarticular.
Deep knife, deep knife.
So if you do extraarticular first, it's very messy. So once you do arthroscopy, then you do extraarticular, you will have very clear field because of the fluid.
So I think large posterior base flap is what is recommended. Can you see this? We will start by dissecting the peroneus, common peroneal nerve. This is the fibular head. The common peroneal nerve will be somewhere here. This is the lower border of the ITB. This is lower border. Okay, so we'll. This is the fibular head. I think somewhere here nerve should be. Yeah. Blade the. Yeah, artery first. Mosquito connector. Yes. सीधे देते 8 and update. I think if you really find interested to find the nerve, I think it's always good to start from the proximal part. এটা নয় বলতে? না এটা না হলে কোনটা হবে? এটাই হতে হবে, ওটাই। Yeah. বাবা সুন্দর দেখেছে। So this is the common peroneal nerve. Okay. So that's it.
So how far down will you dissect? Will you?
Yeah, I think the. Yeah. It a 9. Okay, 9 is better. Yeah, so this is a 9 graft, 9 drill, and then this is where I want my anterolateral. Go ahead, drill. Yeah. Hmm. Ninety correct to Kudi. So we'll do with the 9 graft first for about 20 millimeter, and after that we'll complete it with the 4.5 because 9 is already there inside. Hello. Wait. हाँ चलो हाँ take out. Oh. Depth gauge টা দেবে। diaphragm টা করে নিই তারপর। Yeah. So yeah, so it's roughly it's touching the outer cortex. 40, the 40 is what is our diameter, the length is. We'll measure it with the femoral graft as well. Drill it. Yeah, we have just crossed it, so it should be around 40. Suto, suto, suto. না এটা করলে হবে না চলো yes yeah okay good yeah so around 40 is fine yeah it's okay so build up oh Shiva sorry Shiva so we'll try to take out bolo graft vehicle no ultimate oh sorry hands number 2 is ready yeah chalo so the femoral side is almost I mean the interarticular part PCL is almost done. We'll prepare the graft first and then we'll start again because they have not prepared the graft. So give me some 5 minutes to prepare the graft. डुबी রেখেছো কোনটা গো হ্যাঁ হাতে ডুবিয়ে কেউ রাখে গেল
Hello. Sunita. Since we will be doing laprad also, so any tips to prevent the collision of the tunnels?
Sorry?
Any tips?
Yeah.
Any
so
tips?
For the PCL and laprad, you don't need to worry.
If along with that you are having ACL, that time what precaution you will be taking to prevent the collision of the graft? Collision of the tunnel?
Yes. Usually with ACL I do not do laprad. For the ACL I do modified Larsen where one femoral tunnel.
Okay.
To avoid this graft collision. Okay.
Okay.
Are you getting me?
Yes.
Yeah. So I am not a very big fan where you usually do 3 or 4 tunnel in the femur. For the ACL tunnel one for the LCL and one for the popliteus. 3 tunnels in the femur is I think is a bit too much.
Yes.
So that's why I usually do 2 only. One for the ACL and one for the modified Larsen.
Okay.
Are you getting me?
Yes.
How do you do since you are a laprad fan?
No, it is very difficult. So I
Yeah.
also try to avoid it.
Yeah, just to make life easier, शाम तक फ्री होके बियर पीने लायक टाइम बचा देना चाहिए. ইন্ডো বাটনটা খুলেছে খুলে দেখিনি ঢোকা যাবে কিনা খুলে দাও এর ভেতরে পরে লাগানো যাবে তো फ्री बटन है এটাকে ছোট কি করে করে পিক না ঠিক আছে না এটা উপরে কেন দেবো এটাকে কোন দিক দিয়ে এইখানে যাবে না, হ্যাঁ ঘোরা ঘোরা, টেনে নিচ্ছে এটাকে, হ্যাঁ এটাকে লুজ ছাড়া, হ্যাঁ চলো ঠিক আছে, 20টা साइज है। बटन तो खोलो खोलो, पेन काटा আছে তো, হ্যাঁ ঠিক আছে, এটাই দেখতে চাইছিলাম। Sorry, I'm keeping you in blindfolded because I think I'm just preparing the graft. So we are almost done. पूरी तो ना 25 नहीं चुका, so we are done. 9 को 8 कर दीजिए सर, चलो चलो गाजर, चलो चलो फटाफट चलो चलो। Yeah, so can you see this? Yeah, this is an open loop, okay? This is an open loop. Since we will be passing the graft from intra-articular part, okay, so give me the button. একটা পড়ে গেলে দু চারটে এক্সট্রা আছে তো, দাও বাটনটা দাও। So we will be fixing the one button at the end because we will be passing this graft from the intra-articular part. So that makes this is we will be putting this fixed loop, which also has an adjustability of 5 millimeter. That is the advantage of using this adjustable fixed loop. Okay, this is a 20 millimeter. If at the end of the surgery you think that you need to adjust the graft for another 5 millimeter, you can do it. That is a very good big advantage. So those who are actually fan of the adjustable loop can use it to do the have the benefit of the adjustable loop, and those who are fan of the fixed loop like me can also use it because this will not give way more than 20 millimeter. You have the fixed loop, and at the end of the procedure, if you feel that your graft is a little lax, you can tighten it by 5 millimeter. So then 20 will become 15. So that is a really good loop which you can try. Indian company have बनाया, make in India, Modi का भी support है, सबका support है, and it's a really good part as well. So the other thing is and this one is the open loop because I will be passing the graft from intra-articular part. The biggest problem with the PCL is passing that avoiding that killer turn, passing the graft from the tibial side and then taking everything graft. So the best thing is you pass the graft from the intra-articular part. This one will go to the femur directly and this one will go to tibia directly. For that you don't need any implant. If you have a the large button, then you can't pass it. So instead you have a cut end button like this. At the end of the procedure, once the tibia is gone, I will put the button like this. Okay, we'll show that at the time of tibial passing as well. So that is the whole idea. The graft is really robust graft, peroneus, quadruple. Give me 9.5 millimeter graft. Okay.
Okay.
Yeah. So we'll be passing the graft both from the anteromedial part. The blade, retriever the. So we'll be increasing this, the loop, blade. So we'll be increasing this port, anterolateral port a little more, so that my graft, 9 mm graft, passes very easily on both the sides. Artery and retriever.